Shahid, the program officer, Japago.
Hi, I'm Chitra from Astrika Foundation. I'm the Associate Director there.
Astrika Foundation.
We are into maternal health and to skill building.
I am Anushaka. I'm also from Astrika Foundation.
Your background is also.
No, so I had the advocacy and communications at Astrika Foundation.
Good morning, everyone. Ravneet from the evidence team of Swasti.
Hello, good morning. I'm Endang from Ministry of Health, Indonesia.
Hi, good morning. I'm Dr. Shikha Bhasin from Center for Catalyzing Change.
Hi.
She will give you the background of what we do.
My name is Tina. Tina Ravi. I work with Center for Catalyzing Change, and we work on maternal health, adolescent health, youth. We have a diversified portfolio. Thanks.
I attended your session yesterday.
Yesterday, I know. Good morning. I'm a second year MBBS student. Yeah. Okay. So, one, two, three, four. You four of you can be in a group. Yes. We'll have a lot of discussions because the workshop is all about understanding the concept and it's not going to be one to one. So we'll be exploring some maps and we'll have some discussion and that's how it goes. So you four of you in our team. You can join whichever team you like. So come over here, please. You can just rotate your chairs. Later, now we'll have few slides after that. Otherwise. This team here, please. Yeah. Yeah, somewhere in the front. That would be better. Comfortable ones.
We will have a presentation now. How will they just like?
Yeah, you can turn your chairs until the presentation is done. Yeah. Otherwise, you'll not be able to see the slides, and later you can change. Thanks. One, two, three. So can you three be in a group, please? Sorry, there are two new people. Yeah. You can come here, you three of you. So we'll have three groups. Anju ma'am. Yes.
Thank you. Good morning, everyone. Myself, Dr. Komal Shah, Associate Professor at Indian Institute of Public Health, Gandhinagar. I'll be moderating today's session. And today's session is all related to evidence and gap map in the field of maternal and neonatal health. So the session will be chaired by Professor Anju Sinha, and she is co-chair Cochrane India Network. She is member of Cochrane Neonatal ARI and Rapid Review Groups, member of Cochrane Trainers Group. Ma'am has been working extensively in the field of evidence synthesis and generating evidence-supported guidelines. Her work in the anemia prevention control group is phenomenal. So we welcome you, ma'am, for this particular session, and I would invite ma'am to come on the front side. Then we have two of our speaker on board who are from Campbell, South Asia. So first we have Dr. Bhumika TV with us, who is Director General Campbell, South Asia, with more than 7 years of experience in evidence synthesis. She has previously held the position of Assistant Professor and Coordinator of Public Health Evidence South Asia at PSPH, MAHE. She has also been a co-director of Cochrane, MAHE affiliating. It's not working. She is actually Director Research at Campbell South Asia. She is also working extensively in the field of evidence gap map, evidence synthesis. She held multiple numerous positions. She has extensive work in the field of immunization. She had previously worked with 3AI, and now she will be teaching us some of the evidence gap map related hands-on exercises today. So I welcome her also on board. And with this, I request Anju ma'am, chair of this session, to orient all of us with the Cochrane's activity, and then we can slowly move ahead with the sessions. Thank you.
I think now, can you hear me? I think it's working. Yeah. So very warm welcome and good morning to all of you. I am sure all of you are very much interested in evidence-based medicine. That's how you are all here. So may I ask if you have done any systematic reviews or you know anything about evidence synthesis and what are the kinds of synthesis? Anybody aware about the subject of or any experience of prior exposure to any other workshops? Okay, so in India, in which institution? Okay, good. Anybody else? Yes? At? Okay, and you worked on a systematic review? That's good to know. Okay. So I'll be introducing you to what Cochrane India Network is about. So you have heard about the Cochrane Central, which is based in London, and it has a network in 130 countries. And systematic reviews produced by Cochrane are considered the gold standard in evidence-based medicine. So we started this Cochrane India Network in 2021 after a meeting that was held in 2020 in February. We used to have a Cochrane Center in Vellore CMC, but that was the only center in India. So Cochrane decided that we should have a network in India. So 9 network affiliate centers are there in India at present. They are all in academic institutions such as All India Institute of Medical Sciences, PGI Chandigarh, CMC Vellore, Indian Council of Medical Research, MAHE, Manipal, and Dental Institute at SOA University Bhubaneswar, and also in KGMU Lucknow, and IIPH Hyderabad. So all of these are part of our network, and we have been given a mandate by Cochrane to promote Cochrane's work, disseminate Cochrane systematic reviews, and also to build capacity. So capacity building is one of our major work that we do. So we do workshops to provide, hand-holding and training to people who are interested in systematic reviews. So today's session, which is on evidence and gap maps, is also one of the ways how evidence is synthesized. In a systematic review, you do, which is a secondary research, and you have to have a protocol, and you have to form your, keywords and PICOs, and you have to write everything in detail in the protocol. The same way in EGM also, you follow the same processes. The only difference is that you do not synthesize the evidence, like in a systematic review. When you complete data extraction, you go to analyze your data and produce forest plots. Here is a difference that evidence in gap map, you just stop after doing the screening and selecting studies and extracting data. Then you come to there is another software to produce a gap map, which is a visual interpretation of the evidence. So you get a grid, like a picture, in which you have interventions and outcomes all plotted in the form of bubble plots. So these bubbles indicate by their size the kind of evidence which is there. When you click on the bubbles, you get the information about all the studies that exist in that area. So which is very informative, and it's kind of a dashboard, and it is very informative to policymakers. So what I find very interesting is it can be a tool for use by funding agencies when they want to advertise for call for proposals in different areas. So they will come to know where is the area where we have gap, and we can produce more evidence which is needed. So we can, then call for proposals to identify primary studies and fund the primary studies to produce evidence. So it is a tool in itself. So that's what I wanted to tell you about evidence and gap map. And let's proceed.
So now our first speaker, Dr. Bhumika, will start with the session. So yeah, inviting her.
वाईफाई के लिए पूछा Thank you very much, Anju ma'am, for coordinating this event with Campbell South Asia. So Campbell, just to have a brief introduction about Campbell South Asia. Like Cochrane, so Campbell Collaboration is a global organization working in the area of evidence-informed policy decision, and we are Campbell South Asia. So we do similar work, that is to carry out evidence synthesis projects which are more pertaining to low and middle income country issues. The difference is that Cochrane works on health and clinical issues, and whereas Campbell focuses on public health and social sectors. So that is a difference. And so at Campbell, we mostly work on evidence synthesis products along with systematic reviews. We also work on evidence and gap maps. And also we prepare knowledge translation products like evidence portals and policy briefs and policy toolkits, which are readily available for the policymakers or the community to use the message on a particular topic. So today we decided that we will show you all how this evidence and gap map actually works. So it's theoretically, it's more like the steps are similar to that of systematic review. But if you're new to systematic review, we'll still take you through the steps. But here we do not synthesize the data. Here we will only show what sort of evidence or studies are available in that particular sector. So that come. So it's a systematic representation of all available relevant evidence for a particular sector or a subsector. And it tells us what evidence is there and not what the evidence says. So this is the difference between a systematic review and a map. So here in systematic review, we synthesize, we collate the information from all the primary studies, and we say what the result says actually, whether that intervention is working or whether that intervention is not working. But in map, we say what is the available evidence on that and where there is no evidence on the studies. Again, it is systematic, so we will have a protocol. You will have to register that protocol either in Prospero or Open Science Framework or in Cochrane database or Campbell database. And then we will have a systematic search strategy. And then we also have to specify clear inclusion and exclusion criteria, because what studies goes into that map is very important, because we cannot have all the studies going into the map and clutter that, and that will actually mess up the map. So we'll have to have clear inclusion and exclusion criteria, and systematically we'll have to report all the eligible studies. And we have range of evidence synthesis products in the maps itself. So like I said, the first one is systematic review, where it collates all the primary study data. And then we have review of reviews, that is in systematic review itself. So we will review the different systematic reviews, and that's called as overview of reviews. And then comes evidence and gap map, where we will actually map systematic reviews and primary studies all together. And then we also have mega map. In this mega map, we will accumulate all the systematic reviews and e-GEMs on a single platform on that particular topic. And then we have map of maps. Here we will only collate all the evidence and gap maps on that particular topic. So it depends upon what kind of product you want. It depends upon the scope of the funders or the researchers, that what do I want to learn from this particular aspect or on this particular theme. So this is how the map looks like. So when we do this group activity, so I will share that link with all of you, and then you can just open that map and try accessing that. So here if you look at the columns, you see this intervention. So it's health, and then we have different sub-themes under health. What is promotion, prevention, rehabilitation and medical care. And if you look at the rows, it's all about outcomes. Under health, again, mental health, cognitive development. So under promotional interventions, what studies have looked into mental health and cognitive development are the studies that are accumulated in that first box. So, and also we have different color coding. If you see yellow, red, green and blue. So this indicates different things. So, and yeah, I forgot to mention that when we do a map, we will also do critical appraisal of the systematic reviews only, but doing critical appraisal of all the primary studies that goes into will be a hassle and it's going to be difficult. So here we use a scale called AMSTAR to assess the quality and the critical appraisal. Then we categorize the studies into low, medium and high quality, and based on that the bubbles also indicate whether the studies that are there in under that bubble they are of low quality or medium or of high quality, and that's how the studies get categorized. And similarly, based on that promotion intervention, what are the studies that are available on access to health services, then immunization, then health checkup and rehabilitation. So if you look at access to assistive devices, so there's nothing there. So that box is empty. So that indicates that there's no research that has been carried out in that particular area, and this is where we need to fund, or the researchers need to take up, because this is the area that needs to be explored. So, and how do we come up with these themes and sub-themes? That might be your other question. So this is basically we create this framework at the protocol stage, what goes into our intervention category and the outcome category. And then we are going to decide with the stakeholders. So as you all know that it's important to engage the stakeholders in all your projects. And then we'll discuss what is important. For example, this topic was on disability, and then we thought about health. So these were the outcomes that we thought are very important. There are a lot of others, because this is a screen shot, so I couldn't capture, but then when you explore this map, you'll get to know about the other themes and all of that. So this themes and sub-themes, all of this will be predetermined by the team itself. And then we see, okay, where are the studies that are available and where it is not. And also if you see, we have low quality review and high quality review, and then we can also see that in which of the sector the reviews are of low quality and high quality, and if it's of low quality, then we can think of doing another study in that particular area. And what if we have a lot of high quality reviews already there? So then you can collate the information from all that high quality reviews, and then you can prepare your policy briefs or the knowledge translation material from those high quality reviews. So this map has lot of utility that ways in research. This is another example, that is interventions for reducing violence against children in LMICs. This project we did it in collaboration with UNICEF Office of Research in Ochenti. So it was again in a similar way that it had different interventions and outcomes which was predetermined by us. And then, as I said, the mega map. So mega map includes only evidence and gap maps that would have been carried out in that particular sector. So this was again carried out for UNICEF, where we looked at only evidence and gap maps. So this map shows the coverage of 475 systematic reviews and 25 evidence and gap maps and specific rapid reviews. And they identified 153 additional reviews and maps. Then your question might be again, when do we update this map? So typically every map we'll have to quickly update. 6 months is minimum, and within 1 year you'll have to keep updating the map, because the newer studies always emerge. And the softwares that we use for this is EpiReviewer, and we also have EpiMapper. So we carry out all of this data management and everything under EpiReviewer, and then there is a file called JSON file. We create that file, and then we use that file to create map on the EpiMapper. So that activity also probably will be doing. Otherwise, we'll show it on as per the steps on how to create that map. So now, if you all can sit in the group, so I'll share a link on your email IDs. So you can just open that link, and then look at the maps and you can ask. So each team can come up with 3 or 4 questions that I would like to answer on the map, that what you feel, what you did not understand looking at that map. So can first group be here? So we already formed the groups. I'm sorry for the late ones.
Can you just, how does she?
So we can have 4 groups.
Okay. If they can just open this link.
Okay, you can sit, you all can sit together and join. So you can join them. So 5 in that team, 5 here and 5 here. Yeah, can you please come? Can you please type this link on your phones and just open this?
You will say Mega Map?
Mega Man. But no, you just type this because we want to give this particular map. It's on child well-being. So
It's like Mega Map, UNICEF.
Mega Map UNICEF on child well-being. Child well-being. Child well-being. Health and child. You got this? I think. Yeah, this is the one. She got it. What did? Okay. Yeah. Yeah, that one. Yeah, that one. So you just have to get that map. So can you please use this link itself, because it will directly take you to the map. Otherwise, it will take you to the report. Then you'll have to search for the map. Yeah, that's the one. Yes. Yes, this is the one. So, but this doesn't have this map. So that, can you please take out that link itself? You can go on Google Lens and just. Did you all get the map? No, that's not the one. No, you did not put that link. On Google Lens, can you just capture that? It will directly take you to. I think it's the correct one.
Did they have internet here?
Yeah, I asked him to connect.
Then we can show it here.
Yeah,
Just
sure.
wait. Can you
No, it will directly go, no? Just see. This This is the right link, so this is what you'll have to get it.
I think so now we can see it here. See, this is the one.
So now you can start exploring. You can click on those bubbles, go to the studies, and see what are the different themes and sub-themes. And if you have any questions on this, you can come up with 2 or 3 questions from each team, and please ask me. You can also note down what actually you see. So like you see 4 different colored bubbles. Then there are small bubbles, there are big bubbles. And yeah, you can also see what are those filters. So you just explore and try to understand. Are you able to get it, all of you? So if you scroll down, you can see different themes, health and nutrition. On education, and if you scroll towards your right, you can see the other outcomes. Learning and development outcomes, risk factor reduction. If you see here, so on maternal smoking and education. Yes. So you can put a filter as well, but this you will have to categorize. You should have earlier carried out country-wise coding on EpiReviewer, otherwise you'll not be able to add that filter here. Study. Exactly. Yes, yeah. Yes. So in this map, we have mapped systematic reviews and evidence and gap maps. So in another map, you can also see primary studies and systematic reviews. So it depends upon you what you would want to have in the map. No results, yeah. The results also, if you go to that study, you will get to see the results. But we will not synthesize the results, yeah. Not any of the evidence and gap map, which will not actually synthesize the results.
On what priority, like how is this enlisted? Like which one will come first and which one will come second? Is there some like the sequence? Does it have any logic?
I don't think so. There's any logical reason on what study, how it comes. It depends upon how the data is captured.
Yeah, but basically, if you really look into the sequence of the studies, it's alphabetically because that's how software takes it. So the name of the author is like how the second name of the author, the alphabetical come. But the sequence of this framework, the intervention category, subcategories also depend what is the main intervention category that you're looking at, and in terms of the outcome, what was your primary outcomes and secondary outcomes.
AMSTAR, we have this tool that we use for assessing systematic review. That's a critical appraisal tool. Yes. We predetermine the intervention categories, themes, sub-themes, and also the outcomes. So this we will have a discussion and then we predetermine with the stakeholder engagement. No, this is basically for us to understand. So there's no point in revising because we want to know where there's gap and where there are studies. So. No, we can't add that in the later stage because it's a process of screening and coding. Later, if we add, then we cannot code them under those headings. So we will, yeah. And then we look at this. No, yeah. Fill in with the studies, there is a process that Suchi will take it forward. So how do we go through that process and then how do we get this map? Yes. As I said, it's we carry out critical appraisal for all the studies that goes into. We do not do it for primary studies in general when we carry out an evidence and gap map. It's for systematic reviews unless and until the funders insist that we need to have this critical appraisal carried out for primary studies. We will not. But for all the systematic reviews, we generally do it. So based on that tool, in EpiReviewer itself, we will actually, there are certain categories under that critical appraisal tool. We categorize the studies based on that. And then that automatically get captured under low, high, medium categories. So got an idea about the map? Yeah. Okay, now we'll get into the steps, how to get to this map.
Yeah. So as we, I think so I stand here. So we explore the EGM and then now I will be talking about how actually we formulate the research question, which answers some of the question that you have, like how you come up with the framework. Like that's the very important steps, and that because we have everything aligned, we actually do a lot of planning before coming up with the framework. There are a lot of stakeholders involved. So how that steps come, so I will cover in that session, and then we can also like talk about like any queries that you have. So first thing that's very important when we say about like how we develop the EGM, what are the main steps? The first step comes in setting framework, like we actually set the framework. So if you really looked into any EGM that we worked on, like for reviews, you have a different thing, like you really looked into research questions, but when it's talking about evidence and gap map, we really sets our framework first. What framework are we looking at and which framework we are? When we have this framework setting up, which kind of interventions are we looking at? As I said, there were like a primary intervention that you're looking at. So if I'm looking at any map on like on prevention of children who are at risk to reduce violence. So for me, my primary intervention should be child-centered. And then I will have a secondary intervention which will look into the other caregivers, parents, and then community-related interventions. So then that's how you categorize it and you make your framework like that. Same with the outcomes. If my primary outcome is to look into the reduce in violence or actually to improve the health, so all the outcome which is related to health, we will have those as primary outcomes. So my framework is set first. So when you finalize your framework, there are a lot of stakeholder consultation happens. When I say stakeholders, for every EGM and reviews that we worked on, we actually have a lot of stakeholders advisory group meetings. what the advisory group meeting involved the funders, practitioners, researchers, subject expert in those areas. So they come together and then we actually display this is the framework so that we don't miss it. So just an example, I was working on the sports interventions. So when we are thinking of sports interventions, we say what kind of intervention, then we line up all the sports programs that's there, like which is like a very structured sports program for children who are at risk so that they don't do reoffending. So we did this framework planning, we did all the sports, we also had sports plus programs. Sports plus program means with sports you also give a lot of rehabilitation programs to those kids, education, job training, and also make sure that they went into employment. So we had this as a framework for our reviews. Then we have a stakeholders. So there were a lot of organizations working with girls who are at risk. So that you also add physical as well. So dance were added to it, yoga was added to it. So these are also the intervention which actually helps. So we actually have these lot of stakeholders consultation. We added the age group till 18. They said no, there is a age, the crime age curve is also after 18 you see a lot of crimes happen. So they asked us to make it age till 25. So why this stakeholders consultation? When you say framework, these stakeholder consultations are very much important. For one of the program that we like neonatal one that we are starting working on, maternal and child EGM, we have a stakeholder consultations. What areas that we can work on, like which, like neonatal mobility, neonatal maternal health. So we have a lot of stakeholders, what area needs to be done and which kind of intervention are we looking at. I will also share the example of it, but that's very important. Then you have like title and scope. As Bhumika said, there is an inclusion and exclusion criteria. So we have a very clear scope before starting. So we will not go back because we have a laid down scopes. And very important, if we don't find any studies, that is also a finding. That based on our scoping, we could not able to find any study on that area. So this is one of the area that researchers can take up. So if a PhD scholar really wants to work on it, they can see this is the area where I can do research. This is the area funding organization can actually fund for research. This is the area we have a lot of evidence available, but the quality is not very good. So like how we can actually ensure that the quality of the evidence is there. This is the area where we have a lot of interventions and it's very effective. Then the implementing organization can think these interventions are very effective to improve maternal health, to improve child health. These areas are very much important. So that's like how. And then we have this PICO. I will talk about it. Then searching and screening. Like it's a very systematic process that we follow in EGM. We have a very good, like searching, what kind of databases we will search. It's also depends the areas that you're working on. And then which kind of grey literature we look into, the journals that we are looking at, dissertations, journal search. We also use AI for searching it. So that is a very important step. And then we also code. So when we code, we also have a very important filters, right? You were talking about the countries. So we, in our coding tool, in our data extraction, we are very clearly saying what really wants to kind of filters that we want to use. So if you have a very different target groups, even though to child, so you have a different age groups, do you really wants to filter it? If you also have maternal, like maternal health, parents, teachers, lot of care, like community health workers. So if you have that, you also filter it based on that. So that is very important. And then the next step that you all talk about, the colors of the bubbles, critical appraisals. So we appraise every studies. To appraise the systematic review, you use AMSTAR. To appraise individual studies, there are a lot of tools which is available. There are like SHORE, RCT tools, like if you have a RCTs, there's also Campbell tool, Campbell collaboration tool also to appraise the studies. Also the qualitative process evaluation and also the impact evaluation, effectiveness, cause experimental studies. And then also we design maps and then we also report it. So these are the steps that we follow. So let's talk about the first step. So how we actually come up with the research question, and that's how we come up. So you have a general idea. So if really wants to, like everyone is from different backgrounds. So what, like if you really looked into, I really want to look into maternal health or child health. So that's like a general idea, what you really want to. So the same way, like if you really want to look into agriculture input subsidies, that's like what is the potential idea that you wants to look into. Or an intervention which like I want to look with children at risk or conflict atrocities. So they are like many areas, like what is the general idea that you have. Then what you come up, maybe is these, what kind of interventions are effective. So I really want to look into any intervention that is very effective in improving the immunization coverage or reducing the neonatal mobility, or you really want to improve the child health, like what kind of intervention. So you come up with that, like a very interest, like what is the interest area that you really want to look into. Do you really want to look into intervention which is very effective in reducing or improving? That's kind of interest area that you come up. Or so any intervention that you really want to look into, if that is very improve the economic condition or health conditions. So that is like how you come up. And then you have this very tentative review questions. How that review question is also like, what is the target area that you look into and what is the actual result that you're really. So your review question is like talking about the interventions, talking about the target areas, and then it's also talk what you really wants to reduce. So the outcome that you're looking at. As I said, well-formulated research questions helps you in all the steps that you have laid down in your EGM. So if you have it helps you in research strategies. So if you have a very important lay down research question, it helps me what I really want to search on. So if I'm only focusing on immunization, my search should be very much focused on what all immunization thing. Like, so I'm looking at immunization coverage. I will make sure that the intervention that I'm looking at should focus on the community interventions. So that's like, it's very important what inclusion exclusion criteria. It's like there will be gray areas, like a scoping of it. So did I cover this? Like, do I really want to have an intervention which is like focus on parents or caregiver? Like, if I'm looking at breastfeeding, obviously the woman. Do I also have to look at any intervention which is community led? Like, so that we are really clear, like what we really want to, like only the awareness part of it, like all the intervention which is like awareness led, so that's like data extractions, the synthesis method that you really want to look, and the presentation dissemination of findings. As I was saying, that when we're setting the context, the advisory group plays a very important role, because then you can also act like this review will be useful, this EGM, like that's like scoping will be useful for it. What all intervention that I should be included, I'm missing it. Any population, any subgroup that you think can be included, if the areas that. So any, like if you are really focusing on working on one area, you can also see what all subgroups, subpopulation that have an influence on it. So when I looked into population, I also look into the subpopulation that have an influence on it. That to be included. So as I was saying, there's a term which is very much used on reviews and also in EGM, which is PICOS. And that is for effectiveness. Like when we look into the effectiveness of studies, what I meant by PICOS is like population, then the interventions. If you really look into the framework, it's talking about the intervention. Then also the comparison. So active or passive comparison, like we also look into comparison, and then is outcome and the study design. So outcome, what kind of outcome that we are looking at? Study design, are you only looking at the process? Like if you really wants to have a qualitative, so there are EGMs which also talk about the barriers and facilitation. We did one for Center for Homelessness. What we did, we also map all the barriers and facilitators for homelessness. And then we also have a EGM on effectiveness studies, which talk about what kind of intervention which is very effective. So when I talk about study design, it's also, are we looking at the intervention studies, like experimental, quasi-experimental, qualitative, and it's also depend the scope. So if you are looking at maps of maps, then you will also have EGMs included. In EGM, you are like systematic reviews. So what is the scope or study design that you really want to look into? You will also define that in that stage. So very important, what is like a relevant population that you're really looking at. So if you're looking at welfare recipients, teenage, crime victims, disadvantaged, like what child health, women's health, gerontology, elderly people, which areas you are working on, what is the population that you're working on, and the age group that you're working on, or also are you looking at from the gender lens? Are you also looking at from an inclusion lens, disability? So then you also have the population like that in mind. Yes, I also look into the gender lens. So I also have like female, like I will also include papers which is talking about the female, or specific. See, I'm looking at child health, but then I also want to look into the inclusion. So I also look into disadvantaged population as well in the child health. And then you also like, so that's like very clear what kind of population that you're looking at and also what kind of subgroup that you're looking at. And that's you defined it in this stage, like what is my population. Okay, when we say place, this is also a area where you also look into the scope. So are you looking at Southeast Asia, region? Like what region? LMIC countries? Or it's a global EGM? Because the scope should be like if you're looking at the global evidence on it. It's like when you're mapping it, you really want to look into the global evidence. So we did one for Youth Endowment Fund, which is on child, like preventing children's getting into violence. That was a global. We got 2,000 studies which talk about all the intervention which actually helps prevent children to get into. So that is also, this is the where you actually also scope the population. Second, the clear interventions. So when we say interventions, it's also there like, are you looking at the branded programs, midday meal schemes, immunization, universal immunization program, like any schemes that you are looking at, so you have a branded schemes in mind, plus also all the interventions which is like community led, any traditional intervention, inherent indigenous interventions also happening in the community for such a long time. You also want to capture those interventions as well when you're looking at. So these are what kind of like, if are you only thinking of children's or children's with families also. So any intervention which is family leads, which is also giving to very much health focus visit, like if what kind of intervention is given into health settings, what kind of intervention is given in the community settings. So all these things you have to be very much planned, like where is my scope and which like, so you will get a very clear idea from the population, you will get a clear idea from the intervention that you really wants to focus on. And then you like, as I saying, like comparison actually helps you when you really wants to compare. So intervention is given to like if it's the active comparison or a passive control, that's like a comparison group you also identify. And then there's also a specific outcomes that you're looking at. When I say outcome, it's also depend, when I say when you're thinking about the potential idea. So what are you actually looking at? What kind of outcome that you really wants to look into? So if it's disease control, disease prevention, or rehabilitation, or are you just focusing on whole like the prevention strategies and also like treatment strategies and the rehabilitation on it. So if you're looking at that compass, then your outcome should also be focusing on all the areas. So that's how your outcome should be. Like if like I want to prevent disease, and then like that's like the prevalence of the disease, then like number of people who are like, so that's how my outcome will also, like what is the main outcome that we're looking at. Yeah, so these are like also depend, like if you're only looking at the psycho well-beings. So we are looking at the well-being also, like if you're only looking at the health outcomes, or you're also looking at psychosocial economic outcomes as well. Like so there are maps which also talk, even though the child well-being maps, so there are also child-centered outcome that you look into. Also you look into the financial, psychosocial, social outcomes. And the study design I have explained, like are you only focusing on RCTs or like causa experimental, if you are looking at only effectiveness, or also you are looking at the qualitative aspects to it. So then you also have a qualitative papers included in. You also want to include all the reviews, then also EGM. So it's all depend the scope. If I only wants to focus on the like quant information, quantitative studies, then my focus is only looking at the impact evaluations, plus the RCT and the causa experimental. When we have this research question, it's very, as I said, when you define your PCOS, that is the main exercise that you do, which helps you to develop your framework. When you have that very much clearly defined PCOS, that's how you actually define your, so how whenever we write the research title, it should be what intervention. If you look into this structure, you will understand how I really wants to fit into. So the intervention is like what intervention are, like child-centered interventions, like transport intervention. I worked on one of the map which is on transport. If you really looked into transport, yes, but it's all the interventions related to transport infrastructure, how actually helps into women's health, health, access to health, then also like economic, then social psychology, just like how this infrastructure, just a transport actually have lot of outcomes that we achieve. So that's like the what kind of intervention that you're looking at, what it's like, it's improve, what really wants to make the change. So it's improve, reduce or increase. If I want to increase the immunization coverage, if I want to increase like economic of the smallholder farmers, what I really want to improve, what I really want to reduce children's to be involved into violence, reduce children's mortality, morbidity. I really want to have these. So what really want to look into? Then you compare it to other interventions, and then you really define the population. Children in LMICs, youth in LMICs, then maternal like in LMICs. And then or maybe like you are looking at women who are like breastfeeding, so like just define your population, and then you say it's like it's a EGM or a systematic review. So this is, I think so we had this like I will be just sharing some of the examples which you can actually help you to understand how we define it. So intervention for reducing violence against children, and EGM. Yes, so anyone can tell what's the interventions here with this title?
Reducing violence against children. Interventions terminology is
Okay. Reducing violence against children is like, or reducing violence is something that is like the outcome that you're looking at. Yeah, it's an evidence and gap act, yes, it's a EGM. So I'm sharing EGM example. Our reviews have like, it's a mixed method review or a systematic review. Mixed method means both qualitative aspects to also children. As I said, like, so for populationless children here, and then that to LMIC. So we define the population children in LMIC, and then we have all the interventions. Any interventions that actually helps to reduce it. So that's like all the intervention, that's because the scope. Then
Any
obviously,
example on that?
huh?
Ask them to give an example on reducing the.
Yeah, we'll take this numerator. Okay.
No, no. What? Can anyone give an example of an intervention for reducing violence?
Reducing violence. Any example of the intervention?
Yeah.
Counseling of parents, yes. So these are parents' intervention, like.
That's just an example, but you can also give 2-3 examples.
Yeah, so I think so parents, anyone also wants to add on to any interventions?
I'll give an example from Karnataka. Government of Karnataka has one, not implemented well, but they call it Kavali Samiti. Kavali Samiti is the subcommittee of Gram Panchayat. So it's a community driven thing. So Kavali Samiti, I also don't know the exact meaning of the Kannada word. So Kavali Samiti is a Gram Panchayat has, the Panchayat system has subcommittees. It's not working well. But am I audible? Yes. Yeah, so these Kavali Samitis, they are supposed to meet together, and it's a redressal forum. So they need to address this within the community. So this is one intervention. This is I mean, it's a structured intervention, should be implemented well, but I mean, there are gaps in that. One example.
Yeah.
Intervention could be making children aware and train them what to do when teach them what are the what can be violence, how different kind of violence can be, and where to report. That can be one kind of intervention awareness.
For example, just my friend mentioned a healthy child panchayat theme, which is adopted by the PRI members. This is one example. Working with the abandoned child is another example.
I think intervention might be also in the term of making some groups among the, interlinking the departments working towards children.
Yeah, so if I really, for this map also, if I compartmentalized what you said, so they are intervention which is child-centered. So awareness to the children, they are child-centered. They are also interventions related to parents. And then they're like parents-related interventions. community related interventions, then also systems related interventions, and then legal. So they are like intervention which is very focused on legal systems and systems in place. And then when we say systems in place, any intervention which also happen in the school settings, irrespective for this. So that's how the interventions, that's like every intervention that you think on this area. And then the out.
Interventions are categorized under themes and subthemes.
Yeah. And if you really look into these interventions, the way we, and that's why like when we brainstorm it as a group, see a lot of, you have named it. That's why when we just do this frameworking, we just like what all intervention can come. And then we grouped it. Which intervention, like in which primary intervention that I really want to look into. Child center, then the community. Are we also looking at the systems interventions? Then all the systems that can actually have this play roles, legal interventions. There's also one, then a second example, which is on any interventions for people with disability in LMIC countries. Any example anyone wants to say about this? Yeah. 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 So basically, if you really look into in this one, the EGM, the outcome was overall well-being. Like, yes. So next, it's a overall well-being that you look into. So it's all the intervention which with people with disabilities. That was here in this EGM. Sometimes when we look into the EGMs, we really want to scope. Our scope is to map all the evidence that is available. How we define in this case effectiveness. So basically all the intervention which is effective, the intervention which is actually looking at the effects of that interventions in reducing whichever outcome that you're looking.
No, we do not define
it.
Defined by the
Primary studies.
They're only collating like
Evidence.
No, but if you're collating, then why is the definition effectiveness of interventions? Because then you're saying then it should be just interventions for disability.
No. So just to give you one thing, when we say effectiveness of interventions, we are actually very strategically looking at the studies, primary studies who looked into the effect of that intervention. Not the interventions as like, so if it's any interventions. Yeah, impactive. Yeah, positive or negative. Yeah, so but then when we look into the positive and negative, if you really look into, that's the one step that you look into in a review, that you really want to see the direction of effects. So that's like beyond EGM thing. But like even though now the EGM have been using these kind of platform where in the map also you can see the effects. So that is like the EGM new development. It's a EGM which map it, and then when you look into the map also give you the summaries, the cell summaries, is this intervention is effective or not. That is also a new addition to EGM that we did it with the recent work that we did with the portal thing. So as we're saying, there was like population with people with disability. Here also we said about LMICs, and when we talk about the interventions, we said all the intervention which is looking at the welfare of people with disabilities. So all the intervention which is in looking at the welfare of, and then it's actually based on the WHO's community-based rehabilitation matrix. So health, livelihood, social, employment, empowerment. And that's how, when we define the framework, that is also very important that if there is already an existing framework, and then you can actually use that framework for how you can use that framework which is already existing to looking at to improve the well-being of the disabled or to improve the well-being of the children. So if you already have a framework, you can actually use that framework and make it scope based on your EGM. So there was no comparison to it, like any for this one. And then when it looked into well-being, as I was saying, outcomes, because it was, the scope was big, then we defined the PICOs. So well-being, we looked into all the aspects of health, livelihood, social, employment, empowerment. And then the study design, we looked into all the experimental and non-experimental studies, which look into only the effectiveness. So when we also look into inclusion exclusion criteria, we make sure that the studies is looking at the effectiveness of the interventions. Because that's the role. Even though if you're looking at the prevalence, then your EGM will have a different scopes altogether. So it's also depend what's the scope that you're looking at. So this is one of so we had this with Cochrane India that we're thinking of intervention for reducing the neonatal mortality and evidence and gap map. So what is the population, if anyone can say, what's the population if you understand? Okay. Okay. Pregnant women. Healthcare providers. Okay.
Even adolescents for that matter, because of the early marriage thing. So if you are looking at, for example, anemia, it's also one of the factors of your NNM or IMR. So you would also want to catch them early. So maybe one of those interventions was only focusing on adolescents.
Antenatal care.
When you ask for population in this, I think that was your question.
Yeah,
so I think we are distracting, and there's a big rabbit hole if we'll try to include, and we'll get lost while doing the gap map, or we'll search for evidence if we'll include all the age groups, adolescent, and very specific to the question you asked.
Yeah.
So I have that doubt. How far is too far?
Yeah, so I answer these questions, but let's see what's they will think of. I will answer this for sure.
Intervention might also be in terms of looking into the supply chain and the
supply
logistics management.
Logistic management as an intervention. Okay.
We can highlight, for example, ASHA worker, a frontline worker who is mobilizing for institutional delivery. Then we can labor room in charge and labor room staff nurses. Then we can say SNCU in charge and SNCU service provider, and definitely mother and unit.
Population here, I think we can restrict it to neonates, and the interventions we can look into these domains. So
Okay. Yeah, he wants to add something. Yeah, please.
No, it's okay. So
Yeah.
on here, the problem is, can't we just avoid the population and just focus on the outcome here? So see, your interventions can be community based, your interventions can be system based. So there may be many population. You can go to the provider, you can go to the community, you can go to the even there are interventions who are talking about preconception care. They are not yet mothers, but if you give proper intervention, that might improve their anemia levels. They might go into better pregnancies. So my question is, why are we thinking of population here, not the outcome? So if I have to do the evidence gap thing, won't I look into all the outcomes which are focusing on neonatal mortality and look into whatever populations they have worked into, unless you have an inclusion or exclusion criteria specific to what I want to do. Suppose I want to do an intervention with systems. Suppose a nurse mentoring program. I want to see whoever has worked with the primary healthcare or nurse mentoring or any say SNC, tertiary care. So my focus will be that. If I want to see what are the community-driven interventions, I will focus on that. But still, my outcome, I have to focus on neonatal mortality, and then I have to include or exclude the studies. My question is why I am looking into a population now and not focusing on this question.
Okay, just I think so.
How many-
Bhumika
How many
can-
of you want to agree with what he said? So why do we want to have population,
Why?
and
Population.
why can't we just look at the interventions, and why is it so we are insisting that we need to have population, but his question.
Is population a criteria? Is that what you're saying? I mean, we're just responding to the fact that she asked what is the population. Is population a criteria?
So the population that what he's talking is related to interventions.
Yeah, so basically, yes, we define the population. Yes, it's a criteria. But he's saying, don't look at the population, just look,
Because the population right now is new.
Yeah.
It doesn't matter, his point is, it doesn't matter who the intervention is with,
Yeah,
as long as it is impacting, reducing the neonatal mortality.
So sometimes this confusion happens with everyone. So very good that
Yeah, I think so. Ma'am also wants to say.
So when you start to think about a topic, many various ideas come to your mind. Like as you are saying, various interventions. There are like SNCU level, primary health care level. So you have to consider all of that. But then when you are working on a project, you have to define your research question and have your limitations, like define your scope. What are you going to answer? And that will define your PICOs and that will define your population intervention outcome and comparisons. So otherwise, if you don't remain specific to a content, you don't have your framework, then you will not be able to answer. You will be, there are so many studies, and what will you include, what will you exclude? So there is a protocol. You have inclusion, exclusion criteria, and you have to go by that.
No, I agree, ma'am. Exactly. My question.
Yeah, I understand what.
This point. Like what will be the population? So I thought that, as you said correctly, so here I am focusing only on the outcome, and then the populations can be many, and then I have to focus on what is my research question, or what I am going to do the intervention with. So then my population will be fitting into that. My point was this.
No, I think because that you missed that first part of the session, because so we will have to look into the interventions that is for our population. So under interventions, it could be a different category of people to who you would be giving interventions to. That is where you're getting confused. That population is entirely different from the population that what we would want to look into in our EGM. That's where you're getting confused. So, so population, here we are looking at neonatal mortality. So our population will be neonatal.
Yeah.
Yes. The
So
interventions could be given to health workers, mothers, so they all come under. So like he rightly pointed it out.
Yeah, so just an example that we said, like we really want to reduce the violence in children. So the population is that where you really want to see the change in that population. That is how we define the population. As she rightly said, in the interventions, maybe we can give vouchers like to the parents, to the community. So the intervention can be given to different population, but our population in EGM, the first population is the people there you really want to make the change, and that's how you define. People, places, matlab settings. Like, are you looking at the, if like children's, or like if you're looking at this like hospital settings, all these settings. So you also define the centering and the LMIC, all these things. Okay, for this EGM, the population that we defined is this one. Yes, please.
So I know our population is neonates. As we were talking about, the interventions can range from within obviously the hospital setting where they're born at that moment, what are you doing? But we're also talking about going backwards, that when a woman is pregnant, or say when a woman is an adolescent, but again then what is the limit, right, at that point? Because if we are targeting neonates, do we want to focus only on pregnant women, covering the pregnancy and the birth, or do we want to actually talk about even say preconception care or adolescent girl care? So how do you again draw your boundary for that in this kind of an example?
Yeah. That is the reason we call it as scopes. The scope we will have to stakeholders to define the scope. So that's how we decide and where to end and where to only narrow down. So initially when we had this discussion, our question was really broad, and then when we started having discussion, then we thought that okay, this is not possible, we can't take it to this extent, so we'll have to narrow down. Again, we thought of considering different kind of intervention, then even that would it would be a lot. So then we restricted only to health. It's still under the development stage right now, this question. So
That's why we are just like really wants your like
your
observation, like comments, how you looked into.
This is really interesting because this is work in progress between Campbell and Cochrane. We are having this is a real-time work that we are doing currently, and it's good to have your opinion. And I see Carla and Sally also sitting here. So initially when we framed this question, it was including maternal and neonatal. So then we had a discussion that it would be very broad if we have both maternal interventions and neonatal outcomes. So we wanted to make it more focused. So now we are narrowing it down to neonatal health only, neonatal mortality. Would you like to say something, Carla or Sally?
Yeah, yeah, please.
Thanks, Andrew. I think it's such a great discussion, and you're right. It's such good timing to be listening to this while it's work in progress. But for me, this comes up all the time in all kinds of topics: is the tension between finding out everything that we want to know and feasibility of scope. And one thing that I've learned is that it's good, I think, to have a much tighter scope and be able to get it done, and then go on to the next one, and then go on to the next one. Because if you start too wide, it will be too long to get it done, and we won't have the information. So you're all right. It's true. We need to be thinking really broadly, but we also have to think about feasibility and timing. And what I have learned is it's better to start narrow, to know and hold in the back of your head that there are a whole lot of other things that we need to know, but finish this one first, and then do the next one, and then do the next one, or else it is just too difficult, in my opinion.
And I just want to add that, we have a thematic group on maternal, newborn, and child health, and they are very interesting on a series of questions. So that's just the beginning, and that's why we actually look at that way, that we partner Cochrane and Campbell, and that we do something that pilot. So I think for me, timeline is extremely important, being pragmatic and maybe doing less, but doing the right thing, but it showcase things that we can do in the future as well. It's just the beginning.
And it's not going to end with the EGM. Now we are working with Cochrane, and we're going to produce a dashboard with help of AI tools. So for policy makers, it will be useful to look at this EGM. And as Sally and Carla said, we'll have many more in the pipeline. So this is the first as a pilot. So that's why we are more concerned about a narrow scope and a good framework.
So I just have one doubt. So if you're starting with a narrow scope, so is defining scope is an iterative process during the like a qualitative research, for example. So is defining a scope is an iterative process if we are starting from narrow scope. Let's say we have defined a narrow scope related to any outcome, and according to which we have defined intervention and target population. But during the conduct of data search or study search or reviews, systematic review search, we come to know, okay, that we have been too narrow. Actually, we have come with new evidences, and then can we just broaden the scope in between the conduct of the study, like we do in qualitative research? So are we missing on a major thing while defining the scope? Like she said, sorry, forgot the name. So she said we should start narrow and then build up on it. Like there's a confusion.
No, so basically it's not that narrow. Like, see, narrow does not mean that narrow. We are not, when we go to narrow research questions, it's basically a review that we really want to get into very narrow. A very specific review that you looked into. Narrow, even though with this topic, like we are just like started with the population. If you really look into the intervention, it's not that narrow, but yes, we don't change the scope. Maybe, yeah, because that like we have this registered protocol, scope thing, everything is like, it's just registered before doing it, because everything is depending on it. Your search strategies are depending on it. Your screening, inclusion, exclusion, every step after that is actually based on the scope and the framework that you have. Maybe there will be discussion when we also do the piloting stage. Okay, there is not something that you just start going it. You pilot this frameworks. And in the piloting stage, you will also discuss gray areas. Will that come into inclusion or will that come into exclusion? So there is a stage that comes into when you actually start working on it. In that stage, you can actually think of just making some scope changes, specifically to the gray areas. Yeah, are we looking into such intervention as well, like just indigenous traditional interventions, or like you just have that scope thing in the piloting stage? But when you are done with the piloting, you have your framework ready, you registered it, all the PICOs, you will not change the scope because every steps depend on it. And this next thing that is like, these are the interventions that we focused on, okay, for this one. If you really look into the intervention, you can understand the scope is not that narrow. Even though with this search, you will get a lot of papers. As I said, there's a step, search strategies that like looked into databases, Google Scholar, machine learning, gray literature, journal searches. You get like 20,000, 30,000 research, searching, screening as well, searching databases. So it's not narrow in that sense, but narrow means we will not go with the, as I was saying when I started it, you can't go with the broader idea, just like child health. You have to get some narrow it, what exactly area that you really want to improve, and then you come up. And then you have that EGM defined.
If I can add something
Yes.
over here. So basically, scope is not something you decide overnight. Na? There is lot of homework, piloting what she was mentioning. Apart from that, there are a lot of stakeholder consultation, roundtable meetings where you actually get a lot of insights from the people, from the group who are already working in this area. So there are very thin possibility that you'll miss something which is so important. And then you decide that this is where we are going to work. So that's how it runs.
Yeah, I think so. With this, basically, that's what, if you really look into, just like I'm just finishing up, but then very interesting, if you really look into the intervention that we cared of. Like, see, we also looked into maternal, neonatals, community intervention, health system strengthening. So it's cover all the population that you're talking about. So that's how we like the scoping of it. Any questions that you have? Anything? Any question? And then we can move to the. Yeah, the last thing. Okay. Any questions?
Sorry, we did not have time for this activity, but I think it was a good discussion where we discussed all the aspects of it.
So just like to conclude
Yeah,
with,
just like-
it was just like a breezing session, sensitizing you about the scope of EGMs, and like you are aware about systematic reviews, so it differs from systematic review in that there is no synthesis of evidence here. We are just making a framework with interventions and outcomes on a research question. We have to set the scope first, and then we have to take consultations from the stakeholders, define our questions, refine our questions, have the PICOs set, do the searches, extract data, and plot in the EGM with using a APPA reviewer. There was no time to demonstrate that, but you had several examples of how EGMs look and how you can use them, touching the bubbles and seeing which studies have been included. So that was about it. Thank you.
Just a small request. I mean, like, it's not possible within this macro.
Yeah, yes.
But
The session timings are very small, so.
snap, agar mil jata, just for 5 minutes if possible.
Okay, so I can tell you what's like, what you can do is like anyone interested, there is an epi mapper. So you can actually look into epi website. There is an epi mapper. There is like already thing how to create this map, but then your data should be in epi reviewer. So that's the snapshot. It's like you will actually, we already had a GSN file. So you actually, all your references, you actually extract it into and then in a JSON file. And when you upload that JSON file, there's like, you define which kind of framework that you want. Interventions, outcome framework, intervention based on the region, you select the framework, and then it generates the map. And what kind of bubble? You want a study design bubbles, you want a region bubbles, or you want a qualitative bubbles. That's how it is like. You look into that, but you can also reach out to us in our website. Like, I'm Suchi Kapoor Malhotra. You can look into me, Bhumika from Campbell. You can reach out to us for any, and then we can, like any question, you can write to us. Yeah.
I'll take a moment here. We have our UNICEF chief here from Gujarat, Dr. Narayan, and I would just like to, all of us would like to just know about utility, usefulness of this kind of interventions and studies, what we are currently doing. We are trying to map pediatric NCDs and trying to see like what kind of evidence is available in that particular area and how this can influence policy decisions. But I think your insight and your comment would be really useful.
Yeah, just a second. All of you please stay back for the group picture.
Thanks for the opportunity. I have my guru of newborn care, Dr. Rajesh Mehta. He was in WHO CRO for many years. Everybody knows him. So actually, in the opening session of the summit, Dr. Vinod Pal gave us a very clear picture. I hope many of you were there. if India has to become Viksit Bharat 2047, we have to focus on every single disease which affects our children. Of course, newborn mortality, and he also suggested care after survival, the sixth pillar of INAP. I request everybody to be familiar with India Newborn Action Plan, where we mentioned, based on the state's current position of NMR, what interventions are required to which state. That should be one of the starting point for the researchers to consider as well. I also like the question, the neonatal period is all right, it's very good, but now the states which are in an advanced stage of neonatal mortality, the 5-6 states already reached SDG targets. For them, they are moving on to preconception care, so it may be wiser to keep an eye on what's happening in Maharashtra. 10 districts, they already done it and they're scaling it up. So it will be nice to, some of the interventions we may do early, but at the same time, I know many of our administrators, like secretaries of the states, their focus is on immediately reducing the mortality, what intervention saves the babies, the carrier on birth and early neonatal care. So moving forward, we are also focusing on not just survival, it's an intact survival. So there are many early sensory stimulation and developmentally supportive care intervention which can detect any developmental delays. Of course, we have to get to deepen our commitment to NCD now, but there is a screening of babies at birth for the visible defect, but also monitoring of developmental milestones. So we need to move on, shift the kind of goalpost, not only targeting mortality reduction, but also intact survival. We have evidence, Dr. Rajesh Mehta, if I can request you just to add, I know he has done, I don't know, you can just talk about for me, you are recent.
They were discussing about this template of research. PICO is always a good template to look at before you design anything. So familiarize yourself, this population intervention control and outcome is a good format for any research. And it clarifies, it makes you very clear in the beginning, from the beginning what is to be done. But Narayan is right, you know, the priorities in each countries are different, in states are different. But overall we see 41% mortality in Narayan still coming from premature, complications and prematurity. So small babies remain our top priority because maximum deaths happen there. But asphyxia surprisingly is still high. While infections have gone down, but asphyxia, so we have to, if you are attempting to reduce mortality further, so premature complications and asphyxia should be your target. So now how do you design studies will depend on your priority there. But in addition, intact survival, what happens to newborns who survive, that also is a great area to investigate. And PICO will work there.
Yeah, so thank you. I think this was very insightful and this would be useful for overall like mapping the evidence and all. Please stay back for the group photograph and let us thank our chair and speakers for this fantastic session. This would be really useful for our research and other purpose.
And thank you very much for such a concept and audience.
जिया आएंगे क्या? डॉक्टर विवेक सेशन में थे क्या? हाँ,
जिया को मैंने बात कर ली और कह रहा मेरे पास गाड़ी अवेलेबल नहीं है, तो मैंने गौतम से और गुरुराज सर से बात कर लिया, मैनेज कर लेगा।
जिया इज़ नॉट कमिंग ना, वो मुझसे पूछ रहे कि वो वाला सेशन में क्या हुआ।
हाँ अभी होगा, पहले डॉक्यूमेंट रिलीज़ करा देंगे, दोया मैडम को भी जाना है।
नहीं मेरे को बोले पूछे चेक कर जिया है क्या?
हाँ माशिया दिया था, मैंने कल ही बताया था। अब वो कह रहा है मेरे पास व्हीकल नहीं है, हाउ वुड आई छोटा सा है ना रूम। Very small, yeah. Gauri madam. Please. Good morning and welcome to the road safety session, protecting young lives, advancing road safety for children and adolescents. We have with us dignitaries Dr. Pratima Murthy Madam, Director, National Institute of Mental Health and Neurosciences. Dr. Zoya Ali Rizvi, Deputy Commissioner, Adolescent Health, Ministry of Health and Family Welfare. Dr. Gauri Madam, Deputy Director General Public Health and Director Child Health Education Bureau, Government of India. We have Dr. G. Gururaj from the WHO Collaborating Center. We will just be joined by Dr. Dinesh Kumar, Deputy Director General from the Ministry of Road Transport. So colleagues, we have all gathered together for road safety focusing on children and adolescents. As you might be aware, India is accelerating and focusing towards Viksit Bharat at 2047, and in last 20 years the country has registered 271 million vehicles, and since 2014 we have added 1.6 million kilometers of the highway roads to the India. But at the same time, where the infrastructure is developing, India contributes to 1% of the vehicle globally, but 11% of the road crash deaths and 6% of the road crashes we contribute to the global. This panel here, the esteemed panel here, will be talking and focusing upon road safety for children and adolescents. Sir, please, Dr. Dinesh Kumar, Deputy Director General, Ministry of Road Transport. As we start, may I request puja for a green planter inaugural to Dr. Pratima Murthy ma'am. Dr. Pratima Murthy ma'am, Director, National Institute of Mental Health and Neurosciences, NIMHANS. Sugandha, to please give a green planter welcome to Dr. Zoya ma'am, Deputy Commissioner, Adolescent Health. May I request Abha to have a green planter welcome for Dr. Dinesh Kumar sir, Deputy Director General, Transport Wing, Ministry of Road Transport and Highways. May I request Naumika to please welcome with the green planter Dr. Gauri Sen Gupta, Deputy Director General, Public Health. Dr. Gururaj, former Director, NIMHANS. Sir is part of our team, so we usually give. Pooja, may I request you to please give a green planter welcome to Dr. Gauri Sen Gupta ma'am, Deputy Director General, Public Health. Thank you. May I request Dr. Zoya Rizvi ma'am for your address, madam, particularly focusing road safety for children and adolescents. Over to you, ma'am.
Good morning, everybody. Dr. Pratima Murthy, esteemed colleague, Dr. Gauri, Shri Dinesh Kumar ji, and Dr. Gururaj, all people who I have known for so many years. And it is such a pleasure and such an honor to be among such august gathering. But I think the issue at hand is something which is really very important. If you just look at road traffic accidents, globally we are losing 2.2 lakh lives due to road traffic accidents. That is a huge number. These are lives which are lost suddenly, which leave behind a vacuum, not just in families, but also in schools, communities, peer groups, everywhere. So together we have to work for this. And these also is very important because these are preventable deaths, which could have been prevented had we done something more involving parents, involving teachers, involving societies, and I think the whole conglomeration of people who work with school children. If we just look at the National Crime Records Bureau, you all must be fully aware, but just quoting quickly, we know that almost half of all the unintentional injuries are due to road traffic accidents. That's a lot, about 46, 47%. And if you look at the NCRB 2022 data, we know that about 1.7 lakh of them actually resulted in deaths. If you have, say, a whole total number of accidents, which is about 4.5 lakhs, 1.7 actually end up in losing lives. And about 4 lakhs out of them is having injuries. So that's a lot of injuries and deaths happening, which could have been prevented. And also, almost half of them are related to people who are sitting on two-wheelers. And all of us realize that a lot of young people that is how they kind of graduate from two-wheelers to four-wheelers, and this is the age which is most at risk in two-wheelers. And if we just dwell for a minute as to why this has happened, almost 2/3 of the cases are due to overspeeding, 1/3 is due to reckless driving. And all of this is because the correct information is not there. And the whole issue of that infrastructure is not good or the so-called rules are not available is still a minority. So what we need to address is reckless driving and overspeeding. And that is where we need to address it through school children, through young people who are at most at risk. Besides physical, we also realize that any kind of road traffic also has mental health implications. It's not just a physical health loss, but also mental health, again, which I go back to affecting the person who's injured, his or their families, the whole community, and the schools. Because one injury has an effect on the entire community. Beyond mortality, we also have these lives which are lived with disability. So we are addressing both mortality as well as morbidities. So in light of this, we should just say that within the Ministry of Health, we have a program which is looking at school health and wellness program in which we are training school teachers. And within that, road safety has come up in a big way because we are looking at prevention of injuries and violence. And road safety comes up as an example, as a case study, as an interactive session of teachers with students talking about how to keep children safe in schools, in communities, on way to school, on way back from schools, at home. Safety and security away from injuries also is a part of our National Adolescent Health Program, Rashtriya Kishor Swasthya Karyakram. Many of you must have heard it. It's one of the 6 thematic areas. So I think government has taken has given due importance to prevention of injuries and violence, including road safety. But we cannot work alone. We do realize that health cannot do so much. We have to work with our Ministry of Education, we have to work with Ministry of Road Transport in co-owning this intervention. We have to also work with the school management committees. We have to also work with the field level health workers, with the field level NGOs who are there, who are our last mile arms and legs. And following this whole discussion, how do we work with young people also, we had I think a good feedback. I mean, you may recall it during a G20 leadership, we had organized a whole session of health of youth, wealth of nation, in which Dr. Murthy was there, Dr. Sen Gupta, a lot of people participated in that. In that also, we had 6 regional consultation with young people only. What are the issues they are facing? And road safety came up as one of the issues which they are facing. And coming up from there, I think that there was a good partnership which was developed by NIMHANS with UNICEF, with other academic institutions, with our DGHS, our Ministry of Health. How do we look at improving, I would say improving information, improving tools, giving some skills to all people who are involved with school-going children. And I'm really happy to see that this has taken very final shape now and will be released. So I really give my super congratulations, my heartfelt excitement that we will be releasing Road Safety for Children in India thing, which has been spearheaded by NIMHANS, coordinated by UNICEF and Ministry. Road Transport has been an equal partner in it. So we have to work together to ensure that every child survives school age, lives to be a full healthy individual and provides back to the society which the country expects them to do. So thank you so much.
Thank you, ma'am, for your words and a reminder of the G20 event where we mainstream road safety with under your leadership. Thank you. Colleagues, we have a team of like 30 experts across the country who joined for 9 times between last 2 years to develop a roadmap on road safety focusing on children and adolescents. Under the guidance of Director NIMHANS, Ministry of Health, Ministry of Road Transport, the executive summary was released 2 months back. I am honored and pleased Under your leadership, we are now releasing the main roadmap for children and adolescents. May I please request you, ma'am, to be on the dais. May I request Raman Chesa from the ICEDAC company to join us for the release of the document. Sir, please. Ariana from our regional office of UNICEF, please join us on the. You can come. Dr. Gautam, can you please join us for the release of the document, and Ashil from WHO. Madam, just be on the desk. May I request Anil Kumar, sir, Additional Director from the Government of Andhra Pradesh, Additional Director Health. With your, the Government of Andhra Pradesh has taken an initiative to develop an e-module on road safety, which is now hosted on the website of the Government of Andhra Pradesh under School Health and Wellness Program. We wanted to have this opportunity with Anil Kumar sir to be on the dais along with the Ministry of Health, Ministry of Road Transport, and with your kind permission, ma'am, if you give the directions, we'll launch the e-module. Yeah. Thank you so much, ma'am. Yes. Thank you so much. Zoya ma'am, you are engaged in 2 sessions at the same time. So thank you so much for having you here and for the release of the documents. May I request Dinesh Kumar, Deputy Director General, Ministry of Road Transport and Highways, sir, for your address on behalf of the Ministry of Road Transport. Thank you.
Good morning, everyone. Distinguished person on the dais and my friends. Thank you, UNICEF and NIMHANS, the WHO Collaborating Center for Safety Promotion and Injury Prevention, for inviting me today to discuss a matter of profound importance, the road safety for children and adolescents in LMIC. It is indeed a privilege to be here addressing such a vital topic, protecting young lives, advancing road safety for children and adolescents. Though I am a man of data, but today I don't want to get into just number crunching. At the end of the day, every statistics comes down to just a number. Here, every statistics represents a life altered or lost, a family shattered, and a community in mourning. This feeling gets accentuated when the statistics are about children. We often cite that the network of 6.3 kilometers of roads, the second largest road network in the world after the United States, and an exponential rise in the number of vehicles in India over the last decade, still there has been number of fatalities remained relatively constant. Such a narrative might sound comforting, but we owe little more to at least our future generation. I mentioned that over the last decade, there has been an exponential rise in the number of vehicles in India, although the number of deaths has remained relatively constant. However, these vehicles have a profound impact on the lives of children. More than 85% of the children who die in a traffic crash do so as a vulnerable road user. As a pedestrian, cyclist, or motorcyclist that has come into conflict with a heavier 4 or more wheeled vehicle on the road. Tragically, road traffic injuries are now one of the leading causes of death among children and adolescents in the country. According to MORTH, there were 9,528 children under the age of 18 years who died on India's roads during 2022. Adolescents aged 15 to 18 years accounted for 2/3 of all child's death. 79% of these children were boys. 3,446 children under the age of 18 years died while driving the vehicles. 2,207 pedestrians under the age of 18 years killed during 2022. And why it is happening? We will agree. I mean, we have dedicated our roads to the 4 or more wheeled vehicles. And we are not doing much for our vulnerable sections like pedestrian, cyclist, motorcyclist. And perhaps there is a need to think over how to come over of this situation. Here I quote Sri Nelson Mandela, "Safety and security don't just happen. They are the result of collective consensus and public investment. We owe our children, the most vulnerable citizens in our society, a life free of violence and fear." In this backdrop, the today discussion is very critical and important and warrants to go for some real innovative solution beyond rhetoric. India has reaffirmed its commitment internationally to goal set under the UN Decade of Action of drastically reducing road accidents by year 2030. Road safety is a multi-departmental agenda with the Ministry of Road Transport and Highways as the nodal agency. The MORTH is committed for child road safety and creating safe environment for children to travel and commute by way of taking several initiatives. Some of the key initiatives are road safety awareness programs, safe routes to school, child restraint system, integration of road safety in school curriculum, enforcement of road safety laws, data collection and research, collaboration and partnership, etc. By implementing a multifaceted approach that addresses infrastructure, education, enforcement, and research, MORTH has been striving to reduce road traffic injuries and fatality among children across the country. To bring in efficiency and effectiveness of the program for road safety, there is a need for proper collaboration and coordination among all stakeholders involved, like central government, state government, international organizations, NGOs, civil society, social workers, as the road safety depends on a number of factors like education, engineering, enforcement, emergency, evidence, engagement, and awareness. The Government of India has recognized the critical need to address child road safety and has implemented a multi-pronged strategy involving legislation, education, infrastructure, and enforcement. To name a few, the National Road Safety Policy dated 2010 emphasizes joint responsibility of central and state governments to reduce road accidents, injuries, and fatalities. It outlines the need for enforcement of safety laws, including those specifically targeting children and adolescents. The specific regulation like GSR 758E prescribing safety features for children in motor vehicles, such as norms for child restraint system and safety measures for children below 4 years of age riding or being carried on motorcycles have been issued. The government supports campaigns and the development of educational resources tailored for children and adolescents. Awareness is being raised through community outreach, posters, videos, and public service announcements targeting both children and their guardians. District Road Safety Committee coordinate local efforts, bringing together administration, police, education, department, and civil society to focus on child and adolescents' road safety. Capacity building workshops are conducted for government staff, educators, and transport officials to ensure effective implementation of safety measures. We have shown improvements in the reduction of fatalities through Zero Fatality Corridor projects and Safe Corridor demonstration project. The loss of even one child to preventable road accidents is a tragedy. Let us commit ourselves to creating safer roads for our children and adolescents by strengthening policies, improving infrastructure, raising awareness, and fostering a culture of responsibility. We can ensure that every child reaches school and home safely every single day. Thank you.
Thank you, sir. You rightly mentioned about the multisectorality of this thematic area. Many departments need to work together for actually ensuring the road safety, focusing on children and adolescents. May I now request Director NIMHANS, Dr. Pratima Murthy ma'am, for the keynote address, particularly focusing on the road safety on children and adolescents. Ma'am.
Dignitaries on the dais, dignitaries in the audience, ladies and gentlemen. I don't know how many of you have heard this song. How many deaths will it take till it knows that too many people have died? And when you look at the statistics of road traffic injuries, you'll realize that it's really quite a mammoth task. And ironically, our roads are getting better and better, and yet we are seeing more increasing deaths as the days go by. And although, sir, you mentioned that perhaps the ratios have not gone up too much, surely in terms of numbers, I think there's a lot that we need to be concerned about. For a moment, let's look at the statistics of road traffic fatalities in general, and with the NCRB data suggesting that perhaps there was a 20% underreporting, you have more than 7 lakh people dying in the country each year through road traffic accidents. And for every death, there are at least 30 non-fatal injuries. So one is loss of life. The second thing is, and I just need to tell you about this young gentleman, about 16 or 17, who had bought his new motorcycle and, in a fit of excitement, went out for a ride, obviously did not anticipate a hurdle coming in his way, fell off his bike, and for the last 13 years has been on life support. This means so much trauma to his entire family, so much loss of expectation. So in addition to loss of life, this poses accidents pose a huge amount of burden on families and therefore on society in general. We talked about, Dr. Zoya and Mr. Dinesh mentioned some of the figures as far as road traffic accidents is concerned. But when you actually kind of bring it down to very simple statistics, about 45 children die in India under the age of 18 because of road traffic accidents every day. Think about it, that we lose 45 children every day due to road traffic accidents. And of course, the fatalities as far as young children are concerned, when you look at statistics between 2011 and 2022, there has been a 113% increase of fatalities among children and adolescents. And where do these accidents occur? A large part of them involve children. More than 50%, 50 to 60% of the fatalities seem to occur on the highways. So children, even though they are possibly passive, recipients of the journey that's being undertaken, they are unfortunately lost to this. The other thing, about a third occur at traffic intersections. And we know, it was already mentioned, that young boys are possibly at greatest risk. Pedestrian children, going through these intersections, cyclists and two-wheeler users, especially young boys between the age of 14 to 18, are at highest risk and account for 3/4 of the fatalities among children and adolescents. Now, it also means, in terms of non-fatal injuries, that 5 lakh children need hospitalization for the road traffic accidents they encounter. And tragically, most of the accidents involve head injuries and lower limb injuries. So clearly, there is, in addition to preventing these, and preventing means, making sure that we have a sense of safe roads for our children, also making sure that children do not engage in high risk, driving on the roads. It means actually every single person who is driving being sensitive to the fact that they can injure innocent people, especially children, on the roads. But it also means that we need to develop health services which can respond to these accidents to ensure reduction in mortality, as well as making sure disability is limited. And unfortunately, we really don't have enough of that. At NIMHANS, we see about 800 to 900 polytrauma cases every month. And a significant part of them are children. So therefore, you need intensive care units, you need specialized care for these children, you need surgeons who are able to handle children. So the list goes on and on. And therefore, we need to strengthen our health system to be able to manage pediatric trauma as well. A study from AIM showed that 75% of hospitals lack facilities for pediatric trauma facilities, and only about 20% of the large government hospitals have pediatric ICU units. Clearly, we need to do a lot more. We also need to make sure that we do not develop only centralized, specialized facilities, but even at the primary and secondary care, at the place where children are being affected, that we do develop facilities. In addition to what is developed as part of the highway, a trauma care program, we are also trying to develop in Karnataka a hub and spoke model, so that acute neurotrauma is attended to as close to the incident as possible, and therefore lives can be saved and disability can be limited. We have also proposed for a specialized polytrauma center in one of our campuses in North Bangalore, because in the southern parts of the country, we need to develop that kind of specialization, not just really to develop only the services, but to also train doctors and healthcare providers throughout the country, so that there is state-of-the-art management of trauma. That's also very important. But of course, at the end of the day, I think all of us must pledge to really address all the various gaps that are there to make sure our children are safe on the roads. And I think that's our biggest responsibility. And if they should get injured, that they get the quality care and can get back on their feet as quick as possible. And in that light, this report on child and adolescent road safety in India, which was mentioned, has several stakeholders, the major stakeholders being NIMHANS, UNICEF, WHO, and of course the Ministry of Health and Family Welfare, including the DGHS. I think the whole idea is that this cannot be a problem which can be solved by a single sector or a single entity. We all have to come together, drive advocacy planning. We need to make sure policymakers are onboarded, and it's very nice to see that the major stakeholders are here today. We also need to educate the public, our families. Sometimes you realize that there are 3 or 4 people on a two-wheeler, and usually it's the kids who don't wear any protective gear. And we need to make sure we monitor the efforts to enhance child and adolescent safety in India. And therefore, this multi-sectoral plan, which starts off with awareness and making sure people understand risks and make sure they stay safe, to making sure policymakers also address the various kinds of gaps and they address their responsibilities, becomes so very important. The most important thing is that the steps should not stop with the release of the report. I think we need to see that following the report, there's a lot more action, and I think that's where we all need to come together to see what are the actionable points in the report and how do we all do what we need to do and how do we strengthen these efforts so that truly our roads can become safer, our children and adolescents can be safer on our roads. And I'm sure today's discussion will throw up not only the huge gaps, the challenges, but also the opportunities that we have towards making our roads safer for our children and adolescents. Thank you very much.
Thank you, madam, for boldly spelling out the challenges and the opportunities we need to seek out for looking at. Last week, the Honorable Minister of Education announced that NCERT should take up the issue of road safety into the curriculum, which has been now agreed and endorsed by the Ministry of Education. It will be a big milestone for the entire school curriculum in the country. Taking the agenda forward, we have now technical presentations. May I request Dr. Narayan to please be on the dais for chairing this session. May I request Raman Chesa from ISADAC company, sir, to please be on the dais for chairing this technical session. Dr. Raman is from ISADAC, an Abertis company in India. He is the Chief Executive Officer. And ISADAC has been supporting UNICEF financially for take this agenda forward.
Yeah, thank you. Myself, Dr. Narayan Gamkar, I'm a health specialist in UNICEF. I take a privilege to recognize all the experts. We are very lucky today. This hall is small, but there is a lot of energy and power. Our youngest participant in the room today is just 14 years, championing a lot of road safety work. Thank you, Shyam, for joining. And yesterday he was presenting a poster talking about the good work done by the young people. And young people, we also listened to them yesterday. They say nothing for us without us. So it's welcome all the young champions. Thank you so much for joining. Yeah, please bear with us for a minute till we organize our. Yeah. Yeah, we have with us today Dr. Gauri Sengupta. She is actually have a detailed analysis, understanding of road safety and focusing on children and adolescents. She is a Deputy Director General, Public Health, Ministry of Health and Family Welfare. So we would like to hear from Madam. Your
This is Gautam's presentation.
One second. The first one will be Madam's Gauri.
This is Gautam's.
One second. Ali. Connection.
Yeah, thank you. So good morning and namaskar to one and all out here. All of us are committed towards one thing, that is road safety. For those who do not know, Central Health Education Bureau is an attached office of the Directorate General Health Services, Ministry of Health and Family Welfare, established way back in 1956 on the recommendations of the Bohr Committee, Central Council of Health and Planning Commission. And one of our major mandates, apart from development of prototype health education materials, trainings, capacity building, is conducting behavioral research. So as part of that mandate, and considering that the commitment towards road safety cannot be
done without including the most important people, that is children or adolescents. Having them as one of the game changers is going to be most important, because whatever we put in place will be things that we feel as experts need to be done based on data. But at the end of the day, if we need to actually talk about health promotion, it is they who have to be taking the decisions, being informed in whatever manner possible, in multiple forums, through multiple modalities. We need to have them taking the proper decisions so that we can avert all the morbidities and mortalities that have been discussed by Madam Pratima Murthy, by Dinesh ji, and of course detailed in this wonderful document. So considering that, the Central Health Education Bureau had initiated a study called Pratap, which stands for Prevention of Risk-Taking Attitude and Practices amongst adolescent school-going children. Why school-going? Because that is a wonderful organized sector where you can get children and adolescents who have the maximum risk-taking attitude and behavior by virtue of their being in that particular phase of life, and also being absolutely under the influence of a lot of role models, a lot of social media, and a lot of other things. So this study was based on the following objectives. We identified to do a pilot and then take it on under the National Program for Prevention and Management of Trauma and Burn Injuries. So that is the NPPM-TBI. Apart from that, in the second phase, we will also be interacting with the Rashtriya Kishore Swasth Karyakram and the School Health and Wellness Ambassador Program. And of course, I will request Dinesh ji also, if Ministry of Road Transport, the wonderful modality of the district road safety component which is there, so that in the true spirit of taking this multi-sectoral roadmap that has been released, we will be able to engage more than one sector, not only health, but the road transport department and the education sector, and not to forget all the wonderful NGOs and community-based organizations who are working at the grassroots level, engaging with multiple partners, departments, and sectors in the states, districts, and even up to the village levels. So the first objective was this, to conduct the pilot, first of all as a situational analysis to identify the operational problems, and to provide an early purview of the key risky behavior and attitude towards road traffic injuries, analyzing the data, and subsequently developing the communication prototypes. So 30 schools in Delhi NCR, Jaipur, and Bhopal were taken up. These were based on discussions with CBSE, with NCERT, and permissions also. So to a certain extent, it is purposive. Wherever we got the permissions, it was conducted. And this was, you have to give us the credit that this was in the throes of COVID. So a lot of teacher trainings and all were done virtually. But still, it was amazing the kind of support that was received in this. It was a multi-stage random sampling, and students from the grade 9 to 12, specifically the age group was something that was taken in, and not specifically the standards or the education grades. So after content, the questionnaire had 4 major parts. Apart from socio-demographic details, we wanted to assess the knowledge, the attitude, and most importantly, practices. So this was the methodology that, apart from the selection of sites, you had a proper technical advisory committee which did the finalization, standardization, and the translation of the forms into Hindi also. And we had the school communications, there was a teachers training done, and the teachers were recruited to find students who will be able to take the questionnaire and then the subsequent interactions that will be there. And an online parent consent form was handed over to the teachers and it was undertaken, and those who had provided the consent only were participating in this particular survey. And the school visit and interaction with the schools and teachers was conducted. The initial interaction was online, and subsequently there was one face-to-face interaction with the teachers and of the teachers with the students also. So this is just to give you a glimpse of all the multiple things that were conducted, and based on the initiatives, these are the basic results of the particular study. So total around 1820 students from 30 schools. So if you see, it's a very representative thing of 41% from Delhi, 27% from Jaipur, and 32% from Bhopal. You have a fairly 60-40 representation of the private and the government schools. And across the classes also, we have a fairly representative 25 to 30% representation. Age groups also, we've had maximum in the 13 to 15 years. This is primarily because in the 10th standard and the 12th standards, they don't usually come to school, specifically in Delhi. Most of them bunk school, they're studying, and science sections and all the students are very less. So primarily because of that, you have more of the 13 to 15 year age group, and females and males were kind of 60-40. So if you see the knowledge, we're talking about good amount of urban representation also. Despite that, all the reds are poor knowledge. So even if I don't see specific questions, we are talking about 21, 22. Multiple, we're not trying to poke things. There are multiple agencies doing a lot about road safety, a lot of movies, a lot of social media, a lot of ministerial work, a lot of NGO work. And this is woke children. I'm sure all of us will agree that these are not very laid back children of around 20 years back who were not aware of certain things. So they are very woke children, and yet the knowledge regarding basic stuff is very lacking. Similarly, the attitude is also, the risk-taking attitude is considered as very stylish. Maybe because of the movies, maybe because of the media influence, we couldn't delve into what is the reason why they are willing to take the risk. So that is one of the limitations I think we would like to address in the second phase. But yes, it is there. So I think this is something which we need to be aware of. Apart from that, if you see, these are the 6 questions that were asked for the practices. And if you see, most of them have driven. They have used mobile phone. They are jumping the red light, and irrespective of the fact that they do not have a license, most of them are driving a two-wheeler. So overall, if we see, there's more than 70% poor knowledge, risky attitude, and poor practices. So based on that, this particular handbook was created by a group of experts from AIIMS, from multiple things, education sector and all everything. And the key recommendations that came out of this particular study was there should be no dearth. I think it's not just one modality, but we need to keep repeating the same information through multiple platforms continuously. I think reinforcement is the key. It cannot be a one-time situation. So imparting orientation regarding road safety and basic life support. So with AIIMS New Delhi, we do plan to do something called hands-only CPR also for children. Maybe in the higher classes, but definitely giving the right amount of information to the other children also. So training of teachers and continuing interactive sessions, addressing behavior change, identifying ambassadors, all this will be programmatic. But at the end of the day, I cannot underscore the fact that reinforcement is the key towards this. So for Pratap phase 2, we are slightly lagging. We had promised to do it last year, but due to certain logistical constraints, we could not do it. So hopefully we'll be able to do this year. We have an approval for 5 states, that is Arunachal, Bihar, Haryana, Kerala, and Uttar Pradesh. We do wish to do it in 7 more states, including Karnataka and others. So we look forward to having a better coordination with the Ministry of Road Transport, Ministry of Education. We've already had our discussions, and hopefully we should be able to roll it out and come back in a year's time with a different picture and much more oriented children as well as teachers. So thank you very much.
Many thanks, Dr. Gauri, for your very good analytical presentation and paving the way for some policy recommendations as well. We have another interesting presentation from our own Dr. Gautam from NIMHANS. He currently heads WHO Collaborating Center for Road Safety and Injury Prevention, and there is a good quality and quantity data to kind of guide the way for road safety actions in India. So I request Gautam to please, the stage is yours now. 10 minutes.
Yeah, thank you, sir, for reminding me. So I'll even put the stop clock. So what I would like to do is to just set the stage for the very enriching panel discussion that's going to follow after this talk. So I just will give you certain facts and figures and key findings that basically you can ponder about it. So you can rewind in your mind what to ask the panelists and then probably engage in a healthy discussion. So I'll be providing a snapshot, and this is where it all started, the national planning meeting, which really implied that there's a need for a national level report and a roadmap for road safety. As Dr. Ali told that there were more than 9 meetings and an extensive literature review that was followed, and the report was developed. The key findings was that, see, we have around 565 million children in this country, children and adolescents, aged less than 19 years. If you take younger persons, that is up to the age of 24 years, they are even more in number. The road exposure is also higher in that age group. The leading cause of death, my dear friends, is road traffic injuries now. Due to better control of RCH and communicable diseases, it is the road traffic injuries that is the leading cause of death. And we cannot speak of children health if you don't address the unintentional injuries. So it's become a part and parcel, and it's a health priority in this age group now. As Madam had told, every day we are losing 45 lives. That basically means 45 families are affected every day. 1.9 lakh children were killed between the year 2011 to 2022. Why I am using this year reference? That was the UN decade of road safety. That's basically 2011 to 2020. Due to COVID, the year 2020 is not a good reference here to basically to say what has happened between 2011 to 2020, and hence we have used 2022 as a reference year. Around 5 lakh children need hospitalization for moderate to severe injuries every year. Considering the deficiencies in pediatric trauma care in this country, so most of these 5 lakh children are either undercared, there's a lower quality care leading to less favorable outcomes and long-term disabilities. So this is something that we need to keep in mind. And what has happened in the last decade, 2011 to 2020, we all promised ourselves and to the world that we are going to reduce the number of fatalities by 50%. And we see that we have fallen short of our commitment. In fact, the number of children who have died in the first decade of road safety is like increased by 113%. Though the rates, as Sir told, the rates and ratios have not changed significantly, but absolute numbers are equally important in road safety or road traffic injury epidemiology. So there's an increase in all parameters, saying that the problem is, you could also discuss that it's a natural expected occurrence of increase in all the other factors that surround the road, increase in vehicles, increase in roads, increase in people, increase in travel exposure, yes, but still we cannot discount the fatality and injuries that happen, whatever is the reason. The statewide distribution, with increase in income levels, increase in industrialization, increase in road network, nearly 10 states account for 40% of all the child and adolescent road traffic fatalities. So we know where to concentrate, and in fact the states where it is reported less, we actually cannot conclude that there are no crashes or injuries, because it also, the reporting system may vary significantly between the states, and that's one of the important thing that biases these observations as well. And who are affected? Whom should we target? Children and adolescents aged more than 14 years. That is when independent and unsupervised road exposure happens. They start riding their friend's bike. They start getting fake deals. They start going out of the vicinity and supervision of parents, males, children in rural areas where the exposure to highways and speed is higher. That's why the fatalities are more in these areas. Pedestrians, cyclists and powered two-wheeler users are disproportionately affected in this country, 76%. 76%. People may argue that if you consider the denominator of the number of two-wheelers, pedestrians and cyclists, the fatalities could be less. Yes, there's an argument. In compared to the Western countries, it is less. But nevertheless, if you break the pie of the problem, this is the pie, part of the pie that needs to be addressed to reduce the overall problem in this country. And what is the reason? Guru Raj sir was saying that the determinants of determinants, that is the cause. There are multiple reasons, something which is proximal, many things that are distal. You need to address a whole lot of things that clearly indicates that a multisectoral approach is really required to address the problem. So directly we can attribute that there are vehicle related causes, there are road related causes, there are human behavior related causes, and behavior is an important issue in this age group because of the rising hormones, peer pressure, trying to impress each other. And they believe that they have got better alertness, better control, and it's a belief that is difficult to override as well. So there are a lot of vehicle, road and human behavior related risk factors. We actually, one of the largest surveys of road safety risk factors. We do not have a road safety risk factor surveillance system in this country as such. So I am just showing the results from one of the large, where we have more than 20 million observations. What we have seen is that there's a huge gap between helmet use and correct helmet use among children. It's very less. See, it's 3, 10, 50%. And you know that wearing helmet is protective in nature, but the helmet use is very, very limited. And data from RASI shows that 94% of the children in fatal crashes are actually not wearing helmets. So given the protective efficacy of helmets, even if you are able to transcribe as at least 10 to 20% to 30% of people to actually wear helmets correctly, that could really make a big difference in the number of fatalities as well as the severity of injuries. 82% of the fatal road traffic crashes involving children were unrestrained. They were not restrained because there's a whole problem with the child restraint system, availability, accessibility, affordability, and even the intention to use it even among people who are actually affordable and knowledgeable as well. So there's a need to change the overall sphere of getting people to buy child restraints, getting parents to use child restraints. So it needs to be addressed. Speeding, as you know, it is directly related to fatality. 12 to 52% of vehicles were speeding beyond the posted speed limit. A 1 kilometer increase in speed results in 4 to 5% increase in probability of crash, a 20% increase in probability of injuries. So even we should try to reduce the overall population speed limits by shift to the left, even by 1 kilometer. Just 3 days back, we were presenting the results of the speeding observation in Bangalore metropolitan region, and we see that in the Bangalore metropolitan region, all things considered, the average speed of vehicles for all types of vehicles decreased from 65 kilometers. Metropolitan region includes the regions outside Bangalore. 65 to 61 kilometers per hour. That is a 4 to 5 kilometers per hour decrease in average speed. But the prevalence of speeding has decreased from 49% close to 23%. So a small decreases in average values leads to large decreases in prevalence of the problem. It is something that every public health specialist is aware of this. So then the evidence with respect to alcohol, we see we have the same BAC limits for adults as well as young children, whereas in many European countries and many high-income countries, they have a differential limits of blood alcohol concentration for young and novice drivers as against the general population as such. We need that's one of the gap that can be addressed. And even though India has done extremely well in the area of ensuring safer vehicles for four-wheelers, and recently I think India also got an award in the ministerial conference in Morocco, we did an analysis of what is the child occupant safety rating system in existing cars, and we see that even though even the 5-star cars in India have got a 3-star or lower rating for child occupant safety. So they are 5-star for adult occupants, but they are 3-star for child occupants. And no number of stars will be useful if the person does not wear the seat belt, if the person is not so it's also the behavior and the safety features is also important. Where are these children dying? Even the pedestrians are maximum deaths, but 36% of these pedestrian fatalities are happening in intersections. So we need to make our intersections safer. We need to make our highways safer, because nearly 50% of fatalities, that is children, are happening in highways. And where are these children dying? The trimodal distribution of death, as Sir found out way back in the year 2009, is reversed for children. 50% of children die on the crash site. It implies that prevention of road traffic crashes is more important, because it's difficult to manage children once they are hit because of the biological vulnerability, and the specialty to manage the hemorrhage and shock is not easily available in rural areas. So only 30%, literally even the best trauma care systems can reduce fatalities by 30%. So 30% of the 20% who make it to hospital can only be survived. So we cannot keep building hospitals in this country. We need to make the roads and vehicles safer and human behavior safer as well. So that is the key message as for us children here. So safe journeys to school. We need to ensure that the walking and the pedestrian facilities are better. And Madam had mentioned that only 20% of the large government hospitals have pediatric ICU facilities. So there's a whole lot of capacity building in the health systems, strengthening that is need to be required. And I will not go, the audience here know about what are the issues with the existing data systems, but I just like to say that there's a need to increase the availability of information related to child and adolescent road traffic injuries in the MORTH and NCRB report. We need to add more tables so that people can use it for doing some action and evaluate the effectiveness of the actions that are undertaken. So since due to shortage of time, I will skip this. I would just like to say one important point is that we have made a lot of recommendations, not a small set of recommendations, which is tailoring towards addressing specific aspects in child and adolescent road safety. One of the important recommendations is implementation of the multi-sectoral action plan and having a nodal officer for child and adolescent road safety in the state level bodies, authorities and councils, and have a dedicated budget for child and adolescent road safety. Ensure the safety of vehicles, increase the availability and accessibility of safety equipment with local manufacturing capacity so that the cost and accessibility and affordability can improve. And good Samaritan law, school-based child and adolescent road traffic injury prevention programs, reporting child occupant safety rating systems, improving pediatric trauma care, all are some of the important recommendations that is basically doable. I would like to end my talk by saying that I request all of you to please go through this multi-sectoral action plan. This action plan is basically there in the report. There were a lot of debates. It was a huge plan, just made very small, focusing on things that can be done. There are activities and there are agencies that are responsible for implementation, and who can support these agencies who are responsible for implementation. What should be the probable starting line? Obviously that can be changed. And what is one or two simple outcome indicators that can be used to measure whether the activity has been implemented or not. So with this, I thank all the stakeholders, the director and management of NIMHANS, Ministry of Health and Family Welfare, MORTH, CHEB, WHO, UNICEF, the various traffic police departments, NGOs and all the experts who have spent their time and energy in developing this report. Thank you very much for the opportunity to present.
Many thanks, Gautam, for sharing a detailed analytical presentation and also making a recommendation which can guide many of our action. We are very fortunate to drive this agenda forward. We need academia, we need businesses, we need CSO partners, we need development partners. In this room, even though a small number of participants, we have representatives from all of them. I recognize the presence of Raman Chesa, CEO of ISEDAC company, which is actually an Abertis company. We really thank your inputs and encouragement and support for advancing road safety for children and adolescents, and would like to hear from you a few messages, and your thoughts on the issue before we go on to the very interesting panel discussion. You have about 3 minutes, please.
Thank you everybody for this discussion, for this information, very good information, obviously, to understand how and what is the problem. We have to know, first of all, the statistics and the numbers, and to try to check how can run the solutions. I don't want to speak about the statistics. The statistics are very well in all these presentations. I want to talk just from some expert company from Spain about road safety, and also the actions that we are doing in several countries in the world, like in Europe, or also in America, here in India as well, and to show some details that how we can improve this matter of road safety. Obviously, we have to put the focus once the accident is there, about the trauma, the issues that are coming once the accident is done. But for my point of view, we have to start at the beginning. The beginning is to try to reduce the accidents and to try to reduce the fatalities. For that, if we achieve this objective, obviously we will improve all the chain regarding the road safety matter. First of all, the design of roads and highways. I believe India and HAI and MORCE have to rethink this point. Several highways are crossing villages, are crossing cities. This obviously is a very high risk to have accidents. It's impossible to prevent, to eliminate all the accidents if the highway cross villages and cross cities. In Western countries, it's not possible. It's unbelievable. No one is thinking that one highway can cross the cities. The highways, India should go ahead and should think that new highways should be without touching cities, without touching villages. Obviously, if people have to go to these cities and villages, obviously some entries, some entrance, some exits, obviously, but not crossing these live cities. This is a very key point. Other point is crossing highways at the same level. Intersections. This is for me, as a Western person, expert in road safety in Spain. When I came here 4 years back, it was very unbelievable for me to have crossing points at the same level on the highways. This should be eliminated, completely eliminated. All the crossing points should be different level, underpass or flyovers, but not at the same level. This will eliminate, for sure, also several numbers of accidents and injuries. Multiple actions in design to avoid to go on the highway, pedestrians, cyclists, also bikes. How we can reach this? Obviously, at the time that we are building highway, we can build a service road in parallel to the highway for all the areas that we have cities and villages. Obviously, this will increase the cost of the highway, but will reduce the accidents and will have safer the highways. What is the key? Or what is the issue? The cost of the highways or the cost of lives? Or the number, this big number of deaths every year in India? I believe, okay, I finish. I believe we have to focus on the life of people, not on the cost of the highways. Because cost of the highways is one time for 30, 40, 50 years. Then many issues. And 1 minute. After design, behavior. Behavior is important, behavior of users. Thinking on my experience in Spain, 50, 60 years back, no one was using a seatbelt, no one was wearing helmet on the bike. Now, everybody. Why? Why was this change after this? Because enforcement. Only enforcement. Training is important, obviously. I don't reject to train young people, this is important, but to change definitely the behavior of the people is enforcement, and to touch the wallet of them. This is clear. This is clear. Once in Spain, in Europe, in every country, government started to touch the wallet for the people, the accidents will come down immediately, and also the death. Nothing else. This is from my experience. This is from my knowledge about this in other countries. But I believe these actions could be very, very interesting also if we can implement, not immediately, but step by step here in India also. Thank you, everybody, for that.
Thank you, wonderful chairs, Dr. Narayan and Raman. May I request Sugandha to have a green planter to Mr. Raman Chesa, please. And Narayan, please be on the stage, on the dais. And may I request Pooja for a green planter to Dr. Narayan. Thank you very much for this session. May I now request Dr. Gururaj sir to take over as a moderator for the panel on road safety focusing on children and adolescents. Gururaj sir.
Thank you very much, Dr. Ali, and at the same time for inviting me to join these deliberations today and this very important topic on saving lives of children and adolescents. We have heard from the distinguished speakers in the morning about some of the numbers, the statistics, the scenarios and what needs to be done and all that. Let's take a little deeper dive into these aspects now and see what is it that we can actually do. There are two important issues which I would like to highlight at the beginning. One is today, I don't think anyone can deny the fact that travel is a basic fundamental need. Everyone has to travel, whether it's small child or an elderly person, an office goer, a woman going for shopping, somebody going to bank, everyone has to travel. And children need to travel more because they are at a stage in their life where education really is most critical. Whether it is for private tuition or for school or for anything, at extracurricular classes, they travel, they have to travel. Secondly, they also use multiple modes of transport. They go as pedestrians, they go in auto rickshaws, they go on two-wheelers, they go in public transport vehicles, they go in school buses, they travel in different modes of transport. Third and the most important thing is, children are not adults with whom we can communicate a little bit more easily, but with children, because of several vulnerabilities and their susceptibilities, it is very difficult and challenging to engage them in stronger road safety activities, even though we have been hearing about some of the pilot studies. There are definite scientific reasons for this. There are issues with regard to age, gender, development, body size, vision, hearing, cognitive abilities, their emotional aspects, the peer group influence. They are exposed in today's world to a number of these things, and their level of maturity and understanding the complex issues on the road are very, very difficult. So the answers don't seem to be very simplistic in nature, but at the same time, they need to be more scientific and evidence based, and we need to learn from many other countries around the world. To go a little bit more in depth into this scenario, we have a very interesting panel that will throw more light onto these things. So I have pleasure in inviting our panelists, Dr. Syed Ali from UNICEF to join the stage, Professor Geetam Tiwari from Indian Institute of Technology, New Delhi, Dr. Ashil from WHO India Country Office, Mr. Nikhil from Germany, and also Ms. Avina Bhatt from as a youth. Okay, Avira Bhatt from as a youth representative to throw a little more light on how do we address these challenges. Due to paucity of time, I'm sure many people in this room know our audiences, but I'll keep their introductions very brief. Dr. Syed Ali is a health specialist at UNICEF with more than 15 years of experience working in the areas of child survival, growth, development, HIV/AIDS. And in the last few years, especially UNICEF has also moved into the area of child and adolescent road safety, and he has been leading activities from the Indian region. Professor Geetam Tiwari has been working in the area of road safety for more than 4 decades now. She is Emeritus Professor at the Transportation Research and Injury Prevention Center, TRIP, in IIT Delhi. And she is the founding head of the center from 2021 to, she is the head of the 21 to 23 time, has worked extensively in safety of pedestrians as well as on public transport users in urban environment as well as on national and state highways. We also have with us Mr. Nikhil, who has had his education in Germany and has been working as a road safety researcher for more than 10 years now. He was awarded the Sid Watkins Scholarship by the FIA for his research in motorsport safety. He founded Hugvita in Germany with the aim of leveraging European knowledge and technical expertise to improve child road safety in many of the developing countries. Dr. Mohammad Ashil is the National Professional Officer for Injuries and Disabilities at the WHO India Country Office with more than nearly 15 years of experience in health system strengthening, injuries and disabilities, and several other areas. He has worked extensively in several states of India and looked at strengthening trauma care as well as rehabilitation aspects. So let's get in directly into this thing. Dr. Ali, you have taken over in the UNICEF the area of child, adults and road safety. And India has been making some of the developments, but at the same time in the region also there have been some developments. So what do you think are some key highlights in the area of child and adolescent road safety in terms of the policies, programs, plans, human resource development, some funding, monitoring, many of these from a larger public health perspective? What do you think are some key highlights and where do we stand today? Can you use the mic, please?
Thank you, Dr. Gururaj. So, in the region, actually, as per the WHO health statistics, in the Southeast Asia region, Afghanistan is leading the rate of death due to road traffic injuries. It is 16 per 100,000. India currently stands at 11.3 per 100,000. Maldives has made a very good progress, 1.3 at this stage per 100,000. Now we have to learn from each other, like a South-South collaboration. Some good points has done in Maldives where in 2012-2016 they reported a huge number of deaths. Following that, they have made helmet, as Raman has mentioned, compulsory for, and they did a study on the Maldives-China friendship bridge where they made mandatory use of the helmets, otherwise they would not allow to go on the highways, and that has resulted in huge reduction. Now, India, we have with the Safe Life Foundation the Zero Corridor demonstration projects, where we were able to reduce by 61% the road traffic crashes and the deaths on the Mumbai-Pune highway. And also we have other examples from India, the Belgaum-Yargati corridor, where a good amount, 41% is reported. So I think this sort of the learnings needs to be. So country currently has, in terms of absolute numbers, a large number of deaths, particularly children, adolescents, young people, and in terms of the bulk, the cohort, India, as you know, it's the largest in this area. So these points, and I would like to, as you mentioned about the policies and programs, and Dr. Gauri also mentioned about, there are lots of recommendations. If you look at the Motor Vehicle Act, in the Act, it's only 2 times where the mention of children is there. It's 129 and the 194B section mentions about child. So that part of this, you know, amendments into the policies to make it children's safety is needed. Thank you.
Yeah, thank you very much. And I think the point you said about learning from each other makes a very important issue, because there is a report by Save Life Foundation published recently which talks about good practices in road safety in the Indian region. There are quite a few examples available there. I would request the audience to have a look at that report when time permits. Moving on, once we understand that children need to travel for variety of reasons in different variety in modes, the road infrastructure is one of the critical elements. In the safe systems approach, we have safe roads and safe speeds as 2 major pillars that are very critical to be considered here. So Professor Geetham, I would just like to ask you, how are the infrastructural issues contributing to RTAs, and do we have any good data on this? And also, is the safe design of road environments, planning, operation, maintenance given adequate importance in considering safety of young people as they use our roads? And if you have any good examples, please share it with us.
So I think the most important thing is that one of the most important thing is in understanding our data and all the discussions we had, and you also started about the safe systems approach, but the theory behind safe systems approach is Vision Zero. And Vision Zero has 2 very important principles to remember, that we have to understand human frailty. And today we are talking about children. The children, we have heard in presentations also, they are more vulnerable because of their size and age, etc. Second important thing is acceptance of human error. And this is absolutely very important for understanding children's behavior, which you also mentioned in the beginning about their cognitive skills. And we really have to, and I think I was also trying to relate to some of the findings that Dr. Sengupta mentioned about risky behavior, enjoying doing risky behavior. This is not new, this finding. This we have known at least since mid-60s, when traffic psychologists started working on safety with children. So basically, in the background, if we remember these 3 things, and then we start seeing that what needs to be done about the road infrastructure. So that means we have to create a road infrastructure for all, but definitely more important for children, which meets these requirements. A large number of children are walking to school, or they can come by bicycle, because bicycle has a lot of other benefits. And recent studies from India show that in rural areas, girls using bicycle has exponentially increased. So it is our responsibility to make that safe also. And of course, then children are traveling by buses, but eventually bus also means walking, pedestrian. Your final journey is walking. So when we talk about safe road infrastructure, these are the 3 things. 3 road users we have to address.
Okay.
I think this is nothing new that I am telling you. Everybody has known about it for a long time. There are a lot of detailed guidelines also which exist. Indian Roads Congress has a separate guideline for safe school zones. It has separate guidelines for pedestrians. It has separate guidelines for bicycle infrastructure. I think we really have to ponder about why is it not happening on the ground. And that is the really big challenge. And one of the understanding that comes from, again, if I want to focus only for children, is that school-going children is about teachers, it's about parents, and it's about involving this whole ecosystem. So children actually can express what are the difficulties and risks they face in coming to school while they are boarding and alighting, or when they are waiting for their parents to pick them up. This whole environment one can make safe by following the guidelines, but have the teachers understood why they cannot park on the paths, pedestrian paths, which have been created, or the bicycle path, or near the gates. I think there is a lot of consensus building which needs to be done to create the safe infrastructure. And your last question, that have we paid enough attention? While we are expanding highways, and a couple of things that Dr. Raman said is absolutely true, and repeatedly we have brought out that our major risk areas are when highways pass through settlements. And a lot of recent expansion has happened, just adding more lanes. So the earlier 2-lane road, which was easy to cross and safe and lower speed, has become higher speed. Even though there is a notification from the ministry that now if the highway is passing through settlement, it should be at elevated. Yeah. But we really have to declare those sections non-highway sections and start paying attention to bring it to safe speed limits, which we have known for a long time.
Thanks, Geetam. I think there are several things that needs to be done on the infrastructure front to make children more safer. Once these roads are there, there are different type of vehicles in which people travel, in which students travel, young children travel. So we have seen quite a bit of advances happening in the last few years in the area of vehicle safety. In fact, day before yesterday, we saw a message from the Maruti Suzuki that in the next year or so, their cars will have 6 airbags. And there are many such things happening on the vehicle front. So I would like to come to you, Mr. Nikhil. Tell us, how are vehicle technology futures evolving in protecting children and adolescents, because they are at a young age? Secondly, also with regard to children and adolescents, it is not just the cars that they travel in. They travel on two-wheelers, they travel in auto rickshaws, they travel in school buses, they travel in public transport buses, and many of them walk on the road. They cycle on the road. So, are there any vehicle technology developments happening to look at where children are traveling more, on which type of vehicles, and how do we make them safer in that? Over to you.
Okay, thank you, Dr. Gururaj, and thank you everyone for being here. So, as we already discussed, the vehicle technologies in terms of child occupant safety has improved a lot. Global NCAP has done a commendable job in pushing the safety systems across India. But as Dr. Gautam mentioned, Indian cars does not score really high on Global NCAP regarding to child occupant safety. One reason is because 6 airbags are not mandated, one of the reasons. So today I would like to talk about child occupant safety from the perspective of child restraint systems. So this is a topic that is not often discussed in countries like India. And WHO has said that this child restraint systems, or lack of use of child restraint systems, is one of the least addressed risks in countries like India. So India has one of the highest motorization rates in the world, and the usage of child restraint system is less than 1%, sadly. And as you all might know, child restraints can reduce the possibility of death in toddlers by about half. So in collaboration with FIA Foundation and in partnership with schools and hospitals in India, we did a study last year. And we found out that to break the adoption barriers, we need to have a comprehensive strategy that focuses on creating awareness, enforcement of the rules, and introducing the right products. So from the study, I would like to share one insight. So according to IRAP calculator tool, it says that in India, around 1,400 children, child occupants die every year. So whenever I talk to stakeholders regarding enforcement, the reply I get is 1,400 is quite a low number, so we cannot prioritize child occupant safety right now. But you might know that distraction is one of the main causes of accident. And from an observational study we did, and we are also planning a detailed study, children who are unrestrained in a car lead to distraction of the drivers, which can lead to an accident in which a pedestrian is killed, a bicyclist is killed, or a motorcyclist is killed. So I would like to say that not using a child restraint system, the cost of it is much higher. And to touch on the point from Dr. Gururaj about child occupant safety in other motor vehicles like two-wheelers, powered two-wheelers, auto rickshaws, buses, taxis, etc., I think it's not an easy or direct answer. So what we should do is to go for the low-hanging fruits. So for example, for power two-wheelers, we can enforce, it's already mandated in the regulation, but we need to enforce helmets for children. And also we need to bring up a testing standard for children's helmet to ensure that safe quality products are pushed into the market. So most of the helmet testing standards have been developed in the West, and they do not still have a proper standard for children's helmet because children doesn't travel that often in motorbikes in the Western countries. And regarding auto rickshaws and buses, something we could do is at least mandate a lap belt, which improves the safety a lot. And yeah, that's my answer.
Thank you. So while we look at the roads and the vehicles, and it's always our desire to see that road crashes don't happen, but crashes, they continue to happen. In that event, saving lives and giving them the required timely medical care can save a lot of lives. We saw in one of the presentations by Gautam, 50% of the children's deaths happen at the crash site, and the remaining on their way to hospital or in the hospital. So nearly half the deaths take place. So Dr. Ashil, I just wanted to ask you, with your experience of working across different Indian states and also promoting ideal trauma systems, what is the current status of trauma care for younger population in the country, and how does efficient trauma care make a difference for survival and death? Gautam mentioned a few points in terms of the availability of pediatric trauma care facilities, but what is it we can do with regard to pre-hospital care or early deaths, and how can we reduce these deaths?
Thank you very much. Thank you very much for this question, and thank you very much for inviting for this panel. Let's acknowledge that in the last 2 hours when we were discussing this thing, 50 more people died due to crashes in India, and 200 more people were seriously injured. Most of them would be going for disability. So that's the gravity of issue which we are discussing. And if you look at the global statistics on what trauma care systems can do, when you take the adult population, when we say that people with potentially fatal injuries are 6 times more likely to die in a state or a country with no organized trauma care system than with organized trauma care system. But as Gautam has said earlier, that is different for children, because for children the prevention is the key, because many times there, as Madam was mentioning about the Vision Zero and the safe system approach, where the human tolerance for injury, and you consider the human tolerance for injuries, that is quite low for children. Having said that, the systems what we have in place, we need to be careful about that, is that we need to be looking into detail about that is, as we say that the vulnerable road users are the primary victims in many of the cases, where the pedestrians, where the cyclists and the motorbike people around motorbikes are actually getting injured and they are dying, so there is one definite bystander in that, and the bystander is the person who is hitting them. But many times, because if we are saying about pedestrian, there is someone who is hitting. So there are, if the section 134 of the Motor Vehicle Act says that, so the first responsibility of taking the patient to the hospital is on the person who is actually involved in that crash, unless he is also injured. That's another thing. So, and if that's the case, then are our the drivers enough trained to what to do during a crash and how to do that? And many times what happens is that a crash site, the people will be, mob will be coming and attacking them. So the section actually gives a provision, if you fear a mob attack, you can go away from there. But the thing is that whether we are training our drivers enough to actually handle a situation like that. And when it comes to the pre-hospital care, you know the number of ambulances, registered ambulances in India? That is 193,000. And functioning is 173,000. Which means that for more than, like less than 10,000 population per the ambulance would be, for maybe 9,000 population, every 9,000 or every 8,000 population would be having one ambulance. And there is no reason that we should be waiting for 45 minutes to 1.5 hours for waiting for the ambulance. Then why it's not happening? Even if you have an ambulance just beside your doorstep, you cannot get it if you call like the, because that is not, that does not come in the, if you for 108, you call 108. There is set of ambulance called by under the quotation, under the tender, where the ambulance are placed in some places. But an ambulance or a patient transport vehicle may be very near to you. That will not come to you because that's not mapped. So now the system, what is being, yesterday also we were discussing with the joint secretary, we were actually thinking of the Pradhan Mantri Gati Shakti, we know that there are where the hospitals are. If we can actually map this, all the ambulances and the patient transport vehicle, because in most of the cases in India, we don't have to stay and play. What we call the systems in trauma is stay and play and scoop and run. Stay and play in Delhi, if any accident, you don't want an ALS ambulance going there and the EMT doing something there, because you can take them to a hospital in less than 10 minutes or maybe 15 minutes maximum. So you can take them to a hospital. So it's very rare situation that you have to stay and play. It's just scoop and run. For that, you need patient transport vehicle or the BLS ambulance. You don't require the fancy ALS ambulance in which the ventilators are never used, literally never used. So, so why do you want to invest in such a thing? So, mapping these ambulances would be another important thing which I think would be very critical for not only preventing for pediatric injuries, also for the adults. And when it comes to the hospital, just to add the hospital part of it also, that as Gautam was also mentioning. What we need to understand is that children are not smaller adults. So many times what happens is that what we call as casualties or the emergency departments, the people over there are trying to deal with emergencies of adults. So the pediatric emergency is not really being taken into consideration or not many times a part of the training. If you go to the trauma center AIMS, where is one of the model center, if you can say, where the WHO Collaborating Center, headed by Boyser and Tej Prakash. Tej Prakash sir, they are doing wonders on one thing and many things, but one major thing would be actually getting the resuscitation, the SOPs for resuscitation. And if you go there, there is a scale where a child is put. Then by the height of the child, you can actually assess what is the dose of the things to be given, which is not actually followed in many of the hospitals. So if you see, pediatric emergency care, pediatric trauma care is a very nascent or very young area to be explored in India, and most of the states which have done very good thing in the emergency trauma care system, but their hospitals lack facilities and training for addressing the pediatric trauma. So that's brief.
Thank you very much, Dr. Ashil. A few years back, me and Gautam, we did a very interesting study in Tamil Nadu. Tamil Nadu had reduced their trauma-related deaths by almost 28-30% in just about 2 years' time. So we did the evaluation and tried to find out what is it they did. So they did 3-4 important things, and that helped a lot. One is in many of the hospitals, they established a triage place where patients, when they come, they are assessed for the injury severity and corrective actions taken. Number two, they appointed a trauma nurse coordinator who could handle many of the things that need to be done in the casualty department, in the acute emergency care unit, which really worked well. Third thing they did was provide treatment. So we called it as 3 T's: triage, trauma nurse coordinator, and treatment, and then followed the treatment protocols. These 4 things reduced that by about 30% in 2 years' time, and now it has been scaled up to the whole state of Tamil Nadu. So we have some good examples happening everywhere. Due to paucity of time, we'll not go into very detailed discussions, but I would like to ask each of our panelists at this stage, what is it that 1 or 2 things they really, I'll come to that. 1 or 2 things that we really need to do on a priority basis to address this important topic in the country. So starting with you, Dr. Ali, what are 1 or 2 things that you feel that must be taken up on a priority basis by the national governments and the state governments to promote this agenda of child and adolescent road safety?
I think intersectoral collaboration is much needed, both at the national as well as the state level.
Okay. What do you feel about the data part of it? Anything specific to be done?
I think currently the data systems, the definition of the child and the adolescent is different. So we are not able to actually track. So if we can have a uniform data system, MORTH and the Ministry of Health and the post-crash, so that we can come out some conclusions and good recommendations.
Okay. Thank you. Dr. Geetham, I just would like to ask you, how do we address the safe speeds, safe travel to school, and safe school zones? These are 3 things which are much talked about all over to promote child and adolescent road safety. But what is it that a country like India needs to do in specific and clear terms to address these 3 areas?
So I will just focus on what the schools can do, because we are only focusing on children here. One important thing is, which many people have talked about in the morning also, involve education department and along with proper budgets, establish road safety clubs just like environment clubs in school, but to have very focused activity with budgets for it. And the activity starts with children themselves collecting data, creating database for what are the risks they are facing, and along with experts, but sitting with children, teachers, parents, together develop a whole design proposal. Because involvement of parents and teachers to establish something like this is extremely important. Only experts going, no one has the ownership then. So, and it will not happen unless the education department sends essential directives to all the schools with budget. Without budget also this will not happen.
Thank you. I think a few years back we did a very large study in Bangalore covering about 130 schools where we looked at the road safety scenario around schools and around school children. There were many issues, and I fully agree with you that this education sector needs to be totally involved at all stages of planning, implementation, and further development on that. Dr. Ashil, Mr. Nikhil, from the vehicle safety technology point of view, from the occupant restraint system or any other issues, what are some 2-3 things that India must do on a priority basis?
Yeah, thank you very much. So, agreeing with Dr. Geetham Tiwari and adding to it regarding awareness campaigns, in India, teachers and doctors have a huge influence on parents. I think we need to develop awareness campaigns through schools and hospitals to also reach out to parents, because regarding child safety, parents have a huge role, and it can also be really cost effective. And going on to enforcement side, particularly to child restraint systems, I think there are 2 parts to it. From the central government side, there is still lack of, it's already included or mandated in the 2019 amendment of the Motor Vehicle Act, but it still lacks clarity because there is no age specification. And the second thing is, no safety testing standards has been mentioned. Because if it's not mentioned, something similar to the helmets will happen. Even yesterday I saw cheap helmets or not conforming helmets being sold on the roads. And once it happens, it's very difficult to phase it out. So, yeah, thank you.
Thank you. Dr. Ashil, we know the developments in the field of emergency medical care. It has taken about 25 years now for emergency medicine to become a specialty and to become a part of all the medical schools and some postgraduate courses to be run there and training of medics and paramedics and supportive staff to happen. All this, it has taken about 2 decades. But I don't think we can wait for another 2 decades for the child adolescent area to become more strong. So what is it that you think from a national perspective or at the state level that can be done? You clearly mentioned about the role of ambulances. In fact, I was in one of the states recently where they were planning to buy a huge number of advanced life ambulances. It took quite a bit of convincing that had to be done to tell them that ALS is not the solution to the problem. So similarly, you mentioned about the basic ambulances that are required and to the scoop and run policy to make it more effective. But other than that, in the hospital, with only select facilities having a pediatric emergency trauma care available, what is it that needs to be done at the state level? Do you think an investment in training will help, or an investment in setting up facilities will help? What is it that can provide some good results?
Yeah, just I would like to ask if the medical doctors here, how many are confident in actually doing like putting a ventilator or maybe putting a laryngoscope, so that you are not. The thing is that maybe I think it should start. If one intervention could actually change this thing, is making it a priority in the medical education, because what is done is that casualty posting is a 15-day posting which you are trained. And many times what happens is that the people who are least trained are put in the most important place, that is the hospital's emergencies. So the MBBS doctor, the house surgeons, or maybe the senior resident or the junior residents are put on the task of actually saving the lives. So shifting that from actually making the hospital emergency as the face of the hospitals, and making sure that that's the area where the action happens, that's the area where the life-saving happens. And like I said about ambulances, we have 193,000 ambulances of 173,000 ambulances functioning, of which means that 8 or 9,000 people are having one ambulance. Similarly, if you see the hospitals also, it's a quite number of hospitals in India. 41,000 hospitals are in the repository of the MORTH when it comes to, and also that is taken from the PM Gati. So 41,000 hospitals are there. But the problem is that how many of the hospitals has this kind of emergency? Because emergency many times is not lucrative business for many of the hospitals. Elective surgeries are much more lucrative. Emergency. So involving the private hospitals, involving everyone, making emergency a priority, and making emergency as the face of the hospitals, training enough, and including that in the curriculum of starting from MBBS would be and all the MBBS doctors should be able to at least save a patient from dying. That's the minimum thing which they need to be able to do.
Thank you. I was recently in one of the states looking at their insurance systems, looking at how much money they spend on different types of health problems, and you'd be surprised to know that trauma care is the #1 condition on which nearly 22% of the state health insurance money is being spent. And that's a huge one, because the private hospitals are empaneled. They have to be given the support from the state insurance schemes or from other insurance schemes, and that costs quite a lot. And the state insurance schemes also doesn't cover all aspects of the trauma care. People bear about 25 to 30% of the cost on their own, even though they are supported by different national and state insurance schemes. So it's an important point that we need to remember. I think if we look at the larger policy issues and safer roads, safer vehicles, trauma care and all that, like Dr. Geeta mentioned, engaging the youth is also equally important. I mean, we can design hundreds of things, but if it doesn't meet the requirements of the young people, it's of no use. So let's hear from Avinyam that basically what is your experience, what are your thoughts, and how do you think young people can be engaged and actively made to participate in road safety issues?
Dr. Geetam, if you won't mind, would you want to sit from my place? I would like to stand.
Sure, please come.
Hello, everybody. As said before, I'm probably the youngest delegate in this room. I'm 15. And in fact, I have my board exam day after tomorrow. I'm in IGCSE. I have my math board exam. I, like my friends, should probably be studying right now. Don't think I'm that great at math, but I'm still here today because I think this issue is important, and I think that my voice and the voice of countless children needs to be heard. I'm a Veera Bhatt, and I'm going to talk more about road safety. So the leading cause of death for most of you guys, the thing that most likely to happen for your death is heart disease. But that's not for me. I'm probably, at this age, not going to die of heart disease. I'm going to die on the roads. And this is not going to be during me skiing around in a motorcycle or me, drunk driving. I don't think my parents are going to allow that. But it's going to be me commuting to school, just walking to school. And that's in many low and middle income countries just like mine, like walking to school feels dangerous. 220,000 youth die every year. How is that a number we're okay with? Now imagine this, imagine I'm a 10-year-old child. I'm just trying to walk 1 kilometer away from my school, but the pavement is too high because that adults that built that road didn't consider that I would be using it. It's filled with trees, with motorcycles littered over it. So I walk on the highway. I'm just trying to get to school. I had to present poetry that day in class. I just got full in my maths test. And my life, my dreams, my achievement, my family is broken apart just like that in a matter of seconds. How is that something we're okay with? Our physical vulnerability should not be an excuse to worsen our lives and should not be an excuse for policy indifference and inaction. But the thing is, we are not just victims in this case. We can look at this child, we can look at me, and we can look at all of the other people who are facing these issues and go, oh, poor them. We aren't just victims, we are stakeholders, we are citizens, we are leaders, and we're ready to be involved in these actions of change, involved to get our voices heard. Dr. Geeta, talked about a lot of how it's hard to communicate with children. I'm communicating. I'm wanting my voice to be heard. We are communicating so hard with these adults to have safe streets. But why isn't that being there? We demand safe school zones, as a lot of the panelists and others have talked about. Enforce speed limits, proper zebra crossing, and safe public transportation. Why is it that a 15-year-old is using a motorcycle besides showing off to his friends? Is it due to that there's no other way for him to travel a 5-kilometer distance beside using a motorcycle? Because there is no public transport, because there is no safe walking areas. We are asking for basic protections because we value our lives, we value our futures. We are encouraged by frameworks like the WHO Global Plan for Road Safety and recent global commitments, but these frameworks are there, but the action is what's needed. We can make all the frameworks in the world, all the data, all the research, all the policies, but they'll all just be in the air unless nothing actually happens on our roads. To every government official, every policy maker, every agency, all of you responsible adults here who care about children, prioritize our lives in your budgets, in your laws, and in your urban designs. And include us. We are not going to stand here and sit by having our lives wasted. These kids who are dying every day, the 2 who have died globally while I was making this speech, could be your future doctor, could be your future politician, or could be speaking at a road safety conference right now, but lose their lives on these streets. We need to have accountability for road safety policies. Road safety is, again, as talked about a lot by Dr. Ali and others, is not just an isolated issue. It affects our physical health, our mental health, and education, gender equality. I mean, as a young girl, am I safe walking on these streets? I won't think so. My parents would never allow me to go past 6 p.m. And climate action, of course. There is so many problems happening on the most basic necessity, my freedom to walk. Protecting children on roads is not just about preventing deaths, it's building stronger, healthier futures, stronger, healthier adults, and safer and happier lives. Let's not wait for another tragedy to happen. Let's act now and create a world where being young does not put me at risk of being dead. Thank you for listening and believing that young lives are worth. Thank you, Dr. Ali, for inviting me here.
Thank you very much for bringing out some real issues of young people as you use roads in different ways. So that brings us to the end of this panel discussion. I just would like to highlight a couple of points here as we leave this room. One is basically the numbers that we have all been talking about, the 16,000 deaths in India, which is roughly 20,000 child adolescent deaths in India every year, is only a part of the story. There is a face behind these numbers, there is a family behind these numbers, there are real incidents behind these numbers. Deaths alone don't really make a big impact. There are about 600,000 children at a ratio of 1:30 who are hospitalized for severe injuries. These children leave the hospitals with different stages of disabilities, with some with lifelong impairments, some with major handicaps, and all of them happen at a young age, and they have to live with this for the whole of their life. And anyone who has been working with this would know how difficult and challenging it is. In our post-trauma guidance clinic, we have seen those with even minor road crashes, what we call a cerebral concussion, they become violent, they have memory problems, they have difficulties in information processing, they have cognitive difficulties, they have recognition difficulties. There are numerous difficulties they face even with a cerebral concussion. You can imagine what happens with contusion, hemorrhage, skull fracture, and other types of brain injuries. So the story is not just about 15,000 deaths that we talk about. There are lakhs of children who are affected in a road crash, who live with different stages, and we know that it can be prevented. That's the most important thing. It's not that we don't have solutions. We have enough solutions that have been proven, tested, and shown to be much more effective. We need to remember that one of the important driving forces for much of the interventions to be developed are good quality data, which Dr. Ali mentioned, that we need to have disaggregated data and also look into more of crash investigation to find out where we should intervene to make a difference. The second important thing Dr. Geetam said, which we all need to remember, is people make mistakes. And this is more so in the area of road safety because of different reasons. And it's well established now that simple mistakes made by people should not lead to costly and more precious human lives. And these mistakes can be avoided, and there are effective solutions that are available. The third important thing is that we need to have somewhat more specific child and adolescent road safety policies and programs that are built in the country and integrated with other activities of, say, for example, education sector, which we touched upon, road infrastructure ministries, or some of the NGOs who are working in this field. So many others, there is need for much more integration of road safety in that. There are technologies that are available today, which Mr. Nikhil highlighted, but we need to integrate that again into the practice of people making it available for people and people using it on a regular basis and seeing that they are benefited with that. Safe travel to school and school safety zones, Dr. Geetam mentioned that there are guidelines available for many of these things, and we need to ask ourselves a question: why is it that we are not able to implement it? There is need for efficient trauma care programs that covers pre-hospital, hospital, and post-hospital care. Rehabilitation of children is also an equally important issue in today's life, because these children can't be left as such and to mend for themselves. They need to be supported and taken care. Vehicle safety need to be implemented. Dr. Ashil mentioned about Good Samaritan issues, and still 10 years after its implementation, we have not implemented it in totality. There are only few centers where it is happening, but by and large across the country, still there is a very good report again on the status of implementation of the Good Samaritan Act. Please take a look at it and you will see that it requires. There are also bigger challenges in terms of the prioritization, in terms of the intersectoral coordination, the leadership and governance, the funding, infrastructural policies, and the way we commute. Most importantly, we heard from Avinya, but you see this photograph here of a child. Imagine 600,000 children like this getting hospitalized and then living with difficulties for the whole of their life. We know we can do things, so let's think about this and develop mechanisms for implementing, for developing the right, choosing the right interventions, for integrating this into education, road sector, vehicle sector, industries, many of these things. We also need to innovate. There is nothing that happens, because at the era of artificial intelligence and technology, there are many ways by which we can do it. And also at the same time, we need to make good investments for road safety. And I think these are some very critical issues. As we leave this room, let's keep these ideas in mind and work on it to make our children and adolescents much more safer in the coming days. Thank you all very much for joining this session.
Just 2 minutes I will
and I would like to thank my panelists for giving a very good illustration of what's happening, and at the same time some solutions for this.
Sir,
Thank you all.
Please be on the dais, Dr. Gururaj sir. So, a green planter, thanks to our esteemed panelists. May I request Sugandha and Pooja to please give a green planter thanks to Dr. Professor Geetam Tiwari ma'am.
Dr. Said, a small comment. I would like to appreciate the commitment of Avira and also this young guy in yellow t-shirt, Sham, for the commitment to this work.
We'll also call
Thank
Sham.
you.
Yes, we'll do. May I request a green planter thanks to Mr. Nikhil Abraham. Thanks for joining us all the way from Hagvita in Germany. Green planter thanks to Dr. Ashil from WHO. Green planter thanks to Avira. Sugandha, please. And finally to Dr. G. Gururaj sir, thanks so much for your guidance and support always for the issue of the road safety. Thanks. In the paucity of time, we'll have one-to-one bilateral questions. Thank you so much.
Once again, we'll take a couple of questions. Please hold on. Narayan. Please come in. Gautam. Yes, please. Yeah. Dr. Ali? Dr. Ali? Can we have 2-3 questions from the audience? Okay. Yeah, I just saw a couple of hands going up. who wanted to ask some questions? Yes, please.
First of all, thank you so much for this beautiful session, Avira, Nikhil, everyone. For that, I would like to ask just one question. For example, as a school children and as a college child, for children and adolescents that are traveling in autos, buses, rickshaws, are there any policies that are available through WHO, UNICEF, and even the government of India? In any case, an accident happens by chance, or there are any kind of mental health, policies available or insurance available for that cases. For example, if a child goes through an accident, just like Avira said so, that I cannot travel in a, road because my parents don't allow me to do so. And you mentioned about AI. So in lieu of that, I would like to ask, many children are actually predisposed to actually be on the front lines of PTSD and CPTSD also. My question is that, and Mohammed sir, even you can contribute regarding this.
Can you exactly once again pre-form that guidelines for?
So I was just asking in very short that children and adolescents who are traveling through various means of transport like auto rickshaw, etc., just in case if any accident happens, so are there any provisions, insurance available to those children, adolescents who are then becoming people with NCDs, mental health conditions, with disabilities in India today? That's what.
Availability of insurance.
Yeah, if you look at by the Act of the Motor Vehicle Act, the Section 161 actually provides the provision for there is a fund for that, and under the fund there are provisions for hit and run. There are provisions for any kind of accident, not specifically to the auto rickshaws. Any kind of accidents, there is a provision for providing a medical help. The question comes on the long-term rehabilitation. Currently, the definition of long-term rehabilitation is not really done in the Motor Vehicle Act, and not even in the rules. Any of the rules, it is not given in that. So what we are also trying to do, yesterday Health Department, we are sitting with we had a committee which actually discussed on that. What was discussed is that we need to come out with a rehabilitation protocol also for victims of road crashes. As sir clearly pointed out, now there is a lot of people who require rehabilitation. Even the Act says about emergency care. We speak about 48 hours of free care. Then what happens after the 48 hours? People with spinal cord injury go for a disability, and how we can actually prevent that? So there is and mental health. There is a lot of issues with the mental health. So how we can actually go for a prospective life course approach and maybe taking a rehabilitation as a priority, that is being discussed at the higher level. And the Supreme Court committee has said that they will be inviting the DPWD department also on board for the next discussion, because that there is a responsibility of the other departments also to be looking at the rehabilitation. So it's if you ask whether something is existing now, no, but there are many things on the pipeline. Thank you.
And sir, as you also mentioned, cerebral concussion, that is also very, taken into consideration, that it could have very much mental health consequences.
Yes, yes. Yes, madam, please.
I just wanted to highlight a few points that there should be a rule for the trucks to not to commute during morning hours, because basically car-truck accidents are very common, and trucks are carrying overloaded trucks. They lose balance and they crash with the cars, and there should be a rule that the trucks should be the trucks should be commuting at night only, late night. And secondly, in the highways, there should be a rule that scooters, cycles, etc. shouldn't go, because highways, everybody is driving very fast, and that way the cases of accidents are more for the motorcycles, bikes, scooters and cycles. Thirdly, in a motorcycle I've seen in Gurgaon, one motorcycle driver is carrying 2 children and wife. Means 4 of them are driving together, all together. So this thing has to be, I mean, some sort of a fine has to be levied for such people.
Yeah.
And
Dr. Geetam, would you like to answer this?
my one last point I wanted to say. There are road dividers and culverts there in between 2 roads. Last week, my niece died while crossing the road. She toppled over the divider and had a severe heart attack.
Yeah.
So actually, the first point you said about trucks, in all big cities, the rule already exists. And so actually in Delhi, the trucks are only allowed at night. They cannot ply between 6 o'clock. I think they start coming to the city at 9 o'clock at night.
Yeah.
And at 6 in the morning, they have to stop. This exists in most
cities.
metropolitan cities, but we have observed in smaller cities, the rule doesn't exist. And often the highway is passing through that, so perhaps we need to implement this rule there. But otherwise, the rule already exists. Second one, you mentioned about two-wheelers carrying a lot of... Yeah. So this also the rule, so okay, there were 2 things about two-wheelers you said. Number one, that they should not be allowed on the highways, right? The rule exists, but the reality is that in our country, the ownership of two-wheeler is very high. Motorization in India is happening because of two-wheelers. So I think there the actually solution is to think about designs, road designs, where the two-wheelers can be accommodated more safely. Whether it's a separate lane or the idea of service road where the two-wheelers can go, or having hard shoulders with different texture. So there are a lot of these issues which have to be worked on. And third, you said about two-wheelers carrying a lot of people. So that again is it's an economic necessity. So the answer to that, the rule already exists that they should not do. So therefore the answer to that is we should have better public transport, where people are with reliable, safe, affordable public transport. That is the only way perhaps you can draw some people from two-wheelers, because two-wheeler is a very convenient mode. It has a high risk, but it is very convenient. It's economically affordable. It does not get stuck in congestion. So it's a challenge, but this is the challenge we have to, because no matter what you do, even after helmet is only 30% effective. You still have very high risk if you're using a two-wheeler. And third part that you said is the fault of road design. It should not, the median is designed incorrectly. This toppling should not happen.
Just one comment to add to Dr. Geetam Tiwari. I think one of the low-hanging fruits I see in India is the training of heavy good vehicle drivers, public transport, buses, lorries, because I think that can reduce a lot of deaths, because a lot of deaths happen from getting hit by a heavy vehicle.
Yeah,
Hello.
madam, please.
Good afternoon. I'm Dr. Mubashir Angolkar. I head the School of Public Health at KLE, Karnataka. Panelists, congratulations and thank you. This was really some things we learned, some things we know. And madam, yes, all guidelines on place. Like Avira said, laws, until we don't turn those guidelines into rules, regulations, laws, they're just guidelines. I mean, who gets penalized for breaking a guideline? Avira, my question is to you, beta. I'm standing here as a teacher, an administrator, a researcher. And when I wear these 3 hats and I look at you, first I congratulate you for coming all the way and speaking on behalf of your whole adolescent community, children community. I want to ask you, what are you doing in your capacity? What? Tell me.
So, thank you so much for asking that question. And so I've been doing a lot of stuff related to road safety recently. First of all, we talked about first aid and how that's important. Recently, me and my team last year, we went to a few orphanages and a few government schools, and we taught basic first aid to those kids on when crashes happen, how to treat first aid wounds with obviously from older kids who are biology students. So we taught that first. Secondly, we're planning to make 3 safe school zones in Gurgaon. So again, as we talked a lot about, see, it's very uncool for a child to hear from a specialist that you should wear a helmet. Like, okay, you're a specialist, why should I care? It talks about when children support other children, when youth support other youth, and we all bring a community together. So creating those communities inside school is something that I'm starting in my school and then 2 other schools. And we specifically, there's this low-tier private school called Surat School in Manesar. So we recently did road safety there. Me and my friend Sarah were both in 10th.
When you say road safety, what exactly?
So we talked about why road safety is important. We brought awareness on the issue, and again, the most vulnerable age group is that 15 to 19-year age gap.
Because we have paucity of time, if I can stop you there.
Yeah.
What I really want you all children to do, you know, I mean, first aid and all that, okay, but what you were saying was making the space safe.
Yeah.
And I want you to work towards that. Why will not your school, forget other schools and all, why will not your school, why you children will not stand and tell the teachers that this is not right?
Yeah, so by...
So your, I mean, we can go on and on, but beta, what I want to convey to you and to all is that, see, health is the responsibility of the individual. For all this whole conference, whole day and everything, but each one of us has a responsibility. And we need to take that. We need to, own that. I am responsible for myself. And to make my space safe, I have to do things. So no blame game like you are speeding or drinking or whatever, no blame game. Just make it safe no matter what. And each one of you. So I really, really appreciate, I want to compliment you for doing what you're doing, but I want you to think and make it more, maybe small, maybe simple, but which will have an impact. So if you have made just one school, your school safe, that'll be a model for all the children to make their schools safe. Yes?
That's so important.
Thank you very much, and I think that's a very important point. Youth should also... Yeah, please.
He's the youngest advocate in Bangalore, Sham Shukla. So if you can, 1 minute.
Yes, tell Sham Shukla what you're...
So I noticed a gap, like it's because the students are victims. They themselves might not be like crash, but they are the victims. So I noticed that multiple students and parents were not wearing helmets. Just to understand the gravity of the situation, I conducted a survey. I went to multiple schools. Total of 785 vehicles were surveyed, and I found out that only 42% of parents wore helmets and 4.5% of students wore helmets. So wearing helmet is like 70% of head injuries are reduced if you wear helmet and you undergo accident. So my intervention right now, see, teenagers, no matter how silly or stupid it is, if one guy shows it's very cool to anything, they start following. So my thing is to make helmet as a cool thing and not just as an enforcement. So just building a habit, not punishment, and in schools, making colorful helmets and competitions.
Yes, you're right, Avira. That brings to you also that why don't you teach children in your school how to cross a road, safety measures. We start very small. And Dr. Gautam had, I don't know if he's here, and he had a photo of intersection place where maximum happens, and I was telling him, my observation, when the light goes green, everybody wants to cross the road. I mean, I am driving, waiting for it to go green, because then I go. And those who want to cross that road want to cross it when it goes green for the vehicles. So this just shows that they are not aware of seeing, and probably, madam, that, walkers, red, yellow, green.
No. Yes.
But it is not
No,
happening.
let's...
Idea is oldest, ma'am.
Children will cross the road whenever it is convenient. As a motorist, your responsibility is to stop.
Yes, it is, but I am not denying my responsibility, ma'am. That was the first thing I said. But I said creating that awareness among them, or a light for them also.
In
no,
fact,
no, ma'am. Washing hands.
in
ma'am,
fact,
as a public health person, washing
I'm sorry, I
hands.
need to bring it to a close because the time is running out. We'll just take one more question from there. You can all discuss it during lunchtime and get into more detailed discussion. Please keep your question or comment very short. Aman here? Yeah.
Since I'm Amar from Center for Environment Education, and we have been working a lot with the schools and trying to improve school zones to make them safer. And my observation is that we are kind of taking child road safety as synonym of educating a child about road safety. It is not about that. We need to understand that children, by telling them that they should be doing certain things, and then putting the burden of responsibility on child is completely wrong, and it is not going to help us take us anywhere. Even for the example of green light, if you read in the textbook, it says when green go, red stop. Whether this is for a pedestrian or motorist, it is not clear. So if it is a green, as a pedestrian, I will start going, which is putting me on risk as a child, which is completely wrong. Therefore, and even when we see risk-taking behavior, it is not risk-taking behavior. It is having no or poor perception of risk. They don't understand this. Therefore, it needs to make systems such that it factors those risks, that people will behave in certain way, and then we have to design the system.
Yeah.
The point why I want to make, then other than children, all other stakeholders become important and critical, and are we thinking about them? Those are road making agencies, those are traffic police, those are RTOs, school education department and teachers and parents. Law says child has to be secured by making them wear helmet. It is the responsibility of the adult. It is not the responsibility of child. Similarly, what is that we are doing, because these people, the adults in the system, are not understanding the need for childhood safety. They just give a simple solution that we have to educate child, which will not help us going anywhere, and we have very little time, just 5 years to achieve the number of reduction of 50%. We need to be very mindful about it and working on the important elements in the system, and then trying to make them or educate them or sensitize them in their role and how they should deliver on those roles to make the roads and the systems kind of safer, and that is what safe system approach tell us, and we need to move towards that.
Yeah, thank you very much. And I think there are some cities in the US where they have introduced a system where they are taking away traffic lights, because it's created so much confusion as to who should cross the road, who should go forward, who should go backward, and when to stop, when not to stop. So there are a couple of experiments that have taken place by removing the traffic lights, bringing very powerful legislations that if you touch a pedestrian, you are really in trouble. Not just trouble, very big trouble. So there are quite a few things that are happening in different ways. Let me just have a look at my watch. It is 1:04. Yeah, there is another session after this. Please feel free to discuss with our panelists and continue this dialogue. Thank you very much to all, and thank you very much to all our panelists.
Good afternoon, everyone. My name is Mansharan, and I'm here with my colleague Surbhi, and both of us would like to wish one a very warm welcome to all of you for finding time on a Sunday afternoon uh, on behalf of the entire team at CHAI. This is a subject that is very close to our heart, and both of us have worked together in the SRH team here for the last 4 years and have interacted with many of you also over the course of these past 4 years. So today this session is all about how do we really start looking at or expanding the narrative of family planning and expanding the narrative of sexual and reproductive health as a portfolio, and what are the other ways that we can look at our conversations. And we really want to keep this very interactive for the next 90 minutes. We really want this to be like a workshop where everybody can suggest and give inputs and participate, and we're very excited about the next 90 minutes. We hope to actually turn a lot of, there's a handout that we've left, which is also a more detailed version of some of the work that we will look at today. But we would love to keep this as an ongoing dialogue even after this workshop. This is the starting point, and I'm very excited. And thank you again all for making it. I'll hand over to Surbhi now, who will sort of guide us over the next 90 minutes.
Good afternoon, everyone. My name is Surbhi, and I'm delighted to be hosting you all for today's session. A very warm welcome again to today's session on strengthening SRHR services for maternal and neonatal health through expanded access to birth spacing and delaying interventions. And thank you again for choosing this workshop, especially when there are several parallel sessions ongoing. Today we have an exciting panel lined up for you, featuring 10 incredible speakers who will bring rich and diverse experience and important perspectives on this topic. I must say that this cozy and intimate setting offers us the perfect environment for meaningful deliberations on a timely and critical issue, and for free-flowing exchange of ideas and to chart a way forward. Today we will explore vital linkages between family planning and maternal and child health, and examine how the timing and spacing of pregnancies and childbirth play a transformative role, not just in improving health outcomes for women and children, but also in driving broader benefits for families, communities, and the nation. Our discussion is firmly rooted in India's current priorities and strategic vision for family planning. This is aptly reflected in the theme for World Population Day 2024, which was healthy timing and spacing of pregnancy for the health and well-being of mother and child. Expanding access to delaying and spacing interventions is central to FP 2030 vision and of Government of India, and it is critical to advance progress towards multiple sustainable development goals. So without further ado, it is my pleasure to invite our chair for today's session, Dr. Sumita Ghosh, to set the stage for the discussion. One second, we are just loading the presentation. Dr. Sumita Ghosh is a distinguished public health expert with over 38 years of experience. She is currently serving as officer on special duty at Niti Aayog and has previously held pivotal roles in the Ministry of Health and Family Welfare, including additional commissioner overseeing child health, adolescent health, aspirational districts, and abortion care programs. Thank you so much, ma'am, for agreeing to chair the session. We would like to hear your remarks, opening remarks, ma'am.
Commissioner and abortion services, so and maternal health. So I always think that this connection which should have been there, that narrative, as you said, narrative has not been properly set, and that has not been worked upon.
set the context, family planning program, the oldest program, India was the first one to have a national program on family planning as early as 1952. Then the journey has happened over the years, and at one point of time, it has become family welfare program. So rightly so, because family planning is not only about the size of the family, it is about the health and welfare of the family, the mother, the child, the family, and in that way, community and the nation. So that dots, that connections, that it is so very important for health of women, health of mother, not only the after pregnancy, but throughout the health and throughout the life cycle, as well as the child, neonatal period, child period. So there are enough statistics NFHS 5 has thrown. I think those will be discussed in afterward sessions, how the global, the national scenario is, how the perinatal mortality, is 50 per 1,000 if the birth spacing is less than 15 months. How the maternal mortality, 30% of maternal mortality is due to this infrequent, frequent childbearing, early childbearing, and pregnancy associated complication, which can be easily prevented by proper birth spacing and family planning. So lot of statistics are there to show, and I think this discourse has to happen, and the dots are to be connected, how these maternal health, child health, family planning, they birth spacing, they really matter. The two most major pathways, because I have been in abortion care services also, is that unintended pregnancies, prevention of unintended pregnancies. Because of I have one child, I have gotten pregnant very early next. So that kind of pregnancies can be prevented, and those pregnancies mostly result in 60% of them result in abortion, and half of them may be safe and half may be unsafe. Again, the maternal health, the survival is at risk. Then the child mortality, it is early pregnancy, frequent pregnancy, multiparity, all these things are very, very intimately associated and impact the health of the child and the mother. So that focus has to come. Now MMR has come down 97, I think. So further how we can go, then this is very important, and not only mortality part, the survival part, the quality of life part, the economic part, the education, the career, the social impact. So this spacing and delaying this area of family planning, TFR has come down. Definitely it has come down. So one purpose for which we were so focused upon that may not be relevant in many parts of India now. The main promotion should be on around these things. So in this context, I think this is we are going to have very exciting sessions. Of course, it is post lunch, so I think that will not be impede the flow of things, and so many sessions are there, and I'll be very happy that our discussion start on this. Thank you.
Thank you so much, ma'am, for your remarks and for setting the context for today's discussion. We will now start with a brief presentation to discuss the learnings from our analysis that WJCF conducted on the impact of spacing and delaying intervals on the maternal and child health. For that, I would like to invite Manshran to the dais. Manshran leads the reproductive maternal and child health programs at the William J. Clinton Foundation since 2021, and I'm very excited to invite her to the stage.
Thanks, Surbi. So we will take about 10 minutes to maybe just touch upon very, very briefly some of the work that we've done, which is basically econometric modeling analysis, which we've done with the help of Professor Joe, who's in this room seated at the back and who will be here shortly. So this is just one of the many ways of looking at all of this data, but so my submission would be, let's look at this as a starting point. It's a journey to say that what is the first level of analysis throwing up. Then there could be, I would also request you to keep a lens on of what are other analyses which could be logical follow-ups to this first piece of work that we've done. So I'll give that context. So we'll take about 10 minutes and then sort of dive into our discussion. So here's a few data points that I want to lay out as context. So if we first look at the leftmost side of the slide, we see that around 10 million births are in our country, which are first order births, which means that's the first child happening, and we can see around 15.5 million, which are second order births. Now if we look at both these bars on the left hand side, it's a staggering number, which is in the 0 to 2 year spacing, which means in the first, right after marriage, the first order childbirth, 64% of them are in a less than 2 years zone, and 83% of them actually happen in less than 3 years. So this is just a fact that I would like all of you to bear in mind, that what is the actual first order birth delay from the point of marriage. And the second one is the second child and the first child, and that again we see that it's upwards of 57% if we actually look at 3 years and below. So that means we see the first child very, very soon after marriage, and the second child coming in again very soon after the first child. The second data point, which I want all of us to just carry with us in this room, is that what is our current labor force participation rate? And which stands at 79% for men and stands at 37% for the female population. So this is again a data point for us to sort of just keep at the center of this conversation. And the third part is, which I think for many of us will be common because we all work in the space of maternal and family health, which is a lot of child health and anthropometric outcomes, which I've just kept here for reference, which is the prevalence of stunting at 35%, or looking at child mortality per 1,000 births, as well as looking at our IMR and under 5 rates. So these are the starting points, right, for us to start. And this was really where all of this conversation started, that what is the interlinkages. So right now these are 3 pieces of discrete information sitting on this slide. And how do we start looking at and connecting one with the other is what our attempt is going to be. Why did we do this? A few different reasons, and one of them to really look at what is the impact of family planning beyond family planning, which is on gender, which is on economic empowerment, which is on our economy as a whole. And how should we, and I said at the beginning, to really start to change the narrative, which is to say that beyond our TFR goals, how can we frame family planning to say that what are the benefits, and how should we start looking at that in the context of a country with a very young population? We have 253 million adolescents. How do we start changing the narrative? And really to look at the benefits not only from a labor force participation, income levels for an individual, income levels for the economy, looking at household level benefits for over, like, let's say GDP contribution over a decade. So these are some of the reasons why we wanted to embark on this journey. And also to drive better integration between programs. Like ma'am said, how do we connect the dots? It's all interconnected. So that was also at the root of this. The reason why we really invited and looked at a very diverse group of people in this room, we wanted to look at one, what is the learning that we could have as a program? What could be programmatic linkages that we can carry forward? What is the impact on our strategy as family planning, as a portfolio? How do we have more targeted, more impactful interventions? How do we mobilize investments? There are many people in the room. We have Madhavika. We really want to think about how does this wider narrative inform greater investments into family planning? How do we engage more with Indian philanthropies? How do we drive interest in this area? does gender or economic empowerment offer a slightly different lens to the program and expand the ambit beyond saying it's family planning? And really also to think about what are further pieces of research. You know, I'll lay that out there as well, like this is the start, what else can we look at? So these were a few different reasons. I'll just touch upon this very, very briefly, and we have detailed handouts which capture our methodology as well, and happy to take that individually. But we basically have looked at family planning and contraceptive use, and then looked at benefits which were in 3 categories at a household level, which is more people who are earning in the family, more people who are working, and what is the discretionary wealth and income as a household, and what is the developmental potential also which is achieved by the children of that household. We've then looked at also economic level benefits, which is that over a 10-year period, what are the benefits that come or accrue to the economy, which is to the GDP by better labor force participation, and also higher spending to the economy. And then we've looked at social level benefits, which is in the realm of women's empowerment, better decision making over things like reproductive choices, or better decision making about, let's say, financial autonomy and whether I work, and essentially a more productive workforce. So this is really the context, and we've looked at a multivariable logistical regression which sits at the backbone of all of this analysis. So what we'll do now is I'll invite Surbhi, and we will just briefly touch upon both. We've looked at spacing and delaying, both. So we'll share that very briefly to say what were the learnings that were coming out from the analysis on spacing and then on delaying, and then we'll break into our discussions. We actually had invited another speaker from Guttmacher, and they've done a different piece of analysis, but our speaker is on a flight and the flight is delayed. So we may get her in a little bit later into the discussion, but for now we'll just look at the India level analysis, and this is essentially from NFHS 4 and NFHS 5 data amalgamated. So I'll invite Surbhi to take us through.
May I request you
Sure.
to give us 5 minutes to inform about the VHAT program that we were doing the last 1 decade?
Sure, so maybe towards, we'll just find, we'll just find, absolutely. We'll keep this as a free-flowing discussion,
Thanks, Manshan, and I hope the few slides that we have presented so far gives you a picture of how and why we approached this analysis. I'll now briefly talk about the key findings from the analysis. The handout that you may have seen also talks about the findings, so I'll not spend a lot of time. The idea is to just give you a glimpse of the findings that we are seeing from this analysis and base our discussions on those findings in the second part of the session. So I will discuss the findings that we had looked at both the spacing benefits and the delaying benefits. By delaying, we really mean here the difference between the first child, the time duration between the first child and the marriage of the women. So that's how we have defined delaying. So we had looked at the benefits being accrued from increased spacing intervals and delaying intervals. I'll briefly start with the spacing benefits first. And like Manshan mentioned, the objective of the analysis was to see how and what the NFHS data tells us. So this analysis is rooted in the publicly available NFHS data, which gives us information around both the outcomes, maternal and child health outcomes, as well as the delaying and spacing interval information. So what we did was to look at this analysis, look at this data and compare, apply logistic regression to understand the association between the spacing interval and how it translates into impact for child health and maternal health. So the first chart that you see towards the left here it talks about how the child development potential, specifically stunting and underweight, changes with the spacing interval. So if I just talk about the key summary here, if you see if the interval between the two child is 0 to 2 years versus 3 to 4 years, you would see in the first chart here that there is that the chances of stunting reduces by 15% almost if the spacing interval increases from 0 to 2 years to 3 to 4 years. We also looked at how underweight parameter changes with the spacing interval, and what we found was that there was about 17% reduction in the chances of the child being underweight if the spacing interval increases from 0 to 2 years to 3 to 4 years. Now this is what we this is the analysis from the NFHS, but we also wanted to see how what will be the implications of this at a population level. So to do that, what we did was to look at how many women currently have children between, let's say, a spacing interval of 0 to 2 and 2 to 3. And in a hypothetical situation where all women were to, let's say, have their increase their spacing interval to 3 to 4 years, what will that lead to? So basically, in the second chart that you would see, what we did was to assume that all 0 to 2 all women with spacing interval of 0 to 2 or 2 to 3 are going to, let's say, have a spacing interval of 3 to 4 years. And when we did that, you would see that at overall level, there were about 546,000 children who were found to who would have lesser, adverse outcomes because of this change. So now, if we so that was one, let's say, parameter. We also looked at how the mortality indicator changes with respect to the spacing interval. You would see here on the first graph that if we look at the spacing interval, if we increase the spacing interval from 0 to 2 to 3 to 4 years, there are 53% higher chances of lower IMR in between these two. Similarly, then we applied this analysis, these numbers, to the population level data to see what will be the implications at the population level or at the country level. In the last chart, you would see that if all women were to increase their spacing interval to 3 to 4 years in a year, there will be about 152,000 children who will not die because of adverse outcomes. So this really shows the impact of how spacing interval can lead to reduction in the mortality and improvement in the development outcomes of children. Yeah. So third parameter that we looked at was under 5 mortality. We found very similar results from the under 5 mortality analysis as well. Now here, if you look at the first chart, what we found was that if the spacing interval increases from 0 to 2 to 3 to 4 years, there is a 56% chance that there will be no under 5 mortality. Again, very significant, significant findings from the NFHS data. Now, when we apply this to the population, we assume that all women currently who have spacing interval of 0 to 2 or 2 to 3 will move to 3 to 4 year interval. And what we see is that around 40,000 more children will live or will by the age of 5 if they were if the women would have had a spacing interval of 3 to 4 years. Now, to summarize this analysis, what we did was to, if you look at the left hand side, there is overall improvement in the mortality. You would see that about 1.9 million children can be potentially saved, their lives can be saved if the spacing intervals were to increase to 3 to 4 years. And this is over a period of about 10 years. So you wanted to see a holistic, holistic implication of how this would look like over a long-term period. And what you see here is that there are 1.9 million children who can be potentially saved if the spacing interval were to increase by 3 to 4. Similarly, if we look at the development potential of children, which is basically whether children will have lower chances of stunting, wasting, underweight, you would see that over a 10-year period, the analysis estimates that about 5.5 million children would have reduced chances of being stunted or underweight. And to root all of this in how this will lead to economic benefits for the families and for children, we applied the number of children saved and the number of additional, since due to the added benefits of not being stunted or underweight, how would that lead to the improved income for the children and for the families? And that results indicate that about $135 billion are expected to be added to the national economy if all women were to space their pregnancies by 3 to 4 years. Now, we understand that all of this is a hypothetical situation. Potentially, not all women will space their pregnancies to 3 to 4 years. However, this is to show the potential impact as to how the benefits would look like. And of course, the real benefits would come based on the actual numbers, based on how women decide to space their pregnancies. But the objective of this analysis is to show the potential impact that can come if women were to space their pregnancies by 3 to 4 years. Now, I'll quickly move to the benefits that may accrue if women were to delay their pregnancies or increase their delaying intervals. Again, the first chart here would shows how the employment rate for women is expected to change if the years of delaying between the first marriage to the first child increases. So you would see here that if the delaying interval is 0 to 2 years versus 3 to 4 years, there are 30% higher chances that women would be employed if they were to have a delaying interval of 3 to 4 years. Again, this data comes from the NFHS logistic regression. We looked at the number of women who have different spacing or delaying intervals versus how their employment rate looks like. And this analysis indicated that there is 30% higher chance of women being employed if the delaying interval is 3 to 4 versus 0 to 2. I will again not go into the details of the chart that you would see on the right hand side, but directly come to the results so that we can sort of use this time for the discussion in the second part. So just to summarize the findings here, what we see is that there is 30% higher chance of women being employed. Now, how would this lead to the, what will be the implications of this on the country and on the society? What you would see here on the second infographic here is that there are approximately 3.9 million women who would potentially get added to the workforce if they were to delay their first pregnancy by 3 to 4 years. Now, how would this translate to economic benefits? If more women start getting employed, this would result in additional income, not for the families but for the economy. And if we multiply this by the average wages that women were to get if they were employed, this would then translate to about $108 billion being added to the national economy in the hypothetical scenario where all women were to delay their first child by 3 to 4 years. And we also try to look at how and whether there is any impact on the maternal health due to higher delaying interval. What the results indicated were that there is a chance that 9.3% fewer women will have lower BMI at the time of childbirth if they were to delay their pregnancies to 3 to 4 years. Similarly, if we translate this to the population level, we see that this would result in 1.5 million fewer women having lower BMI if they would have delayed their pregnancy, first childbirth by 3 to 4 years. I know this was a little rushed, but we wanted to ensure that we give you a glimpse of the analysis. The analysis that the handout that you have in front of you also talks about these findings and also gives you a glimpse of the methodology that we have used. We are of course happy to take up any questions, but now I think before we start our panel discussion, I also wanted to play a video that will sort of root the discussion into the overall discourse at the national level. And to do that, I will quickly play a video and then you would move to the panel discussion. We're just figuring out I think they've put the wrong video, we're just figuring it out. Sure. Alright, we're just okay, I think we can start with the panel one, and I think they must have added the incorrectly. Alright, so Okay, let's move to the panel one. In the meanwhile, we'll figure out the video. So for the first panel, I would like to invite the moderator, ma'am, chair, ma'am, to the dais, and also moderator, Dr. Kirti Iyengar, to the dais. Dr. Kirti is a director SRHR with the. Can you also? Yeah. Dr. Kirti Iyengar is director SRHR with Children's Investment Fund Foundation, where she steers investments on SRHR across multiple states of India. Dr. Kirti brings 3 decades of experience in global SRHR to the work. She is passionate about finding ways to close the research to implementation gaps and expand choices for healthcare for those at the last mile. Welcome, Dr. Kirti, to the panel. I would now hand over to you to invite these speakers.
Thank you. Thank you, Suti. So I would like to invite our speakers, Shankar, Dr. Soumya, Raghavendra, and Madhuvitra. So I put a very brief introductions of all the eminent speakers.
Sure.
Yeah, so Shankar is a seasoned public health and social impact leader with over 18 years of experience in designing and scaling innovative health system solutions. And he's currently a senior global technical advisor at Connect India, which is a Tremonics, which is affiliated to Tremonics. Okay, so and sorry. Yeah. Dr. Soumya Ramesh is an epidemiologist and public health researcher with over 2 decades of experiences over maternal and newborn health, nutrition, sanitation, and HIV/AIDS. She is currently executive director at Population Council Institute, and she has led several impactful research and program initiatives. Welcome, Dr. Soumya. I would now like, sorry, my papers are all messed up. Raghavendra Rao, he is a director Portfolio at India Health Fund, where he leads impact fund in support to innovative health technology startups working within infectious diseases. Welcome, Raghavendra. And I would like to introduce Dr. Madhuvitra Bajoria. She is the executive director of the Health Impact Platform at AVPN, which is India's largest network of 600 plus social investors in 35 countries. And she is setting up AVPN's health practice with the role of moving more financial and non-financial capital and Asian leadership toward building a strong and resilient health system. So welcome all the speakers. So we would just, we just heard all the evidence that Mansharan and Surbi shared about the benefits of delayed and spacing. We heard that how spacing interventions can lead to up to 29% reduction in under 5 mortality rates. While when you look at the child mortality, like people who are dealing with the child health and child mortality, family planning and delayed spacing, very rarely appear. We also heard the enormous benefits that delayed interventions bring, which is actually should be very common sense. Everybody knows that how women who want to pursue their education and employment and be independent financially, they would like to delay the first childbirth. However, in India, the gap between marriage and first childbirth is very low. And the NFHS 5 data shows that only 11% of women had used a modern contraceptive before their first childbirth, which means that 89% did not use any. And that is one of the reasons that we have a very short gap. And many women remain out of workforce, and I think Surbi and Mansharan have shared very good experience with, very good research findings with us, which are very relevant. So I would not delay much, and I would just start some of the questions so that we have sufficient time for the speakers. So, Shankar, like you have so many years of experience, I just wanted to ask you that if we want to embed the D-lane and space-in within the existing health system efforts, what steps do we need to take within the health systems? But also, what could be some of the financing levers, for example, in budgetary allocations or incentives or others that could accelerate the update of D-lane and space-in?
Sure, thanks. So, congrats to the CHAI team for starting to build the evidence agenda. The first point I want to make is what's going to be relevant to this discussion now. So, generally the accepted principle in family planning is काम हमारा हो गया है, ठीक है? So, this is not only amongst the civil society, but also among bureaucrats, but also among the general population that our TFR has reached a certain level, and so we need to reap the demographic dividend. But some of us who have been working in sexual and reproductive health for so long, I think we need to get back to 101 of SRHR. So family planning for me, and this is how I have begun to think about it, basis the last 3 years of experience that we have had in 2 investments. One is USAID investment and now with the CIF investment. I've traveled extensively across cities, districts, countries. That's where you see the manifestation of all the things that go wrong when you don't consider family planning as the bedrock of primary care. So the first is terrific work. So I was in Pimpri-Chinchwad Municipal Corporation recently, and you can Google it. You know what the Municipal Corporation Commissioner and the Health Commissioner are grappling with? 2 hafte ka news hai. Increase in maternal mortality. So that's the manifestation of something that's happening in primary healthcare. You go to Warangal or you go to Guwahati, you talk to executive or the bureaucrats. You know, most of them are worried about stunting, right? Most of the bureaucrats are worried about stunting. And when you see this manifestation, then for me who have been with family planning for so long, I see that that conversation on family planning has fallen off the shelf. Nobody's talking about family planning. So the first thing I would like for us to focus, and this is a great start, is build the evidence agenda on why family planning is the bedrock of certain chronic challenges that India has had, right? ये stunting, underweight, ये आज का नहीं है. हम पिछले 40-50 साल से इसे grapple कर रहे हैं. So fertility rate is good. You have got it under where we want it to be, not in every state, but in some states. But we have to start talking about spacing and SBI, right? It's very crucial, and why is because it's direct correlation with stunting, wasting, right? So that's the first order effect. And the way we have to start thinking about it is how we can get the details into the narrative at 2 or 3 critical documents. One is I would allude to FP 2030, terrific document on high impact practices, so I'm not going to go into it. All of you know about the FP 2030 document. Some great work that has been done by Challenge Initiative at a city level on incorporating. So how do we start reframing this narrative on policy? So for me, I think one way to think about from a policy structure is in key documents, FP 2030 documents or guidelines at a national level, we need to start thinking about family planning as an important building block like water, sanitation, nutrition, education and family planning. So family planning takes precedence. It's not like it's the 9th among the 12 buckets of primary health care. वो narrative नहीं चलेगा. Because family planning underpins everything. If you want to attack these chronic problems on stunting, wasting, maternal mortality, infant mortality, and manifestation of the symptoms you only see at the last mile district level. So that's one key argument, and terrific job. I think you're building that evidence agenda for that. The good news, since 2013, 2014, I think by and large, many things have gone right in this country. So infrastructure, physical infrastructure and digital infrastructure has taken care of all the access key issues. Commodity security, the private sector has done a wonderful job, at least for condoms, oral contraceptive pills. Sterilization is a method that the country knows well and has adopted. Sterilization is doing well. So the key question, and we have some terrific history and record with IUDs and PPIUDs. Good work, great state capacities exist. I think the key thing about spacing is how do we change the narrative? First instance and insight I thought your analysis does is it time for us to move away from that 24-33 month? We are hung on to it. 40-50 साल से आप फैमिली प्लानिंग का स्लोगन देखो, हमारे दो साल का अंतर, ये जो हमारे ज़ेटगेस्ट बन गया है पॉपुलेशन पे और ब्यूरोक्रेट्स पे, we need to reframe that. I think it's high time for India to decouple from global frameworks and say what's relevant for the Indian context, because we have some chronic challenges, right, that are linked to family planning. So is it 33 months or 36 months? How do we build evidence for the first order birth and for the non-first order birth? I thought it was terrific. You were showing correlation between which fetches you greater impact. I think that's how you build the evidence. And so how do you do that? That's the second thing. I think this should now be thought through. So how do we move away from the 24, 33 months and move away to a much more India contextualized, because those are the national level. At the state level, from policy, I think the interface for citizens, women who want access to great information, counseling, products and services is essentially Anganwadi and Asha. So I think it's important to recognize that that continues to be very relevant for the 90% of population, which are India 2 and India 3. So the poorest of the poor and the low income, right? One of the good things that I have heard happening is their capacities are constrained at the last mile. So if you want to increase counseling and outreach services and quality of outreach services, which are already there in the national guideline, I think what Tamil Nadu has done post-COVID is very interesting. So they have just added one more person on contract to work along with the frontline workers. And that's reaping enormous dividends across every primary healthcare metrics. So nutrition, on stunting, wasting, on family planning counseling. I think it's important to understand whether that could be a way out, at least in sub-MPV districts where you have hit suboptimal levels on birth order, right? So I think it's important to consider whether an addition of one more person at the last mile works from a policy level. Let me come to the next policy thing. So for private sector, I think India has done a terrific job. Make in India has really done wonders. Not sure how many of you know Indian pharmaceutical companies are the largest exporters of all contraceptive methods, including hormonal IUDs. Okay? It's a little tragic that hormonal IUDs still aren't part of the government commodity basket. Implants aren't still produced in India. From a spacing perspective, I think it's important to understand. It's not that pharmaceutical industry in India doesn't have the capacity. They have the capacity, but the incentive needs. So given the current constraints and incentives, it might be important to understand what could be the incentive for our pharmaceutical industry to produce implants, because government continues to procure it through UNFPA systems. बहुत कम आता है, it's a very fragmented market. So that's an important part. Financing. I thought it was very important that Kirti asked that question. So I think kudos to the existing philanthropic donors who have kept at it on all new product introductions. So DMPA, we have had that consistent investments over the years, and we are just about beginning to see how DMPA is increasing in value and volume. For hormonal IUD and implant, there hasn't been any investment per se in a very concerted manner. We are just about beginning to see those investments coming from philanthropic donors, and a lot of them are invested in improving state capacity and private sector capacity to increase value volume of implants and hormonal IUDs. But let me state some good things that are happening. We did an analysis of local procurement across PHCs, right, for hormonal IUDs. So increasingly we find traction that women are going to PHCs and asking for hormonal IUDs. So that's a good start. So can we bring it up to procurement, commodity procurement for hormonal IUD? It's time to be a little practical. Implant बनने में 2-3 साल लग जाएगा हमें, तो तब तक तो हमको hormonal IUD के साथ काम चला सकते हैं क्या? So that's one important thing. The second thing is the current investment on implant by CEF. I think it's a wonderful opportunity for us to grow the implant market. The barrier to performance there is actually private sector providers. So we still don't have a big denominator of trained and skilled providers. And also the different levels of providers. Right now, skilling and provision is restricted to qualified MBBS and OBGYN doctors. So one way to think about in terms of policy and guidelines is, can we expand it to other categories of providers, including Ayush providers, right? That's where the footfalls are. Yeah. And the third level is looking at the incentive systems for ASHAs and FLWs on SBI. So I know Mukesh is here. I think there are some great learnings. So there is a 500 rupees or 1,000 rupees incentives on the first order and the second order the way we would want to think about incentives for demand creation is change the broader narrative on this 24 months, 33 months, but also incentivize probably the consumers directly on doing the right behavior. I think the government has terrific experience on DBT. They have the infrastructure now with Aadhaar and other subsidy mechanisms. So maybe it's time to think about, can consumers respond to better incentives if they consider first order and second order birth intervals beyond 2 years and 3 years. So that could be one way how you catalyze spacing and reposition spacing that currently exists. I don't think money is a problem right now for Government of India. I just want to make that explicitly clear. And I think we have got enough philanthropic interest now on spacing. So I think it's a good start, good evidence. So let's not ask for more money right now. Let's make the current existing money perform better.
Thank you, Chandra. I think you have touched like such important points, especially like family planning should be the bedrock of all the important public health challenges that we have been facing. And it is really like I felt a little disappointed when I looked at the website of WHO, I hope nobody is there from WHO, where the child mortality, the determinants of child mortality did not mention family planning, at least in the first 7, list of the first 7. So, and of course, this 24, 36, even I go to any meeting, whether at the frontline worker level, I have the same question. So what if a woman wants to delay by 8 years? Why are we only saying 24 months? So I think very valid points. And if time permits, after the first round and after all the rounds, I would like you to also answer what can we do in the southern states where actually the method mix is so skewed, because you have a good perspective from southern states. Okay, so we'll move to Dr. Soumya because we have very limited time. So Dr. Soumya, you have so much of experience with multi-sectoral intervention. So what we want to understand is how can we integrate the delay in spacing within the broader social programs? What would be the potential for using some of these platforms like education, livelihood, skills, etc. For integrating delay and spacing goals?
Thank you. So as we all know, traditionally the focus of family planning has been reducing TFR. Although it's an important indicator, like all the speakers have already highlighted, it has a broader implication. Spacing and delaying has a broader implication. Impact on educational attainment, impact on maternal health and child health, impact on economic empowerment, not just for the women, for the extended family. It impacts household income, it impacts better nutrition for the family. It also has an intergenerational effect. It influences the child's education. So that's the narrative, like the previous speaker also said, that's the narrative that we should take going forward. So there are a lot of case studies where these multi-sectoral platforms have been utilized for example, improving maternal health, child health, nutrition initiatives. So for example, women's group, that has been utilized very significantly in several states for maternal health and nutrition initiatives, like in Jharkhand, Madhya Pradesh, Bihar, UP. Although SHGs were formed not for promoting maternal health or nutrition, it was formed for financial and livelihood activities. Like there are all these opportunities and platforms where we can integrate and promote the spacing and delaying agenda. So for example, schools, ma'am highlighted about adolescents, and schools play a very important role in lifelong behavior change. We have the school health and wellness program, which is a Ministry of Health and Family Welfare and Ministry of Human Resource Development's initiative. This is a school-based health promotion program which is being implemented across the country in all the states and UTs. They focus on 11 key themes in that program. So it ranges from growing up healthy to mental health to interpersonal relationship to reproductive health. So it has a wide range of themes that they focus on, and that can be a platform for reaching adolescents and teaching adolescents about delaying pregnancy. We can leverage definitely the SHG platform because there are examples, prior examples. So just to give one example, in Meghalaya there is a cadre called CGHA, which is Community Gender Health Activists. These are basically SHGs who are given the responsibility of disseminating key messages on maternal health, nutrition, child health to the community. So when we, these are our learnings from Meghalaya also. When Ashas go and give key messages, these messages to the community, to the women, they are looked at as representative from the system. But when SHG members or CGHAs go and give messages to the community, to the women, they are looked at as their own people. So the acceptance of those messages, the uptake of those messages are better. So these are some opportunities that we can leverage and integrate our spacing and delaying agenda. We should definitely leverage technology, especially when it comes to adolescents. We should use technology for creating awareness. So we have, there are a lot of technological innovations, like even here you see so many innovations that are there. So we have eSathi, which is a chat-based digital support system for pregnant women and postpartum women. So where we empower them with appropriate information throughout their pregnancy and postpartum period. What we've done is we've introduced information about spacing during the postpartum period. So there are all these solutions and opportunities where we can integrate, although these are multi-sectoral, they were not designed for promoting spacing and delaying pregnancy or childbirth, but these are platforms that are available to kind of promote this agenda going forward.
Thank you. I think what you have said is enormous potential of self-help groups and all the stool-based platforms. Although we have to see to what extent it will be acceptable to use the stool-based platform for family planning messages.
I would like to add what she was telling, that I was in their stall, what was there. So the pregnancy, this thing I saw, what information and their applications are based. So it happened to me that adolescent is a group which can actually gain from it. Because many service providers are reluctant because of some legal barriers are there in that age group. So but their need is there because they are in the reproductive health, and the reproductive needs are there for contraception, as well as those who are married for delaying pregnancy and spacing. So this I thought is a very important thing, where without actually going through some service provider physically, that they can seek help, they can get the knowledge, they can get the know-how, how, where, what. So that is a very important area, the digital thing, because they are into it. All adolescents are into it.
Thank you, Dr. Sumita. I think that is very relevant. Now turning to Raghavendra, we know that SRHR is not really a priority for many donors. So what would be some of the strategic entry points to elevate delayed and space-in within the agenda of global donors? And also in the current fund-in environment, what would be some of the innovative finance and instruments that we can mobilize to support SRHR issues?
Yeah, thanks, Kirti. I think firstly, let me say I come from an even under-resourced space, infectious diseases, where I can't even have a dialogue like this. I probably am the only funder. Tata Trust is supporting innovation. So for my day job, I support health tech innovations, diagnostics, digital health tools that can be used at primary care at the remotest corners. And when we go there, we see that maternal health is probably the key problem that is being looked at, and we see women coming in every time. So. And I also, in my previous life, was co-managing Adolescents Collaborative at Dasra. And just to pick up on the points that the other panelists like Soumya and Shankar have made, it is important also to sort of evolve as, I know excellent orgs, and I'm not naming some of them because I've co-managed the Makata grant, and through the collaborative, some excellent organization to working on SRHR. But to be actually meet the needs, like where the donor landscape isn't effectively looking at these specific aspects. One is, of course, we can talk about the usuals, highlighting the FP 2030 agenda, the SDGs, not just SDG 3, but SDG 4 and 5, quality education, gender equality. What I'm coming to is the evolution should be that the proposal should also be multi-sectoral. You should look at cross-sectoral linkages between programming being done through, because like everyone was saying, this is a common sense issue, it should be done. But not everyone understands it, especially in the ecosystem where donors are looking at other aspects. So speak their language, and how do we do that? You can look at climate adaptation, because heat waves affect pregnancy outcomes. How do we bake that into our programming? And educated women, again, like somebody very senior was saying outside, a woman is not just about looking at pregnancy and looking at that unidimensionally. An educated woman can bring in better awareness that would lead to multi-sectoral outcomes, and I think the CHAI team has done a great job already of simulating some of those outcomes that could come in. So even the approach to donors should be baking into this. How do you look at nutrition outcomes? How do you look at educational outcomes? How do you then multi-sectorally work your programming to get those? And I'll give you the tangible example. In the 10 to 19 collaborative, there were only 4 key outcomes. Completing secondary education, increasing the age for marriage, increasing the age for first pregnancy, and improving agency. That's all. They are now a 60 million collaborative. So it's about, again, speaking with the right donors, bringing the right collaboration, because somebody might just be interested in data. Somebody might just be interested in educational outcomes, but there is a message that can be sent in a unified manner, doing the incredible work that all your orgs are doing. Secondly, Soumya was talking about digital tools. That's very important, because now you could actually, I'll give you an example of an org we're funding in Rajasthan. It's called Khushi Baby. They have a community health integrated platform, a digital tool that they're co-designed with the state health system of Rajasthan. So there is no risk of adoption ever, because it's co-designed with the state health department. They actually have a digital tool that stratifies risky pregnant women and the various risks that already exist. The tool comes with a stratified risk. This is group 1, group 2. So the interventions are tailored. The ASHA worker or the SHG actually has the right interventions to take them to. They also have, there are other organizations who are also utilizing generative AI-based chatbots. Now women can interact with ASHA workers, interact with SHGs, but there are more questions which they'd like to ask in privacy. So the generative AI chatbots are proving a great tools in actually allowing them to speak to that. So this technology intervention, so while doing the great programmatic approaches all these orgs are doing, you should also bake into your programming these new available technologies, new multi-sectoral, cross-sectoral approaches, and that will make a stronger proposition. And you can even approach funders as a consortium. If there are others who are working in other sectors, but there is a direct impact on the family planning work, that should be encouraged. So that is how you could move the needle. And yeah, I think in terms of innovative financing mechanisms, yeah, all of us know about bonds, how we're looking at impact bonds and measured outcomes, how you can looking at outcome-based financing. To Shankar's point, another important aspect, because there is an involvement of the private sector, it should always be a model that is eventually scalable. You look at what the budget availability is. If you look at a program that is 1.5x or 1x that budget, it will never be scalable. So we need to create a model that actually brings in grant financing to create the evidence, and then bake in private financing, private capital to create that economies of scale, so that it can eventually be adopted by the government. Like Shankar said, there is enough money, but you need to showcase that evidence and showcase a model that can eventually be scaled. So that's my points. Yeah.
Thank you. I think your point about that use their language and proposition should be multi-sectoral, and use whatever avenues like climate adaptation, nutrition, etc. to find entry points. I think very valid points. To cheapen the time, which we have very limited time, I'll now move to Madhvita. So Madhvita, like question which is very similar to Ratwen's question, that family planning is not a priority for many donors.
Yeah.
We have seen that even maternal child health is, but SRHR is not. So what would it take for donors to prioritize investments in SRHR, and what would we do so that they see a value proposition in issues such as delay in rent space?
Sure. Thank you so much, Kriti. Lovely to be here with all of you. As Kriti had mentioned, I am representing AVPN, which is a network of 600 plus funders or social investors from 35 countries who are all mobilizing capital towards impact in Asia. Important to note that these are not just philanthropic funders. Our membership includes impact investors, development finance institutions, family offices, small domestic foundations, faith-based funders, etc., etc. So it's a large network. And we look at climate, health and gender, and I lead our health platform. Our panelists before me have actually done an amazing job of explaining how FP and birth spacing and delaying pregnancies, how it doesn't just have impacts on health outcomes, but such a wide variety of different issue areas. But yet we see public health funding continue to flow through a very issue specific or a disease specific lens. We have been talking about a lot of the work in this space being underwritten by philanthropic funding, but all of us have seen in the past few months how fraught philanthropic funding can be, specifically the kind of philanthropic funders who've been supporting this work, right? I think we all know that currently we might have all our eggs in a few baskets. But at the same time, being an Asian network like we are, we have seen this kind of reimagining of this global financing system as an opportunity, because what we see in Asia are some incredible macroeconomic trends. So 60% of all of the wealth transfer over the next decade will actually happen, and wealth generation will happen in Asia. And there's huge amounts of localized pools of philanthropy coming up in Asia, which creates an amazing opportunity for us to, as an ecosystem builder and as a network, to go out, and me as the health platform to go out and reframe some of these narratives and build a broader tent to engage newer pools of capital. And that's exactly what we've been doing. So for this specific issue, over the last 4 months, AVPN has engaged with 120 new funders across, and new funders, by new funders I mean actors who've typically not been engaged with these issue areas in the way that those of us in this room have been engaging. 120 new funder profiles from family offices, impact investors, philanthropic foundations. And what we have discovered, these are still early insights, what we've discovered is that these complex challenges like the one we're talking about today really necessitate a shift away from addressing women's health in silos. Because I think some of our panelists here have talked about before, if you are a new funder in this space and you know nothing about this space and you're thinking about your portfolio, then then to be approached by different groups that are talking about sexual reproductive health or family planning or maternal nutrition or immunization in silos is extremely confusing. What we have seen work really well is a systemic life stage approach. How does a woman at different critical life stages, how does she intersect with critical health systems? But we still see that a lot of the prevalent narratives in the existing donor ecosystem is yet to fully embrace this integrated perspective on women's health, which is really, I think, missing a crucial opportunity to drive significant long-term improvements on not just on funding outcomes, but also on women's health outcomes. So what we as an ecosystem builder are trying to do is play the role of that honest broker or that neutral convener that can really take a systems level approach to addressing this issue and bringing together relevant stakeholders at different programmatic points of the value chain. So I think we've seen that this can be a great entry point to engaging new philanthropic organizations and family offices across Asia. And I think what we have seen is that by convening and converging distinct efforts on SRH, FP, maternal nutrition, livelihoods, Raghavendra mentioned climate as well, as intersecting areas not just allows us to better direct funding flows, but also broaden the funding tent. And you know, it's very easy for us to go into a room and for someone to say, you know what, I'm not an SRH funder, I'm opting out. So you've lost them already, right? If you go with that narrative. How do we take it very seriously upon ourselves that how do we keep broadening the tent so that nobody opts out? How do we keep them in the room and keep them engaged? So I'll just tell you what it is that we're doing very quickly. So in FP and SRH, we actually have a partnership with the Challenge Initiative that Shankar mentioned, and Bayer. All of you here probably know better than me how amazing it is that the work that they've done. But now as they're thinking of the next phase of the, TCI is thinking of their next phase, they're actually also thinking beyond how can we use this amazing platform that we have built to look beyond just family planning and SRH and actually bring in the immunization and nutrition communities into this platform. And we as AVPN are helping them to mobilize resources with newer pools of capital with this new fresh approach that they're taking. At the same time, we've had CIF colleagues in the UK who've come to us as AVPN, and they want us to build a nutrition leaders program for Asia. So they want us to go out to newer pools of capital and family offices in Asia to engage them on maternal nutrition. Now TCI and CIF have come to us with what they think as distinct projects, right? Help us find new funding for nutrition, help us find new funding for SRH. But what we as AVPN are doing in the background is we're actually merging. We're saying, you marry them. To us, this is the same woman who goes to seek, MNCHN interventions. She's going to the same delivery platforms to seek other key interventions. So, these are, like I said, while they're seen as distinct efforts addressing different issues, they actually both enable positive results on women's health. And we see this as a really critical opportunity to coalesce programmatic and social investment efforts that really take that holistic approach. So now what we are doing, and these are early days, and I'm so glad that I have this platform because really would love feedback from all of you as we build this out. We're building an inclusive funders coalition. This is a Pan-Asia funders coalition that's really going to look at women's health through a life cycle lens. We'll start with SRH, FP, but why not cervical cancer? Why not NCDs that impact, older pregnant women? The activities and outcomes that we are expecting from this funders coalition, one is to foster knowledge and peer-to-peer learning opportunities via convenings and development of knowledge products that shape the ecosystem and enable greater collaboration. Two is capital mobilization towards women's health programming. This can take the form of collaborative pool funds, a pipeline of credible deal flow, a lot of which all of you have. And finally, a really concerted strategic communications campaign to ensure a cohesive narrative that helps amplification of Asian thought leadership on women's health intervention. So I'll stop there, but really look forward to learning and engaging. Thank you.
Thank you, Margarita. This was very inspiring. And I think great ideas that you have as to how we can work, not in silos, but in an integrated messaging. I won't try to summarize all the wonderful, insights that you have shared. I'll hand it back to Surbhi now.
Thank you, everyone. Thank you to Dr. Kirti for moderating the session and all these speakers for their insights and useful remarks. I would now request you all to, we would now invite the second panel for the discussion. And before I do that, in the meanwhile, I'll also play the video. And I would like to acknowledge FP 2030 and Sumita Banerjee here, who have taken lead in developing this excellent video. Let me just play it for everyone.
What is at stake? when we cannot control our lives.
As a young single mother in Nigeria, I understand that I am privileged to have access to family planning. Without this, it would have been financially strenuous for me as a young single mother.
Family planning isn't just about having kids, it's about planning for your future and deciding when and how you want to live your life.
At 25, I am deeply immersed in my passions: singing, acting, content creating.
My journey was made possible because I had the power to choose my timeline.
I'm a business owner and a mother of 2 beautiful boys. Having the access as to when we wanted to have children helped us ensure opportunity and possibilities.
I've always had a desire to have a child, but also always had a desire to have the career that I've always dreamed of. And I knew that if I planned things accordingly, I could have all of those things.
There are many things we can't control. Through planning, I'm able to do all the things I need to do for my family.
These stories aren't rare. They reflect what's possible when family planning is prioritized and accessible.
When women have access to family planning, they can pursue education, careers, and entrepreneurship, strengthening economies. The ripple effects last for generations.
It means that women can invest in their family's well-being, young girls can stay in school, and industries can benefit from the contributions of more empowered women.
Planning your life shouldn't be a privilege, but for too many, it still is. Funding for family planning is under attack. Rights are being rolled back. Progress is at risk.
Family planning should be a basic right accessible to all.
At a time when family planning is under threat, the urgency to act has never been greater.
No one should be denied the ability to safely plan their future.
Let's make that possible for everyone.
Share your story today.
Raise your voice.
Amplify the message.
And let the world know how important it is to have access to family planning.
Stand with us. A brighter future for all, made possible by family planning.
I would now like to invite our speakers and moderator for the second panel. I would like to start with Dr. Bulbul, who is moderating the second panel. She's a senior advisor, strategy and partnerships with William J. Clinton Foundation. I would now request ma'am to invite the remaining speakers as well.
Thank you very much. It's a interesting thing to say, family planning. We are now talking about that family planning is a right, where it has been right for a donkey number of years. So first, I would like to invite my esteemed panelist, Dr. Amit Bhanot. He's the Senior Director with Kinvonics and he's worked in several implementing partner organizations. If I start counting, it will be, end of the day. And he's also worked on impact bonds, so I'm going to ask you something about that also. We have Dr. Indradeep Kaur. She's a public health specialist working with the Municipal Office of the Department of Health at Chandigarh, and she was also earlier State Program Officer at MCA at Punjab. We have Dr. Jyoti Sachdev. Jyoti is also my student. Proud to have such brilliant students, and she's a State Program Officer, Director of Family Welfare, Government of National Capital Territory, Delhi. And the last speaker is, where is William? Yeah, hi William. William Joe, he's Assistant Professor at the Population Research Center, IEG, which is the Institute of Economics Growth. And he's also the co-author of the book which is called Cost of Family Planning in Action in India. So I don't have to go. I'm sure everybody has been talking about family planning, and of course, as Sumita said, India was the first country in the world to talk about having a program for family planning. And initially, family planning was synonymous with population stabilization. And then we moved on, and at that time, if you remember, the slogan used to be, Do ya teen bus, so it was either you have 2 or 3 children and then stop, Then we moved on to Hum Do Hamare Do. That was the slogan. So we keep to 2, And I think that 2 years, where somebody said it's continuing even with the spacing and other things also.
And then I think in 2000 the change happened where we started looking at family planning as maternal newborn child health and adolescent health initiative. And that changed the total discourse of, how you look at the family planning, not only for controlling population, but, the benefit to both the mother and the newborn and of course the child also. And you heard, you saw the presentation, and I think it's very important that now it is bringing out the data which talks about, what is the importance of spacing and also of delaying the first pregnancy. And I think it's important that as we move forward, now that we will be looking, I would say family planning as in a different lens, and earlier speaker also talked about it, that we need to bring out these benefits in our discourse and try and educate from the top to the bottom. I would start with the politicians, very important, because they are the ones who would be speaking to the general public, coming to the policymakers, coming to the providers, all the workers, but most important, the community. I think somewhere it has to be translated into their minds that, typical story in India is, of course, we see the data that the age of marriage has been delaying, which is good, but typically, marriage within 1.5 years, you'll find the first child is born. Within 2 years, 18 months, you'll find the second is there. And then, yes, you don't want to have another child, so sterilization. And that's why if you look at the contraceptive use is very skewed towards sterilization. Because, by 21, you've had your child and you want to, you don't want to continue taking IUCDs, which is now 10 years, but still, why go for that? All the sort of, myths and misconception about that, about, oral pills, who's going to take it every day, implants and other things. So, women sometimes, I would say by choice, also feel it is better to just get themselves sterilized and forget about it. And unfortunately, yes, we have a lot of men in this room, but men have, raised their hands, and we don't find that, vasectomy is absolutely zero, so it is all women who are being now sterilized and permanent method. So I would now, ask my esteemed, maybe start with you, Amit, that, with your experience of so many years, what do you see? What is that we need to translate this into, what we want to change the whole discourse about family planning? What is the more evidence that we require, both from public sector or private sector, to bring out the fact that how spacing and delaying pregnancy is important?
Sure. Thank you, Dr. Sood, and it's an honor to be on the same panel as Dr. Sood, being the teacher from Maulana Azad and Lady Harding, from where I graduated and postgraduate also. But also thanks to Chai for leading this discussion, and for SIF for supporting it, and for other donors and panelists to cover it. I will not cover what the other panelists covered. What I will basically talk about is, we have been trying to do this discussion of how to get integrated women health and livelihoods for the last 3 or 4 years. And I will share some in the sense of experiences around it. So I don't know how many of you have gone through. There's a study, or there's an intervention which was done in Maharashtra and Pune, which is called CHARM, which is Counseling Husbands on Reproductive Health and Marital Equity. And they came out with a lot of papers, and what was exciting about it was they did 5 sessions on gender equity along with family planning discussion. So they said, let's do gender equity discussion with the couples along with the family planning discourse. And they followed the couples for 4 years. And they are just coming out with a paper which is getting published next month. Interestingly, the contraceptive use increased, women's agency and empowerment as by those indicators increased. One unfortunate fallout is sex ratio is becoming more adverse. So as families are getting smaller, there is more, there is an assumption that there is more abortion happening of girl child, and there is a preference for males, because when the counseling was done by doctors, it is showing more adverse selection than when the counseling was done by paramedics or nursing staff. So again, I mean, what I'm trying to say is that it is showing, yes, within a health setting, you should do gender equity, but that health setting needs to be supported by other livelihood interventions where you can demonstrate women's economic potential. And that is where the need for having more integrated livelihood projects which talk about family planning. So पहले जो बात कर रहे थे हम बात करते कि maternal health, nutrition सभी में family planning discuss होना चाहिए. We are trying to say we should go beyond that कि जब आप livelihood के projects करो या women entrepreneurship के projects करो तब भी आप family planning के बारे में बात करो, because then only you will realize the potential for women to become in the sense of more economically productive. Second example, thanks to Ministry of Health and Family Welfare, we have a module for sexual assault on how you can manage it and how you need to follow the guidelines. Interestingly, Ministry of Home Affairs have a women safety division. And Ministry of Home Affairs in 2019-20 developed a kit which is called a sexual assault and safe kit and for examination kit. Now, there are two parts to this discussion. For that kit to be rolled out, it is a great thing, it's a great initiative. NFHS tracks women reporting sexual assault, which is again a good thing that people are reporting, people are coming out, government is encouraging more reporting. What we are trying to see also in that the medical or whosoever examining, they have to do two prophylaxis. One is the STD prophylaxis and the second is the pregnancy prophylaxis. So which comes in that is there emergency pill being used? Now within that kit the emergency pill is not there because the kit from Ministry of Home Affairs depends upon a doctor doing it and doctor remembering it. We try to analyze in the same data sets women reporting sexual violence versus women reporting emergency kit. There's a gap. What I am trying to say is that when you're trying to practice sexual assault cases and gender-based violence also, can we also, when we are trying to sensitize officials, talk about that, look, there needs to be a emergency contraceptive given as a prophylaxis. It can be given by anybody. It doesn't need to be given by a doctor. So that is where we are trying to also see which states are doing it better than the other. So third part is when we are trying to come into what are the applications. So one is this narrative of it. That narrative should be that integrated health and livelihood works. But the next part is how do we make it operationalized on a private sector setting? And is there a science to it? This is technology. Technology is what? The hormones. The hormones are what? There are new technology coming in which is low dose hormones which are third and fourth generation contraceptives more than your Mala D and Mala N. There is now third and fourth generation. In fact, right now in the market, Serum Institute of India is also a manufacturer for oral contraceptive. They were earlier for vaccines. Because there is a growing market for third and fourth generation contraceptives. Now what are these third and fourth generation oral contraceptives? These are contraceptives which normalize your menstrual cycle. If somebody 17-year-old was to go to any place in Europe, this will be the first drug which will be given to her to normalize the menstrual cycle. It also decreases the menstrual pain during regular cycles. It also decreases acne and it makes the skin more fairer. It has lesser side effects than the second or first generation oral contraceptives which are in the market. So here's a low dose hormone in the market, approved for marketing, but not as promoted as other drugs because people fear hormones. And this is very gynecological, which Shankar also talked about earlier, provider bias, where providers tend to hold gynecologists tend to hold these drugs together. But we need to normalize the discussion about hormonal contraceptives. It's not only about menstrual health, contraceptives, and then perimenopausal also. This is the solution which is going to help you out. When we went to talking about it with, for example, village level entrepreneurs. So there is the Ministry of Electronics and Information Technology. They have these common service centers and they are about 600,000 common service centers in the country which are last mile digital connectivity, and they are so much encouraged to talk about family planning. So there is a common service center village level talking about family planning and wanting to know more about it. So there is an appetite when you try to improve health and livelihood together. Second example, Niti Aayog. Just one last example. Women entrepreneurship platform in Niti Aayog. They have a lot of entrepreneurs supported. And last year, on the World Population Day, they wanted to have a talk about hormonal contraceptives. So again, Niti Aayog, Women Entrepreneurship Platform, Beyond Health, how can we integrate further? I'll just stop there.
Sorry, no, I'm sorry, I have to stop, but because we have to move in very quickly. So I'll just come to you, Joe. Can you tell us some more programmatic indicators that we can, sort of work on? And very briefly, sorry.
Yeah, thank you, ma'am. Very quickly, I think family planning program, as you may know, it's among the oldest, and since the database is also tracking so many indicators, I think it is one of the richest data sets that we have in terms of the public health system and what the services are being offered. In terms of gaps, I don't see many challenges there. Only thing is that whatever data we have, we don't use it to its full potential. So, for example, we are interested in, say, total fertility rate, adolescent birth rates, modern contraceptive prevalence rates, and we all look forward to NFHS. But apparently, all of this can be done using the administrative data, which is so granular. And I think only we have to need to just apply a little bit of methods to get that done. So that is something like I will say, we don't need more new data, maybe one or two variables may be added. For example, say if somebody is having a birth, what was the previous interval? Maybe that is something, but largely we have all the data, we just need to convert that into indicators. So that is one issue that I wanted to highlight. The other thing in terms of understanding a lot of spacing and delaying related issues, this is in the domain of very much personal information, which in terms of public data collection efforts may be much difficult to get that, not only from a point of view of asking those questions, but also the point of view of documenting that or entering that data. So it will be a little challenging, but nevertheless, I think there should be efforts to understand it more regularly, because a lot of this is connected with the space of women's agency empowerment, and where we need to understand how it is being taken up in the system. The third point I just want to highlight that, as rightly pointed out earlier as well, we need to have a comprehensive view of the spacing landscape. I think the impacts that we saw through the different results and estimates, these are quite encouraging. And as you will know, like quite of that impact is coming from the fact that as you introduce delaying during say adolescence or early 20s, the biggest impact you get is because there is an improvement in BMI, and BMI leads to a lot of improvements in terms of birth outcomes, which is totally, I think, neglected in some sense. Similarly, we are not also documenting many other spacing related benefits. So we are restricting till some of the indicators, but we can go further and see the cognitive impact on the children, because there is a potential kind of indicator there. Again, I think some of the adverse effects are not well studied. We have to see whether those are really serious. For example, the point of differential stopping was critical. So that also we have to see and examine. But I think that it's very rich kind of data ecosystem that we have for family planning, and lot can be achieved through both say RCH portal or the HMIS data that we have. Thank you.
Thanks, and I'll come to you because you have been implementing the program for a long time. Can you share some of the innovative ideas that you have used in your own program, and what has been the success and what are the learnings from that?
From so many deliberations, first of all, congratulations to Chai for having put that paper. Yes, when we were studying about although the targets in Punjab are well achieved, TFR is 1.6, way below the national target. But when I was looking at the recent NFHS, the demand for unmet needs for spacing has increased over the past 2 to 3 years. For the whole of India, it is 9.9, but for Punjab, it is 3.9. For whole of India, it is 4. For Punjab, it is 3.1, which has increased from 2. So definitely, I think during our implementation of the programs, we have lacked some focus on family planning. There used to be family planning counselors, particularly focusing on the family planning things. And it has become a norm since we have achieved the target. We don't need to focus on that target. But spacing is one thing that has a very direct relation to maternal mortality as well, as has been well explained by Dr. Sumita. 30%, because then first order birth, if it is a cesarean section and the spacing is less, and second is again a cesarean section, that leads to a lot of other complications in maternal health. Child health we have very well documented, but I think maternal health needs to be studied. And then there is a compliance or from the women's side in adopting the spacing methods. So like IUCD, you do 100 IUCD, but one IUCD goes wrong and your public health in that factor fails because, you know, adverse effects of IUCD, there are small villages where you are working. One IUCD gone wrong, the impact is on 10 to 20 villages. That is how IUCD program was not successful initially. PP IUCD rates have been good around 38%. However, the more focus now we are doing on the hormonal or injectable. For that, incentivization has been done for the ASHA workers because there is a breakthrough period. There are a lot many things that women want to ask. So what has been deliberated in the previous discussions, I very well agree with the fact that AI chatbots can be helpful because at present around 70% of women in Punjab have an access to a smart mobile phone. So that can be done in Hindi, that can be done in various languages, and then it is a very personal. And then there is a if you see it in a mental health way, there is a fear in the women to talk about their this intimate health with everybody. Even ASHA they are not trusting. And now what is the present scenario in a public health that ASHA has been apart from RM and CH, ASHA has been burdened with all the things. She has to do the dengue awareness, she has to do the TB, she has to do the NCD. Wherever, when we envisaged the ASHA program, it was to be focused on RM and CH only. So that thing has been diluted for the ASHA. So probably like somebody, Mrs. Shanku was saying in Tamil Nadu, they have some special groups focusing on only the reproductive health and only on this family planning and adolescent health. I think that can be a takeaway point. The thing is the compliance of the women, and then women have to talk health. That is very important.
Can you say something about delaying the first pregnancy, any effort?
Yeah, ma'am, then there is a wide variety. You have to see the societal things also. We have a wide variety of like the women who are educated, who are working, they are delaying the first pregnancy, first order. But then education gives you the empowerment. But when we see it as a labor workforce rate, the one who are not well educated, the one who are around like 10th education, are they doing the labor work, for them, how to impact this first order delay. I think that is where the male partnership will play a lot of important role. The discussion with the male partnership and the discussion and the, I'm in the focus on the male education as well, how they take their partners along with. That yes, this is our home, we have to put in something economic and how the male supports that. That has to be very important.
Thank you.
Thank you.
Thank you. Jyoti, I want you to speak more about the one of the method, PPIUCD especially, which is, as you know, is something which has been there in our system since 2012, and it's proven to be a very successful for delaying the, not just delaying, but sorry, I would say spacing. What have been some of the successes that you have faced in your program, and what are some of the challenges? And if you have some thoughts about, you know, things like couple counselings, please share with the group.
So first about the PPIUCD, thank you so much for having me here, madam. That is the first thing I would like to say. About the PPIUCD, yes, it is one of the method for spacing, and it has come up very well since inception. The training started in 2010 and 2012. It took up well. So prior to that, IUCD, as everybody was telling, that it has been associated with some kind of defamation because of other issues like infection and all. But when the trainings, there was a repositioning and there was an alternate methodology of IUCD training, and then the PP-IUCD came. There was so much other things which were taken care of. And of course, we started talking to pregnant women. Otherwise, earlier we used to only talk about interval contraception and all. So during antenatal, you know, it was like a taboo. First talk about her vomiting, first talk about her fetal well-being. So when we started talking about it, and we started some innovative things like, you know, special clinics, IEC material and all that, it gradually started picking up. And it was again in phasic manner, just like implants and all now we are doing. Started with medical colleges, then hospitals, then maternity homes, and all other delivery points. Gradually took up, and today, like Dr. Inderjeet also said, it's about 40% in our state. And we have other postpartum methods like Chaya, PPS, and now implants also. So, and PPIUCD experience has been very good. Like some of, I mean, it is mixed. So initially there were doubts that, you know, they are getting it inserted and going back and getting it removed. And but we started following it up. And we also have an incentive for ASHA for following up of IUCD, like not only insertion, they get incentive at 6 months and 1 year. So there have been couples, you know, who have been coming back and saying that we had PPIUCD, especially after cesarean. Like initially service providers had issues like putting it in cesarean, excepting few institutions who were doing more of intracesarean than post-placental. So when it started happening after cesarean also, and the women were actually coming back and saying that, you know, we got it removed, and about the return of fertility, unlike injectables. So that is also an advantage. So the women are coming back and telling that, yes, I got it inserted after first pregnancy, and I was happy for 3 years, got it removed, got pregnant, and now I'm pregnant, please insert it again. So these were the, you know, positive things that we have seen. And now we are happy to have in our basket implants also, so that also will contribute to a lot of spacing, because that is another method that can be given before her discharge for 48 hours. And ultimately, like in post-abortion, we say 100% should get something or the other. So definite methods, modern methods, we want to give before 48 hours, and about 900 implants we have put in postpartum women from a total of 2,500. So Delhi is fortunate to roll it out across all districts now.
Good. And can you talk something about talking about contraception to the newly married couple, Nahi Pehl and some of those initiatives?
Yes. So delaying actually initially used to be, you know, labeling like infertility. If she has periods after marriage, the mother-in-law would say she's infertile. So now the women are more empowered. Maybe they can also influence their mothers-in-law and try to do that. So what, like Nayi Pehal kit, as Madam mentioned, is something that gives day-to-day items in a kit, along with some samples of short-acting reversible contraceptives. But what we are doing is information we are giving about LARC also, because now these are being repositioned. Earlier, even the client, even the service providers used to say, okay, nulliparous, don't give IUCD, you know, she will get infertility. And even para 1, people used to say, not IUCD, give OCPs. So, but we know that SARC has issues like, you know, small children are there, she will forget the compliance issues, the side effects. So LARC is getting a role, and so in Nayi Pehal Kit, we are also putting a pamphlet talking about the LARC options. Similarly, when we used to do IUCD camps, so basically it used to be for Paris women's, for limiting or spacing. So now we call it LARC camp. FDS, in fact, fixed day services, no more camps because of the reasons everybody knows. So there also, because WHO MEC Wheel also talks about Nullipara being eligible for long-acting reversible contraceptives. So all three, like injectable, 2 injections, 1 year delay, 5 injections, 3 year spacing. So that is also, so all 3 things open for all para 0, para 1, para 2, delaying, spacing, limiting. So Nayi Pehal Kit was actually meant for Mission Parivar districts, but we opted for it in Delhi, and Government of India was kind enough to give us funds also. So we are practicing that, and it's coming out to be a very like celebrative kind of thing, being given by CDMOs or DMs, or sometimes more local MOIC kind of thing. And we have a YouTube video on that by Dr. Manju Puri, where she's talking to a couple and talking about all other preconceptional things also. So that has a lot of views. I think that video has the maximum views in my YouTube channel.
Thank you. I think, I know we can go on for another half an hour, but looking at the time, maybe I'll hand over to.
Yeah, thank you, Dr. Bulbul, for moderating the session and for the insightful discussion to all the speakers. Now I would request Dr. Sumita to share her closing remarks.
Time is short. I'll be very, very brief. We had the panelists, both the 2 panelists
panels, and they all spoke from their experience, what they are working on, and lot of things came, and summarizing them will also again take a lot of time. What came out well is that there is no doubt, there is no two other words about importance in women's health, and some panelists went ahead that it's not only health, it is the economy, it is so many other things. So there is no doubt about it. And for achieving that, lot of suggestions came that the unmet need which is there, still there for spacing and delay, that has to be filled with newer type of contraceptives, with the recent advances, with low dose contraceptives. So many things are in our sort of arsenal, so lot of potentials there. Integrating it in counseling, in NC, PNC, and other kind of, any time women comes into, there, and through digital methods, so there's a lot of scope. Research and data, that gaps were shown, and they are really important, and good suggestions came that right now our family planning data, whatever program data is there, that is good enough for analysis and finding, where the issues are, if they can be used for AI, with AI, and sort of this thing, we can really get a hold of the situation. And what has not happened, that recognition is there. Dr. Bulbul said that for some time, but what has not happened is the integration into the policies and implementation, and then their monitoring, evaluation, their accountability. So all these things have not happened, and there is a big scope with digital technology, that UWIN is catching all the mothers' data for vaccination only, but the data is there, our ID-based data is there, family planning data is there. If we can connect, collate, relate, lot of things can happen, and accountability mechanism, if you can establish with mortality, especially with their spacing, and also that will be a big advocacy weapon for us. So thank you very much, and excellent discussion.
Thank you, Chair Ma'am, speakers and moderators, for such a rich discussion, and you're bringing your insights and diverse experiences. In the interest of time, we'll close the session now, and would invite the discussion outside if you all have time. Thank you so much.
under her leadership, Cochrane India Network is organizing so many events across India. And I would like to invite ma'am to start the session. Thank you.
And a very warm welcome from Cochrane India Network. So we welcome you to this workshop, and there is a eminent faculty present here from King George's Medical University in Lucknow, and this is a Cochrane affiliate center of the Cochrane India Network. They are going to deliver this workshop to you, and I would now like to introduce the chairperson of the day. So Dr. Raghubar Dayal Singh, Professor in Department of Prosthodontics, King George's Medical University, Lucknow. He has a teaching experience of more than 19 years. He is Associate Director, Cochrane India Affiliate Center, KGMU, and also the Nodal Officer of the DHR MRU, King George's Medical University, Lucknow. He is a Fellow of American Academy of Maxillofacial Prosthodontics, International College of Dentists, Fellow of Pierre Fauchard Academy, Academy of Dentistry International, and Indian Society of Dental Research. He lectured extensively across the nation and has published many articles in national and international journals. Welcome, Dr. Raghubar Dayal.
Thank you, ma'am. Good afternoon. Good afternoon, everyone, our esteemed speakers and all the delegates. I would like to welcome all the esteemed speakers of today's workshops, and I would the team member of Cochrane Affiliate Center, King George's Medical University, Lucknow, Dr. Balendra Pratap Singh, Dr. Hardeep Singh Malhotra, and Dr. Neeraj Kumar. They have already regularly conducting the Cochrane Review workshops on regular basis in King George's Medical Institute, Lucknow, and today also here in this workshop they are going to present. So first our speaker is Dr. Balendra Pratap Singh. He is professor in Department of Prosthodontics, and he is Director, Cochrane Affiliate Center at King George's Medical Institute, Lucknow. He is Cochrane Geographical Group Executive and member of Cochrane Evidence Synthesis Unit, India. He is author of 7 Cochrane Reviews and reviewer of Cochrane Reviews. So please, Dr. Balendra Pratap Singh.
Yeah, thank you, Raghubar, for a brief introduction. Kindly permit to share the screen. Yeah, thank you. So, King George's Medical University is a proud partner of Cochrane India Network as well as the Cochrane Evidence Synthesis Unit. Recently, Cochrane has changed a bit because those who are involved in Cochrane know that we have to submit a title registration form, then protocol, then review, and then updating. So now that system is continuing, but they have changed because now the climate change and so many things are coming into the picture. So they changed into, they actually added thematic groups as well as evidence synthesis unit in different part of the world. This is the QR code. If you want to know what are the various activities by Cochrane India Network, you can just go to the website. You can search in the Google also, and you can update yourself. Whatever the workshop, conference, events are going to be happen by the Cochrane India Network, you can get all the information at one place. So these are few conflict of interest. Only one thing that I have taken few few screenshots from the Cochrane Handbook of Systematic Review, which is free of cost. Anybody can just download it and use the evidence book to write a systematic review, to understand the systematic review and how to implement a systematic review in different clinical decision making or policy making. We all know that the difference between primary and secondary research, I hope, because primary research generally involve the in vitro studies or animal or any patient. And whatever the information we collect, we call it a primary research in a broad term. And if we extract the information from those primary research, we call it a secondary research. So secondary research do not involve any patient, any participants. Just we have to collect the data from already published literature or different census or different databases. So the difference between primary and secondary research was majorly, I pointed it out, but secondary research is generally divided into in a broad category: narrative review, systematic review, and meta-analysis. And the difference was very clear that for primary research, we collect the data from household, from the society, from the hospital, and then we publish in a journal, we publish in a website. This is what the primary research, but for the secondary research, we do not collect the data from household or some other places. We just collect the information from the journal or different website. So two people have to do independently to perform this secondary research. That's why I changed from me to we. Two people have to do entire step independently without discussing with each other. This is what the beauty of review, because we do not remove, we have to remove the bias in each and every step, not only for the risk of bias, but for the data extraction and inclusion and exclusion of the studies as well. So what is systematic review? Systematic review, as the name indicates, it's a summary of whatever the literature present across the world on the basis of predefined clinical question. And on the basis of that predefined clinical question, we identify the studies, we collect the data, we critically appraise, we call it risk of bias. And then if we are able to actually get the numerical data, we call it meta-analysis. If we are not able to collect the numerical data, we call it just systematic review. I hope it is clear to all the audience, because the audience is here from diverse background. And after collecting the data, we have to inform to all the stakeholders what is the certainty in that evidence. We call it uncertainty. So there are 4 levels of uncertainty of evidence: high, moderate, low, and very low. Dr. Hardeep will cover that certainty part in a greater detail. So this is the technical difference between systematic review and what the single studies. We all know that it saves reader times, it resolves the inconsistency between different studies, because we have a same PICO, but still we have a difference. Like in the studies, there are difference in population, there are differences in intervention, outcome measure may not be like at the same time every study have measure the same outcome. The method technique or measuring the outcome may be dichotomous, may be continuous, so there are differences in those. So a reader can get a summary of all the information at one place. This is the evidence-based pyramid. Everybody know that as you go up, there is a less bias and the quality is increasing, and Cochrane systematic review is on the top because of its robust methodology. And we all know that normal systematic review meta-analysis in any journal is like 4, 5, 6 pages, but Cochrane reviews goes beyond like 100 pages, 200 pages like this. So because of its robust methodology that they are following. So we are practicing about evidence-based medicine, and Cochrane review, if you consider, is just the best external evidence. That doesn't mean that if evidence is saying that this particular treatment is actually very effective, we do not believe to directly apply those evidence in our patient. We have to think what was the PICO in that particular review, and then think how is it, can we apply the same evidence on our patient or not. So this is the way EVM practice is to be done. We are doing it, and this is the way we have to think in a different way. Not only the best external evidence, we have to see the clinical expertise, what is the patient value and expectation. So the quality of external evidence is, it should be internally valid. The methodology that we have to follow, it should be very robust. External validity, can we apply these evidences to the population? That's why we consider about the risk of bias and certainty. It should be extensive, because we know that only 6% of the world population actually has a native English speaker, and remaining 50% of the population is only from English language, remaining 50% from other German, French, Chinese. So we have to actually include all studies of any language. Updated, we should be updated. Generally, it should not be technically more than 2 years old, but depend upon various conditions. And if we able to inform to the stakeholder in a numerical form, like this is 2 times effective or this is what the confidence interval, it is very easy to communicate to the stakeholder rather than giving the evidence is good, bad, something. So this is the way. If we are able to collect the information, this is the best way. So what is Cochrane? Cochrane is a more than 30 years old organization. Do not take funding from any pharmaceutical company, no funding from those resources. That's why the trusted information we get. And they have a various platform like Cochrane Library, which is the major one. Anybody, not only the doctor, patient, healthcare professional, policymaker, anybody can just go and access and use those evidences. And in 2023, 60% of the WHO guideline, 2020 is varying actually. In 2022, there are approximately 90% of the WHO guideline was based, have taken 1 or 2 Cochrane reviews. This is what the evidence ecosystem of Cochrane is. They have a different geographical group, like in India, there is a Cochrane India network and there are 9 affiliate center. And there are evidence synthesis unit, there are thematic groups, there are different subject specific thematic groups. If you have an idea, you can submit in those contact and submit the proposal in those groups. They have a method unit as well, as because method is evolving every day. Now it's AI and something. So we have to modify the methodology regularly. We have to make lots of innovation in methodology. So there is a method group also. So the people who are interested, they can actually join. One of the very important points is that they actually translate whatever the evidence in a Cochrane review in a very simple language, in a regional language. Like in India, one of the affiliate center actually officially translating this into the Hindi, also Tamil and Telugu. So this is one of the beauty, and you can get all the information free of cost. It's from any language here. And this is what the impact of 2023. Majorly, who use Cochrane evidence? WHO and so many organizations. They have a collaboration with PAHO, that is Pan American Health Organization, to prepare guideline, to prepare the reviews as per the need of their country. Like for India, our regional need is maybe different than the western part. So we need people who actually are talented enough, who actually trained enough to write a systematic review, so that we can actually solve the problem of our own country. And there are so many translation and so many reviews are going to be in public domain through Cochrane Library. So there are various Cochrane tool anybody can use, like Cochrane Library and Central, which is the largest database for a randomized control trial and controlled clinical trial in the world, not only the midline and MBase. They collect different randomized control trial from different journals, different grey literatures also. Cochrane RevMan and Covidence are a screen data extraction statistical tool as well as the screening tool. So these are the various tools which you get free of cost if you are writing a Cochrane reviews. And these software actually helps a lot to write a review. They actually also help you in identifying the issues. That's why 2 people can independently do all the steps. You can join Cochrane by just screening the studies. If you are expert of any component, maybe screening of studies, if you are a subject expert, if you are a statistician, if you are a systematic reviewer, if you are a translator, you can join this Cochrane Engage free of cost. People post their issues in this. People need whatever the help they need, they actually post in Cochrane Engage. You just collaborate with them, and if both team agree, then they can give authorship and like this. So you can help in translation, you can help in screening of studies, you can help in statistic, you can help in a great certainty of evidence assessment. This is the way you can involve yourself with the Cochrane. And this is the QR code of Cochrane Engage, so you can directly go through Google or through this QR code to directly go to the website and take an advice from there. So steps of Cochrane review, generally it involves 4 major steps, and each component have, again, there are so many steps in that. So some people have to submit first proposal, and there should be no overlap with the existing review. This is one of the very important criteria from the Cochrane side. And if proposal is to be reviewed, and then if it is accepted, it will go to the protocol stage. So they will provide some online tools, REM and web access and all. So you can just write entire protocol here, and then it will be published in Cochrane library, because people know that we have to first publish the protocol, then start writing actually systematic review. If it is accepted, go to the protocol, go to the review stage. They will provide all the access to the software, and you have to do each and every step of review, and then it will be published again in the Cochrane library. And after publication, it should be updated at every 2 years. So you also have to update. You can change your author if you want, but it should be updated. Everything is now transformed into the new platform, that is Editorial Manager. People who publish the journal know the Editorial Manager platform. This is the Cochrane review ecosystem. So you have to start from writing, actually generating research question. In generating research question, you have to involve so many people, not only the doctor but also the patient, as well as the policy maker, all whoever think. You should include those people. And then it will go to the planning method, then writing and publishing protocol, then developing search strategy. And after you can everything published in the Cochrane library, at the protocol will publish in the Cochrane library, and then remaining these steps, running the search, selecting studies, collecting data, assessing risk of bias, each and every step people can do in, author can do in Covidence software. And from this to analyzing the data, interpretation of finding, and then preparing summary of finding table through Grade Pro GDT software, it can be done in Cochrane RevMan Web. Earlier it is called Cochrane RevMan 5.4, but it is now Cochrane RevMan Web. So this is the way it can be done, and this is the entire summary of how whatever the problem, government policy, patients have, or health problem any, then we have, these are the entire steps how to go and actually prepare evidence, and then actually prepare guideline, because the guideline of policy maker have so many issues, because sometimes we get evidence which is actually very favorable, but the practical implication may not be possible. We have to see about the logistic, training of the doctors, training of the nursing staff, sometimes practically impossible, or it's very difficult for the time being. Then they have a different priority. So we have to include those policymakers from the beginning to actually provide evidence, so that they can actually apply that particular evidence to the population at the grassroots level. So today's workshop is what about the evidence synthesis. So proposing a new title of Cochrane review, you can just do the editorial manager and just submit this form, and just to check that there should be no duplicacy, and then presentation can be like you have to submit form, it will be reviewed, and before sending any more information, you have to review the proposal. It will be published in the Cochrane library. You can also see few vacant title. If there is any, you can approach to those author to start in your name. First step is to develop a research question, because this is very important, and Cochrane suggesting that you should not only include the benefit of particular intervention, you should include the harm also, because every treatment must have some harm. It may be cost, it may be some mortality, it may be some side effect. So you must include harm. People generally like systematic review, but they do not include harm. But that is very important. And it should be feasible, interesting, novel, ethical, and relevant. It should not be something which is practically impossible to do. And please involve consumer, healthcare professional, policymaker, whomsoever it is. That is the best step to generate a research question. Second step is PICO, because PICO is actually help in formulating research question. What is PICO? Everybody knows here, I believe. It is like patient, population. What type of population? How will you define that particular population? What are the intervention method? What is that intervention? What are the alternative? Is it giving alone? Are you interested in giving that treatment alone, or with the adjuvant therapy and all? So this is the way you have to prepare your PICO, and the detail is here. Who is the patient? What are the problem? What is the main intervention? For comparison, is the placebo or no treatment or standard treatment? You have to define each and everything. An outcome, what do you want to measure, how to measure, and at what time point you are going to measure. So these are things you have to take. So PICO you have to prepare. Then for each population intervention, comparison, and outcome, you have to prepare the inclusion exclusion criteria for that. particular thing. So importance of PICO is it clarifies the research question. It helps to generate the search strategy for a different databases using the mesh term for Medline, M-tree for M-based databases. And it improves the review quality. Somebody can repeat the search. Even you can repeat the search after 2 years if you want. And this is the one of the just very simple example because the audience is very heterogeneous here. So this is one of the example of PICO question, like in adult with hypertension, you have to define hypertension. Does yoga reduces blood pressure comparison to intervention? It's look very simple, but you have to include how will you define yoga? And how much should be the duration of yoga? Like what is the reduction in blood pressure? Are you going to include the patient who have high blood pressure or moderate blood pressure? So everything has to be defined. So application part is that do not just apply whatever the evidence in Cochrane or some other systematic review, just apply to those in your population, those evidences. Do not. You have to look the PICO of that particular time. This is what in the inauguration lecture somebody was telling, like you have to look at the PICO of that particular evidence. So protocol registration is mandatory and it can be done in Cochrane library. It should be done before the review begins, and it promotes the transparency, accountability. It enables replication and peer scrutiny actually, because if some other author team is doing, so there is no need to do the particular things again. So protocol registration can be done in Cochrane library. And major component of protocol, we all know that we have to write background rationale, then review question, methodology, risk of bias assessment, certainty of evidence, and what is the statistical tool that you are going, what is the statistical method you have to take. These are the major component of protocol, because that protocol is actually you cannot change later on. You can modify a bit, but you have to mention, but you cannot change a lot. And you have to give reason why you have changed the protocol. So using a PICO, why? Because we are only interested in the studies in which both all the four components are there. We are not interested in only clinical like cross-sectional studies and all. So we are only considering the studies in which PICO is there. Otherwise we are not interested in those. That's why the PICO strategy is very important. So what happened in PICO? All the synonyms have to be joined by using the term or, and PICO finally have to be included with Boolean operator terms and. This is important because if people want to know why my RCT is not included in that particular review, so that they can go back, look at the search and then can modify. So databases, which database to search? Generally Cochrane has a long list, but they suggest that Medline, Cochrane library and Embase must be there at least. Apart from this, you can include the grey literature and other. Then you can also include different filters, different types of correct key terms. You can go to Medline database through the OVID, so you can find they can suggest few mesh keywords, because this otherwise if you do not choose the correct keywords, you are not going to find out the articles. So that is very important. This is the Equator Network website from where you can get all the information, how to actually write entire systematic review and meta-analysis, what are the steps that should be included, so that from the beginning you just find the correct way. So that's it from my side. So remember, do not just directly believe what is the systematic review. Look at the PICO, look at the methodology, then you can apply those evidence for clinical decision making as well as for the application of policy, or if you are interested in the preparation of the guideline, then you can actually use. Thank you so much.
Thank you, Dr. Balendra. Our next speaker is Dr. Neeraj Kumar, and he is going to talk about the screening of studies and risk biasness in systematic review. Dr. Neeraj Kumar, he is professor in Department of Neurology, King George's Medical University, Lucknow. He is also the Associate Director, Cochrane India Network, KGME affiliate, and Vice Dean, Research Cell, King George Medical University, Lucknow. He has extensive teaching experience of more than 14 years, and he received gold medal in DM and DNB neurology, and he has more than 120 publications. So welcome.
Good afternoon, the audience. And now, moving ahead, next topic is about literature search, screening, data extraction, and risk of bias. So these are the next steps after PICO. So coming to the steps of a systematic review. So after research question, PICO, and after protocol writing, then we move ahead for search strategy. Developing a search strategy is most important part, and usually a librarian will help in developing this search strategy and running in different databases. Then literature search has to be done. Then article screening should be done. Whatever duplicates are there, it should be removed. And then the step of data extraction is there. And after data extraction, we have to assess the risk of bias. And after that, data synthesis, grade and grading will be explained by Dr. Hardeep in his lecture. So coming first on this presentation layout, so we have to define the research question, the PICO. Then we have to identify the databases to search. Then we will develop a search terms and apply some search filters about that search strategy. Then we have to conduct the search in different databases. We have to document the search process. We have to screen and deduplicate the results. We have to report the search in the review. And then we have to screen the articles, whatever we have searched, shortlisted, and then we will move ahead for risk of bias assessment. So coming one by one, so PICO has already been covered nicely by Dr. Balendra. And for an example, a population, we can take adults with type 2 diabetes. So we have to define what are adults, what are type 2 diabetes, and we have to define the intervention also. In this example, it is insulin therapy. What type of insulin, how many, what is the dosing of insulin, and in comparison, we have taken oral medications. So what type of OHAs are there? It is single or multiple, and then outcome, blood glucose control. So what level of control we are looking for. So all these PICO terms should be well explained before going ahead for your systematic review. So then we have to identify what databases we have to search. So ideally, we have to search the bibliographic databases. Then we have to search ongoing studies and unpublished data sources also. Then we have to search trial registers and trial result registers. So many trials are registered, and time to time they update the results of the study before the actual study gets published. So we have to also include these studies. Then we have to see any regulatory agency sources or clinical study reports. So most of the time when a new drug comes, or when there is a study which reports a side effect of a particular drug, or phase 4 study is there, then they also submit it to the regulatory authority, and all the dossier contains all the information which may be helpful for your systematic review. So you have to search or include these, and there may be some other sources also. So these are the 5 search sources which you have to include in your systematic review analysis. So coming on to bibliographic databases, so these databases should be a guiding for your review topic, and also we have to search extensively so that we have to reduce the bias related to publication. So for Cochrane review, there are at least 3 databases we have to include. One is central, that is the Cochrane Central Register of Controlled Trial, and it is through Cochrane SS. Second is Medline or PubMed, and third is the Embase. So at least these 3 databases has to be searched to move ahead for a Cochrane review and meta-analysis. So Embase is basically, it includes all the Medline records that is there, and there are also some preprint articles which are available there, and they have a vast number of abstracts, full text articles, conference abstracts. So it usually includes all the PubMed articles also, but something is missing from the Embase also, so we have to search PubMed and Embase both. Cochrane Central Register of Controlled Trial is basically the trials, randomized controlled trials, which are listed by Cochrane in its library, and these are taken from PubMed, Embase, and apart from these, they are also fetch trials from WHO clinical trial registry, SINAHEL, and clinicaltrials.gov. So after taking these three major database searches, we also have to think about some bibliographic databases which are specific to some regional area. Means some publication may be in different languages, so we have to search in their language also if our topic is vast. And then we can also look for some topic which are specific to some field, like we have a psychiatric topic, then topic related to psychiatry, then we can also search for psych info. For nursing and allied health related topics and review, we can also include search from SINAHEL. So these are other databases which can be included apart from these three major databases. So next is ongoing studies and published data sources. As I have mentioned that many studies may be partially or may have been listed somewhere. So some studies are presented in abstract in the form of abstract, and they may contain some information related to your topic. So these topics, these abstracts should also be included in your search strategy and search database when you are looking for. Then you have to look for trial registered and trials results register. So whenever one is conducting a randomized controlled trials, then down the years it has been mandatory to register it in a registry. So clinicaltrials.gov or Indian trial register, it should be also searched with these terms. Then regulatory agencies and sources are also a good source of information. So you can search for drugs at the rate of FDA, Open Trials FDA, or EU Clinical Trial Register. So all these are resources from where you can search databases to get maximum number of studies, information, data which you have to include in your search and systemic meta-analysis. So other sources are, there may be some gray literature like conference proceedings, like some government publication which may have some details, some white paper which the government or the other agencies or NGOs put forward. Some dissertation and theses are also there which are published and in the form of a publication, online available material. There may be patent, regulatory data, some maybe there may be some information in some annual reports also. So all you have to have an extensive search to include as much literature as possible, whether it has a positive result or a negative result. So after searching all these databases, you have to develop a search strategy which includes the PICO question. So for diabetes, for means condition, for problem, for intervention, for outcome, there may be some keywords, and we have to include the synonyms which are similar to your keywords also. So for an example, in diabetes, the keyword is diabetes or diabetes mellitus or type 2 diabetes or type 1 diabetes or T2DM. All these terms may be used in different publications. So you have to include all these with OR in search strategy. And there may be some synonyms like hyperglycemia or blood sugar disease also. So you do not have to miss anything. You have to include all these synonyms and keywords into your search strategy when you are defining your P, population. Then intervention, you have to look whether insulin, all the words related to insulin, insulin therapy, insulin injection, insulin pump, all these are there or not. Then you have to define the oral drugs, and then you have to define the outcome. So all these synonyms and keywords should be included in your search strategy. So when you are doing your search strategy, there may be some words which have some similar ending, like vaccine, vaccinations, vaccine schedule. So you can use an asterisk, and after that it will automatically take all the words which are related to that vaccine, and at least 4 characters should be there to use this asterisk wildcard. You can use multiple wildcards in a single search word. Apart from this, there is an automatic term mapping also, which includes the mesh terms. So the mesh terms is that for diabetes related diseases, all the other things like what are the diagnostics, what are the treatment, what are the drugs, all these are automatically linked to that mesh term. So you have to include the major mesh term into your search strategy. Then you can do a proximity search. Proximity search means when you have to use a phrase like accidental overdose. So you have to have these two words searched together into your search strategy. So you can define it by writing accidental overdose, and you want to search it in title and abstract, and how many words you want to look, whether the proximity to these two words are how much different, there is a difference of how many words is there, and then you can add the Boolean operator and the next search word. So in PubMed, the Boolean operators which are majorly used are AND, OR, and NOT. So AND means the results that include all the terms, which includes both these terms. Means if you are using diabetes and if you are using insulin, so both diabetes and insulin should be there into that search strategy term. If we use OR, so any topic which uses the term diabetes or uses the word insulin or OHA will be automatically added to your search. Not means to exclude something, means when you are using diabetes, not insulin, means the population will be person who are diabetes, having interventions, having anything but not insulin. So these are the different search field tags also which usually is used to narrow the search. So it can be based upon author, title, abstract. So all these can be helpful in defining and reducing your searches. So after these search terms, then you can apply search filters also. So in PubMed you can see on the left side there is some information related to publication, 1 year, 5 year, 10 years or more. A custom range means you want to search for 50 years or so. You can search abstract, free, full text, randomized control trial, meta-analysis. There may be language filters also, and there may be species filter. You want to include only the studies being done on humans, then search filter can be used. So these search filters are also useful for your search strategy. Then conducting the actual search. So start from one database like PubMed. You have to conduct a comprehensive search of one database with defined PICO and search words. After that, you have to search that search strategy into the next database, whether it is Scopus or whether it is Cochrane, and you have to adjust the syntax. The words are a bit different in other database, so you have to adjust these a bit, but the actual search strategy remains the same. So after doing the search, you have to save the search also, because it is your base. Means after that you have to remove the reduplicates, and then you have to screen the study, then you have to screen the abstract, and then you have to remove the abstract and go beyond to full text screening. So this search strategy should be search terms should be saved, and these results should be exported in a RIS or CSV file for future use. So in PubMed you can export this search from here, save, and then you can send it to and export this in whatever format you want to. Then you document the search process. So when you are writing a protocol, then you have defined, okay, I will do this and this and this, and then you will define the search strategy also and search process also. So why it is required? Because search terms, Boolean operators, filters, and specific strategies for each database should be recorded. It has to be there in the protocol also and the review also. The date of search is also important, because many articles are added after that also. So you define on what date you have searched the databases. There may be minor adjustment, documents any changes made to the search strategy. If you have changed something after protocol publication, then you have to document that also. So the main purpose is to document the search process is to have an accountability and transparency, and whether another person is doing the search, he should also get the n number of searches what you have searched based on your database search strategy. So after that, the next step comes is screen and deduplicate. Means many a time a particular article or title or an abstract is presented on the same title. So there may be 2, 3 or 4 publications which are similar, which have similar information. So you have to see whether if there is any duplicates, then you have to remove that duplicate. So usually reference manager like EndNote, Mendeley, Zotero is used, which helps you in removing the duplicates. And after removing duplicates, you have to screen also the title and abstract, and based on these title and abstract screening, you remove the duplicates. Then you conduct the you report the search. So in a protocol, this is an example of a title of cerebrolysin for acute ischemic stroke review, and in this, in abstract, and this is the appendix. So in appendix you can see that there is a description of the search strategy and from which on which database it was conducted. Like on Central, this search strategy was used. On Embase, another search strategy was used. Medline, another search strategy was used. The actual search terms are same. They may be minor different in different symbols which used to connect these search terms. So after searching all these databases, the next task is screening the articles. So first step is to screen the abstracts. So title and abstract. So what you have to do, for Cochrane meta-analysis, there is a software called Covidence, and in Covidence, when you get an account, then there is, you can see there is import references, title and abstract screening, full text review, and then extraction. So one by one these steps you have to complete. So title and abstract stage is when you decide whether this is a study is a randomized controlled trial or not, whether it meets your eligibility criteria or not, and if you are not satisfied with the title or abstract and you do not need to go to full text article, then you can screen it out. But if you are in a confusion, you include that study and then you go to the next step of full text screening. In full text screening, if you see that the population is different or the intervention is not matching with your criteria, or the outcome what you have chosen to do your meta-analysis is not there, then you can exclude this full text also. And then the task comes of data extraction. For data extraction, you have to make a data extraction sheet. It is like a summary of your article. So you have to read the full text, you have to define all the important information which you want to have in your data extraction sheet, and you make this data extraction sheet so that every time you do not have to go to the full text again and again and read that article. So after this data extraction step, then comes when you have to do two things. One is to analyze the risk of bias in the published literature, published articles, and then you have to grade what evidence is there, and you have to generate a forest plot, you have to do a meta-analysis based on your findings. So coming quickly to risk of bias. So what is a bias? Bias is, we define bias as a systematic error or deviation from the truth in the results. So it is a systematic error which occurs in particular study. So you have to search for that systematic error in different article. So bias is not imprecision. Means if you are measuring blood pressure and the instrument is wrong, it is measuring a wrong record, then it will be a systematic error. But if another person, if you are measuring the blood pressure of all the persons sitting here, and again if you are measuring after 2 minutes, then there may be some random error also. So random error is a part of normal study, but systematic error is when the error is related to some instrument or the method, that is a systematic error. So bias, what the bias leads to? Bias leads to overestimation or underestimation of the intervention effects, and it can vary in magnitude also. So in some studies it may be having a small magnitude, in another study it may be having a large size, and it can vary in direction also. In some it may be favoring towards the outcome, it may be favoring against the outcome also. So you have to look for the bias. So bias can arise on two levels. One is on the primary study investigators level, means the person who has actually done the studies, RCTs, which you are including in your meta-analysis. And other is the bias of the review authors, means you are conducting a meta-analysis and you have screened 5 studies which are eligible for your randomized 5 RCTs which are eligible for your meta-analysis, and 2 or 3 of these studies are related to you or a person who is known to you, and you have taken these studies are very good, you have picked and graded it higher. So this bias arises at the level of ourselves, means who are doing this meta-analysis. So I will be dealing with primary study investigators related bias, and initially it was ROB1 which was being used, but now it is ROB2 tool, risk of bias assessment tool 2, which is now being used, currently used. And ROB2 assessment tool is more objective, and it is important to do risk of bias assessment for every means if you are looking for one outcome, then you have to do risk of bias for one outcome. Initially in ROB1, what was there, you have to risk one particular article for bias. Means if that article has 5 domains or 5 outcomes, then all will be risk of bias will be single risk of bias for the whole article. But now if an article has 5 risk of bias, 5 domains, 5 outcomes, then the risk of bias has to be taken for all these 5 outcomes differently. Means when you will screen, then you will find it. So in ROB2 there are 5 domains. One is bias arising from the randomization process, second is bias due to deviation from the intended interventions, third is bias due to missing outcome data, fourth is bias in the measurement of the outcome, and fifth is bias in the selection of the reported results. So in a nutshell, so domain 1 covers the randomization process related bias. So what is randomization process? So there are 2 steps. One is there is allocation sequence generation step, and another, the next step is allocation sequence concealment. So you have to generate a list sequence on based on which you will include the patient. So in a study, allocation sequence generation should be there and concealment of allocated sequence should be there. The domain 2 deals with finding flaws in blinding, assignment to the intervention, and adherence to the intervention. The domain 3 is missing outcome related data bias. Domain 4 is measurement of the outcome bias related issues like method of measuring the outcome is appropriate or not, measurement of the outcome differs or could differ between intervention group, who is the outcome assessor, and whether outcome assessor is blinded or not to the intervention, and assessment of outcome is likely to be influenced by the knowledge of whether the person giving is blinded or not. So the outcome assessment is whether related to that or not. And the final step is to overall have a risk of bias based on all these domains. So coming one by one. So bias, what is randomization? So randomization is the domain 1 covers the randomization, and randomization is important because it avoids any direct or indirect unknown or known prognostic factors related problems in an intervention groups. So one is allocation sequence generation, and that is achieved by simple randomization, block randomization, or stratified randomization. The second step is allocation sequence concealment, means the step from which the patient is randomized, and from at that very junction when the patient is assigned to a group, the allocation sequence should not be known to the person assigning the particular group or the person who is being assigned that in a particular group. Some factors which you can have a look in the published articles when you are looking for a RCT, and what are the markers which will make you have an information that there may be a problem related to randomization. One is unusually large difference between the intervention group sizes. If you have decided that the 2 groups in the study should be 1:1, and the number of patients in one group is larger as compared to the next group, then there may be a problem with the randomization process. Second, maybe there is a substantial excess in statistical significant difference in baseline characteristics than would be expected by chance alone. So if you have 20 variables, that is table number 1, in which you usually write the baseline characteristic table, and you are seeing that in one group the number of diabetes patients are more, in another group the number of diabetes patients are very less, in one group the coronary artery disease patients are more. So there may be some problem with the randomization process which has led to this difference in the both groups. Imbalance in key prognostic factors, means if you are doing a study on TB meningitis stages, and stage 1, stage 2, stage 3 are 3 different types of stages. In one group the stage 1 patients are very more as compared to the other group, and in another group stage 3 patients are more. So this will also lead to different outcomes. So this table number 1 will be helpful in seeing whether there is any problem with these subgroups also, and this will indicate indirectly that there was problem with the randomization. Excess similarity in baseline characteristics. If a study is quoting ki they have taken 1:1, 50 patients in one group, 50 patients in another group, diabetes patients are also matching, other comorbid patients are also exactly matching, then there may be some problem with the study design. Surprising absence of one or more key characteristics means in an example like in TB meningitis patient, if the person has not categorized the patient's cohort into stage 1, stage 2 and stage 3, which is very important for an outcome assessment in TB meningitis patient, then he may have concealed something. So these are indirect indicators which point towards the problem with the randomization process. So in a good study, you will find something like this. Means if a person has done the randomization process nicely, then he may be have written this: the central randomization office was removed from the patient recruitment site, participant details were provided, for example, by phone number, email, and the allocation sequence was concealed to the individual staffing and randomization office until the participants were irreversibly registered. So in a study, if this type of description is there about the randomization process, then you can take it for granted that this study has been conducted nicely. So after domain 1, the second domain is domain 2, which deals with blinding and assignment to the intervention and adherence to the intervention. So there are two intention to treat effect and per protocol effect. So effect of assignment to the intervention basically deals with the intention to treat effect, and effect of adherence to the intervention usually deals with per protocol effect. And blinding, as you know that whether the person who is giving the care is blinded or not, whether the person who is being assigned is blinded or not, or whether the person who is assessing the outcome is blinded or not. So the implementation of blinding is important because bias can arise at the level of participants, caregiver, trial personnel also, and the statistician at the level of statistician also. So coming to domain 3, missing outcome data bias. So what happens? You can plan a study very nicely, but when you are conducting, there may be some issue related with patient follow-up, there may be some loss to data also, and every publication has some or the other defect in the data. So there may be participant withdrawal from the study, that is loss to follow-up or dropout. There may be the participant do not attend a study visit, they do not provide the relevant data which was required for that particular study. The data or the records was lost, or the participant can no longer experience the outcome because the patient has died. So if there are problem related to completeness of data, then you have to see that whether there is any bias related to missing outcome data or not. So one is, if the outcome of all the participants has been explained or written in that particular study, then there may be no bias. When the number of participants and the missing outcome data is sufficiently small, then you can say the study is okay. And you can also do a sensitivity analysis to look whether the absence of data is a problematic or not. So there is no sensible cutoff, but a less than 5% missing outcome data is okay, but 20% or large is problematic. So what usually we do, if in a particular study, in some simple single imputation they can do, that is baseline observation carried forward or last observation carried forward, or they may also have used multiple imputation. If it is described in that particular study, that means they have dealt with the missing outcome data nicely. Then coming to domain 4, domain 4 deals with the method of measuring the outcome is appropriate or not, and method of outcome differs or between the different groups, whether same measuring has been taken into both groups or not, defined in the both groups or not. Who is the outcome assessor? So if the outcome assessor is blinded to the actual participants and the actual intervention, then it is okay. And whether the assessment of outcome is likely to be influenced by the knowledge of intervention, means if your outcome of interest is death, then it will not differ whether the patient was, the outcome assessor was knowing about the intervention or not. So there are some terms: measurement error, miscalculation, or under assertment or over assertment, which comes into the domain 4. Now the domain 5 is reported result bias. So sometimes the protocol was there that we will measure this and this and that with different scales and at different time points, but when they publish, they usually publish only that much of data which they think that is having significance, there is a significant difference, or the data is complete. So this also lead to a bias. So you have to look in the particular publication also whether the protocol, what difference in the protocol and the actual publication was there. So after doing all these 5 domain of bias, finally you arrive to overall risk of bias for a particular domain. For example, if you have taken a death at 1 month in a patient admitted with stroke, then for that outcome you have to judge all these 5 domain and then decide upon overall risk of bias, whether it is low risk of bias, some concern, or high risk of bias. So actually, low risk of bias is when all the 5 domains are at low risk, then it is low risk of bias. Some concern is when any of the domains have some concern, then it is high risk of bias. But high risk of bias is when any of the domain has high risk of bias or multiple domains has some risk of bias, then it comes into high risk of bias. So final step that is important is one author will more than one author will independently assess risk of bias. You have to resolve disagreement with your co-authors, or a third person will be used to resolve the disagreement, and then you have to incorporate finding of risk of bias assessment into your analysis also. And this is the riskofbias.info. It is a free website from where you can use different tools for risk of bias assessment. For randomized control trial, risk of bias assessment is done on ROB2 tool, and for non-randomized studies, that is Robbins E, then there is Robbins I tool. So these usually deals with these only domains, but there may be slight differences in these tools. Thank you.
Thank you, Dr. Neeraj. Yeah.
Neeraj, what is that minimization of that assessment? 4 types of stratification. Is it block randomization? What is that minimization? That is it is both block and stratified.
It is a combination of that, and that is an automatic type of thing. So whenever a new patient comes, it automatically designs whether the two groups are already balanced or there is some disbalance between the sex or disbalance between the age group, then it will automatically assign the particular patient into one group. So that is minimization.
Actually, what happened in my case just now, we did a variable block randomization, and my student said it is coming 29 and 31, and which I felt maybe शायद by chance होता ही होगा. Then I got some statistician, Dr. Anil Maruf from UCMS, he said no, ऐसा होता ही variable block में हो ही नहीं सकता ऐसा. It has to be variable. If it was variable block, then it should have come बराबर. In a simple randomization, probably 29, 31 could have come, because this is what you told, that large differences will tell us about the bias, inaccuracies. But if there is a difference of 29 and 31 in a simple randomization, that is okay. That is okay. But in a variable block, even one factor is not accepted.
It depends upon the size of the block, what size of you have taken. So
it was an even block. It was even variable block 2, 4, 6. If that was a block.
Total sample size was
30.
So that's very small number to have block randomization.
Because if the last block is of 6, so there may be difference of 3 or 4, because the total number maybe not 30, it was 34 or 36. So that 1 or 2 difference can be there.
That can come.
Yes.
Sir, for risk of bias assessment, I am doing a study on case reports, because the disease I am studying is the reports are very less. So I want to know which kind of risk of bias assessment should I do.
Case reports के लिए उसमें नहीं.
So we are talking here about RCTs. Case reports में तो.
Because they do not mention all these domains in detail.
You'll have to look for the care protocol and the Newcastle Ottawa program. One question, so is there any screening is done manually always, or can we do it from automatic?
Deduplication means there is a number of software which are available. So Zotero and Mendeley are for deduplication, means number of publications. If similar publications are there, then deduplication has to be done. software which is under Cochrane.
This is actually even I was wanting to ask the screening of by the authors of the biases, which will done that is done individually by yourself or by the software.
No, this bias has to be done by the author himself. And they will
And then after that, and then they will put it on 2 of 3 of the reviewers. If there is a disagreement,
at least 2 reviewers are required.
And if there is a disagreement, then you have to
whether you decide on mutual agreement or you decide on the base of a third person. If you have to write it in the initial protocol itself, how you will
resolve it.
Thank you so much.
Stop. Thank you, Dr. Neeraj. Our next speaker is Professor Hardeep Singh Malhotra. He is a professor in Department of Neurology, King George's Medical University, Lucknow. He is also the Assistant Director, Cochrane India Network, Jammu Affiliate Center, and he is a Dean Research in King George's Medical University, Lucknow. He has completed his doctorate in neurology from the King George Medical University, Lucknow, and he did his fellowship in neurosonology and from the National University Hospital, Singapore in 2010, and received training in quantitative methods in clinical and public health research, Harvard School of Public Health, Harvard University in 2012 and 13.
So we will not waste time. And we'll look at the concept and application of GRADE. The actual thing is like this is what we are doing in 3 to 4 days, and this is like a strong capsule course that we are trying to provide. So I'll give you an insight into the concept and application of GRADE. That is the topic, which is like moving ahead. I do not have any significant disclosures. So as Dr. Balendra very rightly said, not every systematic review can be accompanied by a meta-analysis. Okay. The most important thing is that meta-analysis is an optional component of a systematic review. Whether it can be done or not, this is your own decision. Okay, it should not be pushed into the SRMA. So this is the thing which is very important. The scheme of presentation is I'll start from the need and I'll take you to the examples of translation and followed by a few conclusions. I'll give you the QR code for the GRADE handbook. This is free of cost. You can click the photograph. And this is the GRADE Pro GDT tool. This is also free of cost. If you want to grade and you want to take it to the decision framework, you can actually go ahead with this. So when we say what is the need, the most important thing is everyone who publishes, he says that my evidence is the best, my study is the best, even though it might not weigh that normally when you are evaluating the study critically. So this is something which we need to see. Dr. Balendra and Dr. Neeraj have beautifully covered the rest of the parts. So I'll take you through the part of the data synthesis and the grade assessment. So this cartoon is very commonly shown on the platforms, and it states that I figure there's a 40% chance of shards and a 10% chance we know what we are talking about. So if it is something you are not even sure of what you are talking about, that does not make any sense, and that is what all GRADE is about. That is certainty of evidence. And I draw a very strong parallel to this thing, the forecasting that is done by the National Weather Service, which tells you about the probability of precipitation. Okay, which is similar to the probability of prediction that we calculate in systematic reviews and meta-analysis. So the most important thing is it does not mean that we know only 40% about the rain. This is the critical aspect which is also touched in GRADE. It is about that there's a 100% chance it will rain, but precipitation will only cover 40% of the area. Okay, so this is all about knowing the nuances, and the need is for whom? As Dr. Balen said, that the person who requires the data might be the patient, the healthcare provider, the policy maker, the funder. So the domains in which they require the data is the magnitude, what was the actual change, the amount, that is the data it has been drawn from how many participants and how many studies, and last but not the least, the certainty. How confident are we in the data that we are telling? And an essential component of a meta-analysis is a forest plot. This is the single most important thing which I'll walk you through, because rest of the part can be taken as we move ahead. A forest plot is also known as a blobogram, and it graphically represents the meta-analysis of the results of the randomized controlled trials. So if I walk you through the origin, it was as early as 1978, and note that this was a published trial of 71 negative trials. Okay, it's not about the positive trials. So look at the contrapunto, that it did not come from the positive trials, it came from the negative trials. And this was the first paper which documented how it should be done. It also told you about the power which needs to be there. Next in line came another systematic review that for the first time told you about the pooling of the effect. This is the pooled estimate that you get. And for the first time, it was actually from the nursing group that the term forest plot came, and it was published in 1996, say around 6 years before the Cochrane colloquium and when the Cochrane logo was established. So if we look at the terminology, many a times you find this thing that it was Pat Forest by under or using whose name this forest plot was done, but it is not so. It actually originates from the idea that the typical plot appears as a forest of lines where you are trying to see the wood and the trees. So this is important. So when you look at the logo, this is actually the forest plot, and the diamond that you see here is the pooled estimate. Okay. And it is strongly related with the paper that was published by Crowley and Ian Chalmers. This was taken ahead, and this was the actual forest plot that was incorporated into the logo of Cochrane. So if we break the components of the forest plot, you have a scale. This is very important. This might be a rate or a ratio or a difference. So this is the first thing that you need to see. The second thing is the line of null effect, that is lone. The third is the individual bars that you see represent a study. On that study, what you see is a point estimate or the effect size related to that study. This is the 95% confidence interval of the entire bar. This is the pooled estimate or the diamond. And the width of the diamond is the 95% confidence interval of the pooled estimate of those studies in consideration. Okay. So when we actually move on to the Cochrane review, you find the most important thing is the summary of findings table, which is a transparent, structured, or a simple tabular form which is given by Cochrane, so that everyone who reads the Cochrane review understands what follows what. So it's a structure that is given. It provides you the key information, as I said, on the magnitude, the sum of available data, and how certain we are in the evidence that has been projected. In any review which you'll go through, it will be before the background section. And we'll have a look at this. So this is how it comes, the summary of findings table. I think you're able to see my, cursor. So this is the summary of findings table, which appears just before the background section. There is a specific template for the summary of findings table. The two things which are very important: you cannot have more than 7 outcomes, and each table has one comparison. That is one comparison, one table. In that table, you can have up to 7 outcomes. Okay. So for every new comparison, you ought to have a separate table. The other thing is you need to show both the absolute and relative magnitude of effect. There is no p-value in the summary of findings table. So we'll touch upon this thing in the subsequent slides also. So the initial aspects, they form the summary of finding table header and the explanations as the footnote, because whatever you want to change, you want to upgrade, downgrade, you have a reason why you have included, excluded, they come under the footnote section. So this is one of those studies that we'll be showing you, we'll be going ahead with. So in the first part, you get the pick, that is the population, the setting, intervention in the comparator, and all the outcomes down under. So this is the PIC, and these are the outcomes which actually forms now the PICO. This is the controlled risk, which helps you decide whether you need to go ahead with what kind of measure. This is the effect that you know. So it is 0.75, which can be known as RR, relative risk, or the risk remaining. The risk remaining, or 25% reduction. Fine. These are the three pillars which give you the maximum information, the magnitude, amount, and certainty. So the magnitude as the effect, amount kitne mein se liya. This is 9 trials, 1337 patients. And what is the certainty? How confident are we in the results? We are extremely confident. There is high confidence. If you have to grade this, as Dr. Neeraj said, I am reiterating this thing because initially you were grading the study in the risk of bias. Now you are grading individual outcome. तो हर outcome का अलग ROB बनेगा, main नहीं बनेगा. Okay. This is important. One more aspect, whether to use odds or risk, this is important. When you are looking at something which is not more than, where the controlled risk is not more than 5%, that is where you have to look for an odds, otherwise look for risk. There is no P value in the summary of findings table. This is another thing which is very important, because you decide on the basis of the spread of the pooled estimate or the spread of the individual study, whether it is touching the line or is on either side of the line. Coming on to the main part or the core, that is certainty of evidence, that is grade. The Cochrane logo, it states that this is all about trusted evidence, informed decisions, and better health. So this is derived from the grades of recommendation, assessment, development, and evaluation working group, which is also known as the grade framework. So few people might have come across this. This was published in January, which is the Saferture report. कौन सा जगह travel करने के लिए is the best in the world, graded as green up to red, very high risk, low risk, or manageable risk. We also see global NCAP. You get adult occupant protection, children occupant, or a child occupant protection. Similar is the rating that you see with the grade. So grade consists of 5 domains. The first domain has been very nicely covered by Dr. Neeraj, that is the risk of bias. The second domain is inconsistency. The third is indirectness. Fourth is imprecision, and the fifth is publication bias. You need to be, besides risk of bias, you need to be very careful about the inconsistency or heterogeneity and the imprecision domain. So what happens? You start with the 4 stars. You have, this is the body of evidence, and we know RCT is the highest body of evidence, so you can only go down. If you have a controlled or a non-randomized trial, you start from low, you can either go down or you can move up if the evidence goes. So this is the basic principle of grading every study, whether it is a randomized or a non-randomized trial. We can, so someone is at 4, you can grade by a maximum of 3. You cannot go to 0, you can go to 1. This is one thing. For a single outcome, you can reduce by 2, not more than 2. So these are the 2 principles. Can we upgrade? Yes, for non-randomized trials, we can upgrade if there is a very large effect. You are finding a dose-response relationship which is there, or you can answer all the conflicting evidence which were associated with the concerned outcomes. So this is the gist of how you rate in grade, which can be high quality, which are 4 stars or 4 direct sums, moderate quality, 3 stars or 3 direct sums, low quality, and very low quality. What do they actually mean? They mean that further research is very unlikely to change our confidence in the estimate of effect. So something which comes up with a very high quality, you do not need to spend money on it. Sponsors do not need to invest more on it. Government can make a policy and go ahead and apply this directly to the population in terms of their policies. So risk of bias has been taken up nicely. Coming on to inconsistency, or commonly known as heterogeneity. it is any kind of variability among studies in a systematic review. We can have three types of heterogeneity: clinical, methodological, and statistical. More often we are dealing with the statistical heterogeneity. The most important thing is overlap of confidence intervals. You can apply the statistical tests, but the eyeballing method is one of the methods which are very, very crucial and important. We can rate down for inconsistency. Why? We'll see in the next slides. Heterogeneity can be graded as 0 to 40, 30 to 60 which is moderate, 50 to 90 substantial, and 75 to 100 as considerable heterogeneity. This is as per Cochrane. So if you see these two graphs, just focus on two things. The line of null effect has nothing to do with heterogeneity. Okay, it is only about the overlap of studies. Okay, the line of null effect has to do with the precision of the study, how significant the results are. So if these are overlapping, irrespective of the fact that their final or the pooled estimate is not significant, there is no heterogeneity. So I suppose the message is clear. Here there is heterogeneity, and the pooled effect is also on the line of null effect. So this is an equivocal evidence, positive as well as negative. Come on to this thing. So any thoughts on this? Heterogeneity is there, it is positive. So if you compare with this thing, so heterogeneity has nothing to do with whether it is statistically significant or not. Okay. So we can deal with heterogeneity. It is based on either a fixed effect or a random effect model. What difference does it make? I'll show you. When you're using a random effect model, the pooled estimates are wider, while in a fixed effect model, the pooled estimates are narrower. Indirectness has to do whether you are comparing apples with apples, oranges with oranges. With imprecision, the most important part is, if there is imprecision, how imprecise it is. You can set your own minimal important difference, and based on that difference, you can decide, like red one for the adverse events, this one for the clinical effect. So you can say that this was clinically effective up to definitely clinically ineffective. So this is the principle of MID, which looks at the magnitude as well as the direction. So just a slide on funnel plot, which gives you the 95% confidence intervals in a different form. And our interest is whether the small study effect is present or not. I'll give you few examples of translation. So there's just two examples. The first one is corticosteroids for managing tuberculous meningitis. How we are moving from evidence to the development of guideline in terms of decision making as well as policy. So this was published. It showed that we were very certain about the effect. What happened? In clinical practice, now it became a routine to prescribe in a infection corticosteroids. Fine. Healthcare policy, WHO incorporated the same into their regime. Research gap was identified that it is in HIV negative people, we need to look at the evidence in HIV positive people. So the last evidence we have, primaquine for preventing relapse in people with Plasmodium vivax malaria. We had evidence which was moderate. What happened? Not everyone was following the WHO regime. So it confirmed that you have to go ahead with a 14-day primaquine regime after a chloroquine regime for 3 days, and that is how it has to go. The healthcare policies, if you are going ahead with other regimes, this is a waste of resources and probably you are promoting primaquine resistance. That should not be done. What are the research gaps? We require further trials if we want to reduce the days from 14 to either 7, 5 or 3. So this is the concept behind moving from the evidence, grading the certainty, healthcare personnel and policy. Okay, so this is how you can grade them. To conclude, if there is heterogeneity, explore, do not ignore. A conscious decision whether a meta-analysis is justified needs to be taken. If there is, severe heterogeneity, you would not like to go ahead with a meta-analysis. Go do a subgroup analysis, go ahead with sensitivity analysis. If possible, you want to do a meta-regression, you can do that. Then GREAT framework principally utilizes 5 domains. A high methodological rigor and reduced bias makes GREAT framework the foremost choice to assess the certainty of evidence. Thank you.
Thank you, sir. Any question? Yes, sir. Question.
So that actually depends on if you have already gone ahead. If it is about Prospero, in Prospero, if you are going back, then you should not have gone ahead starting your study, should not have started. They only allow till the time you can make the changes only till the time you have not started your study. So either you will have to declare you did not start, you were only, just as we perform a scope or a screening of the initial studies, you can do that. But ideally it is not allowed.
So we have to stick to the 1 arm.
Yes, until otherwise proved, yes. But if you want to change, you can do this in Cochrane. You can write them back, you can get the protocol changed, you can restart the study. But if you want to go ahead with Prospero, for Cochrane you do not require a Prospero registration. For the non-Cochrane you require a Prospero registration. Now Prospero people are extremely strict. They are not allowing you to make the changes.
So
yeah.
Can we include like 3-arm studies also in single-arm studies?
That is not an issue. You will have to define why you are doing this thing, and you will have to extract them specifically as 2 parallel arms. You are not doing a network. Okay. Until unless you are doing a network, that is allowed. If you are not doing a network, that should be made as a parallel or a pairwise comparison. So A, B, A, C and B, C. So that would not be 2 extractions. That will be 3 rows of separate extractions. This is the only thing that you need to remember.
Yeah. Sir, regarding heterogeneity, which systematic review is supposed to be? If systematic review is saying that heterogeneity is 0.75 and another is saying 0.95, so which systematic review has more confidence?
That you have to see. Heterogeneity, if you can explain heterogeneity, that heterogeneity, suppose you have a study like in the tuberculous meningitis study, there was the downgrading was done because they had included children as well as adults in the overall analysis. But when they separated the group, the heterogeneity was taken care of and it drastically reduced down. So you need to explain if the heterogeneity is high, so the confidence in the evidence will go down. Yes, ma'am. तो हिट्रोजेनिटी वहीं रहेगी. आप भले रैंडम मॉडल लगाओ या फिक्स मॉडल, इससे हिट्रोजेनिटी कभी नहीं चेंज होती. आप कभी भी उसको करिए, हिट्रोजेनिटी विल स्टे द सेम, क्योंकि तो प्राइमरी स्टडी से डिराइव्ड है ना. सो इट विल स्टे द सेम. बट इफ यू कैन एक्सप्लेन दैट इज द मोस्ट इंपॉर्टेंट थिंग. So if the heterogeneity is high and if it is 90%, so that is into the considerable part, you'll have to step it down by 1 level.
Thank you, sir. Now I would like to invite our Professor Anju ma'am to facilitate our speakers. First I would like to call Dr. Balendra. next, Dr. Neeraj Kumar. Professor Hardeep, sir. Myself.
I will request Dr. Anju ma'am to felicitate Dr. Dr. Raghuvar. Dr. Raghuvar to please felicitate Dr. Anju Sinha ma'am.
Thank you. This was a very nicely done. Really, I hope the audience also liked